warm water, I should go up little bit, it is going up. So depending upon the lesions we have to see. This is a midbrain lesion. I will PGs can check later. Now what happened in metabolic encephalopathy? Metabolic encephalopathy, though patient is in coma, all his oculocephalic response and caloric response are normal. This is motor system examination. Should I continue, sir? It is lost, sir. He is there, sir. Huh? So motor system examination, we know decorticate and decerebrate posterior. Most important is that here all we have plantar flexion. But here this is the one upper limb will establish us to differentiate between whether it is decorticate posterior or decerebrate posterior. Then there we have to see. Now coma scales. Traumatic we know GCS, but we should know about 4 score, which is more important. Other scores AVQ and ACD. And CRS-R is the revised score, which is the best, but it is time taking. Glasgow coma scale. Now 4 score. 4 score is very important. It includes eye, motor, brainstem, and respiratory. In what I think, in eyelids open, I think you can read it. That is very important because this score is not affected by sedation and it can be done even in intubated cases. There is no verbal response. And for every 1 point improvement in the 4 score, mortality decreases by 15%. This is my PG doing actually.
Check this.
Now, coma and brain herniation, you know all the 6 types of the brain herniation. That is uncal herniation, central, cingulate, transcranial, tonsillar, and tendoral 6. And then some signs of uncal herniation, early third now. So based on the whatever the initial slides, we need to assess. If it is early third herniation, we see the respiration pattern is normal, but pupils will be affected right side. So if the signs of herniation take late third now stage in the uncal herniation, neurogenic hyperventilation will be the addition point you have to see, or chain stocks breathing. And patient can have decorticate or decerebrate posterior. Now some sedative and paralytic agent, midazolam infusion, can produce pinpoint pupil we need to aware of. Paralytic agent, buprenorphine does not affect the pupil. Hypnotics like histamine causes hemorrhage. And dextromethorphan, which is a alpha-2 receptor agonist, causes sedation, amnesia, and mild analgesia without respiratory depression. Is better for sedation. Patient can be aroused without need for discontinuation of drug infusion. And propofol, it considers the pupil. Strong sedation. Differential diagnosis of coma, traumatic and non-traumatic. It can be structural or non-structural. Now helpful lab studies, basic blood investigations. Other tests are the ECG, echo, EEG, neuroimaging, EVO potential, and ICP monitoring. And the prognosis in the case of coma, usually traumatic coma does well. Consciousness is improved in the later as compared to the non-traumatic coma. This is the flash showing the adults and the children. Now last is the brain death. I made a code of ABC. ABC is apnea test, brainstem reflex, and coma. Apnea test will be positive, brainstem reflex will be absent, and coma. All declared in the absence of reversible cause of CNS depression, especially hypothermia, hypoglycemia, hyponatremia, and other conditions. And these are the mandatory tests asked for 2019 American Academy of Neurology guidelines. And ancillary test to do EEG, now electrocardiography silence, and in EEG, retro are the ancillary test. If the patient doesn't fit into mandatory test, then only ancillary test is indicated. With single discrete ABC, we can diagnose brain death. So just for the PGs, apnea test, disconnect from the ventilator, connect to 100% oxygen, that is 6 liters per minute, be for 10 minutes, through catheter, pass through ET, reaching the carina. And during this time, one should see the respiratory drive and the wait for 10 minutes and check the PCO. If the PCO is more than 60 millimeter or there is a difference of 20 millimeter from the baseline, so apnea test is possible. While doing the study, if the BP falls below 90 millimeter, then you are going to stop apnea test. And this is recent advances. FTG patient patient will gain the empty skull side. And take home message to use 4 score in patient with neurological non-traumatic coma, paramedial midbrain and dorsolateral pons lesion cause coma, respiratory pattern are affected in brainstem lesion, from evaluation of case of coma that flew to localization, and dorsal movement and caloric test are normal in coma due to metabolic encephalopathy, decortical posterior and single test that assess integrity of cerebellum and brainstem is ocular motility or oculocephalic reflex. Thank you for patient listening. It's a vast topic, sir.
Yeah, that was a wonderful talk, but because of lack of time, we have
అంతే.
Thank you. Any questions are allowed? Otherwise, I just wanted to, if I can ask that question, what are the bath salts which can cause coma? What are you mentioned some bath salts can cause coma? I was just interested in knowing which bath salts can cause coma.
No, no, madam.
You said
Yes, madam, bath salts. Just it is mentioned in that bath salts can produce coma, that's it. Bradley.
I'll just take a 1 minute, madam. Since coma academically is like heart failure. See, the cardiologist, heart failure, nobody is interested now. They don't even put the step, they directly put the probe and look at the heart and directly put this catheter. That's what he's doing. The same thing for all of us. We are not doing all this total elaborate clinical examination. Even if the brain death confirmation test, for example, we are asked to go for brain death confirmation, I'm not doing this all those reflexes, corneal conjunctival, any gag, this caloric test, nothing I'm doing. Because we all know, already MRI is done. So the empty skull sign is already seen. So then we're directly going to the apnea test. That's where we are now. So I think where we stand in this examination, we don't know. So nobody is going through this, the students, but still students are having their gadgets at home, in their hands. Right now, where it stands in the future academics, I don't know.
the clinical neurologist, the only thing, nothing can replace clinical neurologist.
I know, madam, but especially for the coma, by the time we went there, already MRI is with you.
No, the neurologist starts when the MRI is normal. So once you have the MRI, you can call the neurologist.
Even if the MRI is normal, we have other things. EEG is there. There is no already suppressed EEG. That's what I just wanted to comment. Thank you.
Thank you.
I'd like to invite Javeen ma'am to congratulate Sandhya ma'am for an excellent talk on coma and hand over the bouquet and memento to her. Recurrent glioma. I'd like to invite the chairperson, Dr. T.V.R.K. Murthy sir, a senior consultant neurosurgeon, Care Hospital, who is an eminent neurosurgeon and a great academician who has trained a vast number of neurosurgeons. A warm welcome to sir.
Thank you. Now, probably we are shifting from a normal MRI to an abnormal MRI. I read with this as it come and then we can start. Before you start, Vijay, one thing, actually your topic and my topic are unique neurosurgical topics. Andaru egasparty vaadu unnaru ikkada.
Yeah, thank you, sir. Good morning to all. Respected Chair, distinguished delegates, friends, senior colleagues, junior colleagues, residents, ladies and gentlemen. Today my topic is on recurrent glioma. Of course, first topic after 2 exhaustive sessions, one on anti-epileptics and another one is on coma. Of course, Madam said her aim is not to, but my aim of my talk is not to confuse my residents, right? So, yeah. So, in the career of a neurosurgeon, the 2 most important diseases which require your diligence to manage, one in the brain, that is a recurrent glioma. In the spine, it is malignant metastasis of the spine. The 2 conditions which make neurosurgeon a wise man rather a knife man, right? So, sir? Philosopher, yeah. As far as recurrent, I'll be talking on recurrent glioma or GBM, more or less synonymous. It's an inevitable event. Eventually, patient is going to die. There is no clear-cut management guidelines given anywhere as far as recurrent glioma is concerned. That's how you tend to manage the cases as per the case-based treatments. And it is supposed to be the most malignant tumor, which comprises around 1/5 of intracranial tumor. So you have to know each and every point about the gliomas. So recurrent glioblastoma, the facts are mean duration of survival is around 1 to 1.5 years. It has been the same since 1970s. There's not much improvement in the survival rates as far as glioma is concerned because of the single fact that the main obstacle for the treatment options are the blood-brain barrier. There's Scott's law of 2, where Scott's law says that 2.2% of people have survived beyond 2 years as far as glioblastoma is concerned, and 5-year survival rates around in the terms of 10% in glioblastoma, whereas it increases further as the grade comes down. But their long-term survivors have been reported. What is the cause? So what is the definition of recurrent glioma? There is no clear-cut definition given, and some people call it as a new disease, some people call it as a short disease, and there are various institutes follow their own philosophical modes of treatment to treat these lesions. And there are some regional differences in the behavior of the lesion because the frontal lesion behaves differently than the midline lesion, that is thalamic lesion. That's how the tumors, they behave very differently depending on the region, depending on the type. There's a reason there's no clear-cut guidelines given for this. That's the reason Srikanth Reddy has given this very difficult topic. So where does it recur? The most often it recurs within the tumor bed and followed by 2 to 3 centimeters away from the edge. Sometimes it will be multiple recurrences all over the brain parenchyma, and sometimes it can be intraventricular or it may be disseminated all through the neuraxis. These 5th and 6th, the intraventricular and disseminated modes are more often seen in those lesions which are midline in location. Basically, you have 2 types of recurrences. One is angiogenic, which is like a typical laddu for a typical neurosurgeon, which is focal, which has perilesional edema, has mass effect, and requires a cytoreduction because you have a clear-cut lesion at one particular point of brain, and it enhances brilliantly on the contrast. The opposite is invasive variety, which is something like Ramu, Somu in the childhood stories. One is a good boy, one is a bad boy. So multifocal, less edema, minimal mass effect, visualized only on flare, and the role of a neurosurgeon is to obtain a biopsy for further management of the lesions. What is the morphology of invasion? One, it spreads underneath the fire. Sometimes it can go through the perivascular areas, and sometimes it spreads through the tracts, the fronto-occipital, frontotemporal, temporo-occipital, and none of that lesion will spread either by lymphatics or hematogenous spread, as you see in the systemic cancers. So, when do you call it as a recurrence? Is when you find a separate mass from the original bed, there is no dispute at all, and sometimes there may be growth in the residual, or you consider a recurrent disease when there are onset of new clinical symptoms and signs. So, how did radiologists define the recurrence? They define the recurrence as the appearance of new lesion elsewhere, that's away from the tumor site, or if there is a 1/4 increase in the tumor volume by MRI, or if there is a contrast enhancement by 25%, and if there is more than half of the increase in the tumor size between the 2 successive imaging, that is. So when do you suspect? One, when you find a new lesions while you do MRI images over a period of time, or when patient develops new signs and symptoms. That's how you suspect the presence of recurrent glioma or glioblastoma. What are the symptoms of recurrent GBM or glioma? You have fatigue, future uncertainty, pain, motor deficits, decrease in the sensorium, motor communication difficulty, headaches, and visual field defects. As far as first fatigue is concerned, it is a confounding variable to the steroid. Most of the patients are on steroids, most of the patients on steroids tend to have a fatigue, so that can be confused with the recurrent glioma or recurrent glioblastoma, or future uncertainties of pain is not specific to brain tumor. Any patient with the malignant tumor tend to get this. And other deficits like motor deficits, drowsiness, aphasia, headache, visual field defects are proportional to the malignancy, aggressiveness of the tumor. The GBM tends to have a aggressive symptoms and signs versus the low-grade tumors. So long-term survivors, there was a question why some people are surviving long. There was a study done by people entirely attributed this long-term survivorship because of the histology. So it has taken 52 GBM slides and they have resubmitted to the pathologists to look into why these people have survived long. So of this 52 GBM slides, the second pathologist found 25% of them were to be anaplastic oligos and 10% anaplastic oligoastros and 3% anaplastic. They were overdiagnosed as GBM and later on they found that they are not glioblastomas but there are something else. There are some other histological component which made the patient to survive long. So that was the era where the entire clinical survivorship was based on the histological module. So what's the ideal imaging to image recurrent glioma? It should tell us about the size of the recurrence and also not only the tumor, it should tell us the portion of the tumor which is necrotic in nature and nature of the recurrence. It should be able to tell us the therapeutic efficiency of previous treatments, and also it should aid us deciding the therapeutic modality, whether you require stereotaxy or you require open biopsy or you require stereotactic radiosurgery, etc., etc., etc. There is something like pseudoprogression, which is secondary to the radiation-induced, whose pathology is ischemia and necrosis, and often it is seen in the patients who has MGMT positive and it's associated with long-term survivorship. Basically, you have to differentiate this from the recurrent tumor because it is purely a medical disease which can be managed with the steroids. Often this can be depicted by MR spectroscopy, PET with the functional imaging modalities. So how often you require MRI? As per the guidelines, you require MRI once in 2 months to detect the recurrence in a glioma or glioblastoma. Maybe glioma, you can postpone it further around 3 to 4 months. So, as far as spectroscopy is concerned, all of you know that there are some markers of recurrence where elevated choline creatinine ratio will tell you that this particular entity is a recurrence rather than the radiation necrosis. So perfusion MRI, now people started using a perfusion MRI as a modality to detect the recurrence tumor and try to distinguish it from the radiation necrosis. But as you know, the size doesn't matter, the activity of the lesion that matters. So when you look at the tumor tends to have the cerebral blood flow. The vascularity of tumor is more, whereas the radiation necrosis, the vascularity is less. When cerebral blood volume, which is measured by the gradient ecodynamic susceptibility perfusion MRI, is more than 2.6 ml per gram, that is said to be recurrence. When the cerebral blood volume is less than 0.6 ml per gram, it is said to be radiation necrosis. This is how the vascular permeability is a maximum in the tumor recurrence, where it comes down to 0 in radiation necrosis. PET-CT is a very useful tool to detect the recurrence over the radiation necrosis, which tell you which close of the lesion on the PET-CT, which is a very useful tool. Every case of suspected recurrent glioblastoma or glioma, you tend to get a PET to know the lesion. And types of resections which are in practice range from biopsy, depending on the lesion, to the gross total resections. What are the short-term goals? That basically you can divide them to short-term and long-term goals. The short-term goal is to confirm the recurrence. Basically, whether what you are dealing with is a tumor or radiation necrosis, and the patient is symptomatic. Your idea is to reduce the intracranial pressure. As far as long-term outcomes are concerned, in these patients should always aim at improving in neurological status and improve the efficiency of adjunctive treatment. For example, if there is a large tumor, you try to reduce the size so that other adjunct treatments can be utilized. This is typical. I'll just skip this slide. Basically, this is related to. So, what is the KPS? Karnofsky's performance score is very, very, very important in deciding the treatment for recurrent glioma. So, the cutoff point is 80. What is 70? 70 KPS is said to have, a patient is said to have a 70 KPS when the patient cares for himself, not capable of normal activity. Whereas 80 is normal activity with some difficulty, some symptoms and signs. These are the patients beyond which they are the ideal surgical candidates for recurrent glioma. Where the KPS score is less than 70, better don't touch them because the longevity is going to be very less. SVP in recurrent glioblastoma or glioma, risk is less, can drain fluid efficiently. You can maybe nowadays we have the advantage of having ultrasound. It's a very beautiful tool. It can place the shunts, it can take a biopsy, and the disadvantage is low sample volume. All of you know this, all these things. So the typical case where in the recurrent glioma, where you can drain out the cyst effectively, either with the help of ultrasound or stereotactic aspiration, or by open aspiration. As far as open surgery, you tend to have a good results in those patients who do not have medical comorbidities like diabetes, hypertension, heart failure, etc., etc., etc. And if the lesion is in a non-eloquent location, and if patient has a high functional status where KPS is more than 80 or more than 80. Or you tend to have a bad results in those patients who have a medical comorbidities, or if the lesion is in the eloquent areas, and patient with a poor functional status where the KPS is less than 70 or so. Till date, there is no randomized controlled studies which will demonstrate efficacy of surgery over the other modalities of treatment, but still anecdotal evidence favors the surgical resection. The goals of resection is simple. Whatever you do, there is a modest increment in the survival, and ultimate aim of a surgeon as a neurosurgeon is to increase the quality of life. Without that, if you are not able to increase the quality of life, there is no point in operating on the patient. Same thing holds true with the malignant spine. There, the aim of a neurosurgeon is to improve the leg function. If the patient's power is zero, there is no point in touching the malignant spine. Whereas in this case, if you are not sure of improving the quality of the life of the patient, there is no point in trying to resect the tumor. The small recurrences less than 3 centimeters, you can go for a stereotactic radiotherapy, which is a small procedure, OP procedure, a single fraction of 15 gray can give us 10 months survival advantage. But disadvantages are same as that of other radiotherapy like necrosis, edema, hydrocephalus, radiation toxicity, and that is not suitable for large lesions. Brachytherapy, in the last decade, there is a lot of impetus for the brachytherapy. We used to place some amount of carnosine wafers in the recurrent glioma bed. Initially it worked well, but over a period of time it also has gone to back door because of various issues. And what used to happen when the patient comes back with a recurrent glioma with a solid single lesion, so we used to place a carnosine wafers in the tumor bed. So the survival advantage is protected by the gliadal, so-called gliadal wafer was basically more survival advantage over the non-gliadal patients. But over a period of time, it also did not work out. So ideal patient for the brachytherapy are those patients where there is a confined lesion, a young patient whose age is less than 65, contrast enhancement, supratentorial, and unilateral with KPS more than 70. And brachytherapy is contraindicated for otherwise lesion, like multifocal lesion, corpuscular involvement, and if the ventricle is marsupialized, the treatment is contraindicated. So long-term survivors. So I divided them into 3 factors. One is patient-dependent, tumor-dependent, and treatment-dependent. Of course, treatment-dependent is aggressive treatment, aggressive surgery, radiotherapy, chemotherapy. Tumor-dependent are less than 4 centimeters in size. If you have a Jane cells in the histology, they tend to survive more because Jane cells represent the laziness of the tumor to divide. Oligodendroglial variant, no anaplasia, MGMT mutation, and so-called our gene friends, TP53, MDM2, underexpression, and 19 chromosomal loss. So goals of the treatment recurrent glioma is to tackle the peritoneal edema, seizures, and take care of fatigue, thromboembolism, cognitive dysfunction. Usually steroids are the mainstay of the treatment of the peritoneal edema, but it also has its own negative impact in terms of Cushing's osteoporosis. So some agents which tend to spare the steroids are CRH, Leucizumab, and VEGF inhibitors. Recently, one of my residents has tried to look at the interleukins. So anti-VEGF for glioma, glioblastoma, they tend to reduce the vascularity, reduce the mass spec, reduce exponential growth, but at the same time they have their own side effects of promoting satellosis in the tumor, and they tend to have invasive recurrence, and they tend to have the gliosarcoma as a side effect. Seizures, I think we should send the patients to our neurology colleagues, and sodium valproates found to increase the survival in these patients. Venous thromboembolism, same, and miscellaneous like fatigue, ebulia, memory, depression, neurology colleagues and psychiatric colleagues will take care. And look at this picture, very wonderful picture. I'd like to see that is the glioma tree. The root of the tree is composed by the chromosome 7, 10, 19, and this is augmented mutation. And in surgery, radiotherapy, chemotherapy is only trimming the tree. We are not eradicating the true disease. So this is typical depiction of our philosophy of glioma management. Now recent classification of WHO has really classified them into circumscribed glioma, diffuse gliomas, IDH mutation, IDH wild type, tend to have worse prognosis, and midline gliomas which H3K27 mutation, irrespective of pathology. Even if midline glioma with pilocytic pathology, if it has a H3K27 mutation, patient is certainly going to have a bad outcome. As far as 1p19q correlation in the oligoendoglioma has excellent prognosis. So genetics, now it has been stressed that the genetics is supposed to take more precedence over the surgical resection in terms of predicting overall survival. The typical, chart depicting the pediatric gliomas, where you tend to categorize the low risk location, intermediate, high risk, where in the low risk you have hemispherical, cerebellar, spinal cord, pathology, pilocytic astrocytoma, ganglioglioma, angiocentric glioma, and DNET, GNT, and molecular. These are the low risk molecular mutations, intermediate risk, high risk. So based on the combination of these particular in the terms of location, pathology, and molecular characteristic of the lesion, you have to take a decision in terms of whether to operate or wait and watch, or you have to aggressively manage this lesion. It's very complex based on the each and every case. I don't want to go each and every detail of that. To summarize patient-related factors are the KPS more than 80 and age less than 60, brain-related factors of non-eloquent area lesion, non-infiltrative type, and tumor-related which has a mass hydrocephalus. For example, if patient presents with a hydrocephalus, shunt is an absolutely wonderful tool to prolong the survival. Large cysts, you can drain them. So, adjuncts like SRT, the lesion size is less than 3 centimeters. If it's more than 3 centimeters, resection with brachytherapy. And the conclusions to be considered for the surgery are the KPS. The interval of presentation, patient you operated in 2020, comes back in 2024, they may be ideal candidate for surgery rather than those patients who comes back very early. And markers, if they're good or bad, you have to consider that. And social factors, the acceptability of the family, that also has to be taken. Just because you're a surgeon, you don't go on resecting. And approachability of the lesion is also of paramount importance to determine the resectability. Thank you very much.
Thank you, Vijay. That was an excellent summary of management of gliomas. For the sake of residents here, I would like to just state a point. that when we have operated on a grade 2 or a grade 3 astrocytoma or oligodendroglioma and the patient comes back with a recurrence, then surgery should definitely be considered, because we have to know whether there is any change in the histology of the tumor, whether the grade 2 or grade 3 which we had operated earlier has changed to glioblastoma, because the management pattern will change. But here what Dr. Vijay has mentioned is the patient has been diagnosed with a glioblastoma in the first instance. Then the indications for surgery are there are only one or two specific indications. One is if there is a significant mass effect in the patient, there is a significant new onset deficits because of the lesion. The second is if by imaging, because none of these imagings will be able to tell us very clearly whether it is a radiation necrosis or a pseudoprogression or a recurrence of the tumor. And if on the imaging you are not very sure about whether it is a recurrence, and you have to have a management strategy. So these are the only two indications for surgery in case of a recurrent glioblastoma. So I mean, if there is any other questions or comments by anyone, please. Well, I think the entire audience has perfectly understood what you are saying. Any comments, remarks? Please don't ask me anything. I think the mic, we didn't understand it.
You told us to ask him 3 times question.
Okay, I mean, if there are no other further comments or questions, I think.
I'd like to request TVRK Murthy sir to congratulate Dr. Vijay Sarthi sir, to hand over the memento and bouquet to sir. Now we proceed for a short tea break for 10 minutes, and we'd like to assemble as soon as possible due to the time constraint.
Momentum తీసుకోగా momentum చేసి లైట్స్ ఆన్ ఉన్నాయి బ్యాక్ వచ్చినప్పుడు స్క్రీన్ కనిపించేటప్పుడు దాని
assemble to continue the session. Welcome back to the session after the tea break. The next topic for today is acute vestibular syndrome. I'd like to invite the chairperson, Dr. Rukmini Mridula ma'am, consultant neurologist in City Neuro Center. And the speaker, Dr. T. Vikram Kishore Reddy.
Vikram Kishore, who is a neurologist from Medicover Hospital. Doctor is very important topic.
Hello. Welcome back from the session. Hope you are staying on caffeine. And the content of the topic is diseases. Talking on acute vestibular syndrome. So it is defined as a clinical syndrome of acute onset, continuous vertigo, or dizziness, or unsteadiness, which can last for few hours to days and weeks, and generally includes features suggestive of ongoing vestibular system dysfunction, that is vomiting, nystagmus, and postural instability. So to approach any clinical syndrome, we need to be very sure on the history. So because there are a lot of terms like dizziness, vertigo, unsteadiness, presyncope, syncope, lightheadedness, we need to take the history properly so that we need to put that exact history into that context. So description of symptoms is very important along with the onset, duration, triggers of the symptoms, and then associated symptoms which are associated. Then we need to find out whether it is true vertigo or dizziness or syncope. Then rule out the non-vestibular causes. Based on the history, we need to categorize whether it is a spontaneous vertigo or dizziness, or triggered, whether it is episodic or continuous, or is it a first ever attack or recurrent in the past. So to describe these 5 terminologies, dizziness is a sensation of disturbed or impaired spatial orientation without a false or distorted sense of motion. Presyncope is a sensation of impending loss of consciousness, which may or may not be followed by syncope. Whereas syncope is transient loss of consciousness due to transient global cerebral hypoperfusion, characterized by rapid onset, short duration, complete recovery, and usually leads to loss of postural control and fall. Whereas vertigo is the sensation of self-motion, it is head or body, when no self-motion is occurring, or the sensation of distorted self-motion during an otherwise normal head movement. Whereas unsteadiness is feeling of instability or while seated, walking or standing without a particular direction preference. So when you come to the duration and the frequency of attacks, these vestibular symptoms or the dizziness and all these things are categorized into multiple disorders. If the symptoms last for a few seconds, then we need to think of vestibular parasomnia. If it is from seconds to minutes, we need to think of positional vertigo, or sometimes vertebrovascular TIAs, or vestibular migraine. And if it lasts for more than hours, we need to think of Meniere's disease, labyrinthitis, vestibular neuritis, ischemic stroke. So if the associated symptoms like patient is complaining of tinnitus, hearing loss, along with dizziness or vertigo, we need to think of pituitary infarct. And if there is an aura fullness with fluctuating hearing loss, associated falls with tinnitus, think of Meniere's. If it is associated with headache, with phonophobia, photophobia, and motion sensitivity, we need to think of vestibular migraine. And if patient with vertigo complains of the 3 Ds, that is diplopia, dysarthria, and dysphagia, we need to think of brainstem stroke. So we need to rule out the non-vestibular causes, which are non-neurological reasons mostly. The orthostatic hypotension, which can be just diagnosed by bedside test of falling blood pressure more than 20/10. And then syncope. We need to rule out arrhythmias because they are the common causes of non-vestibular giddiness. And then drugs and toxins, recently introduced antidepressants or gabapentinoids, or sometimes alcohol, carbon monoxide poisonings, and metabolic reasons like hypoglycemia, hyperglycemia, hyponatremia. All these are non-vestibular causes of disease. Then theme of examination is look for general signs, and then blood pressure monitoring to rule out orthostatic hypotension, variation in the heart rate to rule out postural orthostatic tachycardia syndrome, hearing assessment, which we often neglect at bedside, which can be done by simply rubbing the nail bed to assess the hearing loss because it has some clinical value. And then neurological exam with more emphasis on extraocular movement examination and VOR examination. The vestibular spinal reflexes, examining the stance and all those things. Diagnostic positional manuals when you don't get a reason why the patient is having dizziness in spite of all the normal neurological examination. So this is an ocular tilt reaction which we can observe in the general examination where the head of the patient would be tilt on one side, and it is a triad of skew deviation, head tilt, and ocular counter. And these are attributed to a unilateral lesion of graviceptive pathways arising from the uterus. So here the head is tilted towards the right side, then the right eye is hypotropic, it is in the lower side, and left is little higher side. And when you see the fundus, there is cyclotorsion of the fundus. So as the graviceptive pathways arise from labyrinth and crossing the pons, this has a clinical localization value that if the tilt is on the same side, ipsilateral, then we will think of vestibular lesion, and the tilt happened in the opposite side if the lesion is the pontomesencephalic lesion. Then skew deviation, it results from dysfunction of graviceptive pathways in a patient with vestibular syndrome, leading to vertical diplopia due to vertical ocular malalignment. So predominantly seen in central lesions, and even sometimes in peripheral lesions can be seen, but with a smaller amplitude. Sometimes we tend to miss on clinical examination, so there are no gadgets available like VOR or even this VNG machines where we can exactly notify the skew deviation. So just a simple bedside test like cover and cover test. You cover one eye and then immediately look to the other eye. If there is no deviation of the eye, then it indicates normal. Whereas in a skew, there will be just movement of the eyeball upper or downward when the eye is uncovered. Then coming to the ocular motor examination, we need to look all the extraocular movements in all the images, saccades, pursuits, and the verges. The next most important is look for a nystagmus because this gives a lot of information. So initially we look for a spontaneous nystagmus in a normal gaze. Then we need to suppress the visual fixation by asking to fix on a torchlight or using a VNG goggle. Then look for extreme gaze to note gaze about nystagmus. And if you don't find any nystagmus on the routine examination, we also go for diagnostic positioning manuals where you can appreciate the nystagmus in cases of benign paroxysmal positional vertigo. So vestibular vertigo is often associated with spontaneous nystagmus, that is nystagmus noted in a primary gaze. So it gives rise to torsional horizontal nystagmus which beats away from the lesion here, and it is unidirectional and maximal in the direction of the first phase, which is called an Alexander law, and it suppresses with the visual fixation. So So to ensure that spontaneous nystagmus is not missed, we also need to do visual fixation suppression by either using a Frenzel gases or using a pen-like test. So this is a unidirectional vestibular nystagmus which increases in amplitude and the duration in the direction of fast phase, and it is always unidirectional. Even if the in primary case if it is left beating, it will be left beating, and even in the left case it will be left beating, and even in the right case also it will be left beating. So there won't be any change in the direction of the fast component with change in the gaze. So that is really characteristic of a peripheral vestibular lesion, and the lesion would be opposite to that of the fast phasing direction. So if you see, there is mild right beating nystagmus. That is more on the right gaze. Where is that? And the typical central nystagmus would be bidirectional, that is, it changes the direction on gaze. Or if it is a vertical nystagmus, it is mostly a central nystagmus. Or purely torsional. If it is horizontal torsional, that can be a peripheral or central. In central, it will be direction will be changing with gaze. So typical peripheral nystagmus, that is horizontal torsional, is unidirectional, whereas the central would be direction changing. When you see towards the right, the nystagmus is more on the right side, the fast phase. When you see on the left, it is more beating towards the face. It is changing the direction with the gaze. And once you do not get any diagnosis on the routine neurological examination, you go for the positional in manuals like Salpike and supine roll test. In Salpike, if the torsional nystagmus happens with the upper pole of the eyes leading towards the lower ear, so that indicates that the posterior canal BPPV is there. And if in supine roll test, if it is a pupillolithiasis mechanism, then it will be apogeotropic direction changing nystagmus. And canulolithiasis, there is geotropic direction changing nystagmus. Then there is, if you don't get any nystagmus on routine examination, we also can offer a head shaking nystagmus when demonstrates the dynamic vestibular function. Patient head is slightly bent forward to align the horizontal canals with the horizontal, and head is shaken in yaw plane 2 per second, approximately 10 to 20 times. Normal patients can have 1 to 2 beats, or they don't demonstrate any nystagmus. If there is any unilateral vestibular nystagmus, which is beating to the intact ear, and it may reverse thereafter is vestibular lesion nystagmus. Whereas in central pathology, the nystagmus will be there in a plane other than the head oscillation, which is called perverted head shaking nystagmus. Which is that if patient is moved in a horizontal direction, there will be vertical nystagmus in central lesions. The most important test is like head impulse test, which if you do in a comatose patient, just like Sandhya madam just like to know the brainstem reflexes. This is done in a conscious patient. It is to assess the integrity of horizontal vestibular ocular reflex. So when BOR is intact, each eye movement is associated with an equal and opposite eye movement, thus maintaining the visual fixation on the target. When it is impaired, there will be correction saccades to catch up that lesion. So if you see in this patient, so there is a corrective saccade when the head is moved towards the left side. 1 to 2 beats to achieve the visual fixation on the target. So this indicates the site of lesion on the left side. The same patient had a right beating nystagmus in the earlier. So, and this other patient. This actually is taken in a slow motion. So there is corrective surprise from the. This patient had bilateral vestibulopathy. Two sides view are both impaired. Coming to the vestibulospinal reflexes, because we need vision, proprioception, and vestibulospinal contribution to enable upright stance and then gait. So if any of these are impaired, then patient can have ataxia. So as a routine examination, we do patient ask them to stand with feet apart and feet close together and eyes closed, the Trombone's test. If he stays on that, it is mostly a proprioception problem. If he stays with eyes open, then it looks like more of cerebellar. There is something called a sensory denial method, where the patient is asked to stand on a 20 centimeter thick cushion. So thereby the proprioception contribution for the balance is nullified. Then the patient whole and soul depends on the vestibulospinal pathways for his balance. So if a patient sways with eyes closed, standing feet close together on 20 centimeter thick foam cushion, and if he sways, then that indicates the vestibular dysfunction, unilateral vestibular malfunction or hypofunction of that side. And in patients with bilateral vestibulopathy, they tend to sway on both the sides. So when you put all these together findings, then they come up with a protocol called HINTS, HINTS plus and HINTS plus plus. HINTS plus stands for head impulse, nystagmus and test for skew, whereas HINTS plus stands for HINTS along with hearing loss, which can be assessed on the bedside with a simple finger method. And if head shaking nystagmus is added to that, then it is HINTS plus plus. So what they have found is, like for central causes, HINTS is 96.8% sensitive and 98.5 specific compared with 14.3 false negative MRI in first 48 hours, that is diffusion weighted imaging. So this is more sensitive and specific to localize the central causes. So the mnemonic is like dangerous HINTS is INFA, where IN stands for impulse, head impulse normal, fast phase alternating nystagmus, which is direction changing, and refixation on cover test, which is like positive for skew deviation. Then they have come up with another clinical finding, that is truncal ataxia. So they have graded truncal ataxia into 3 grades. One is mild to moderate imbalance with walking independently. 2 is severe imbalance with standing but cannot walk without support. 3 is falling at upright posture. So they have noticed 2 and 3 as a more clinical pointer towards central cause of stroke. So the ataxia rating alone had a sensitivity of 92.9% and was easier to perform reliably compared with the HINTS. So they have even found ABCD score as also one of the clinical assessment or historical assessment to categorize patients as central lesion causing the acute vestibular syndrome. They come up with a statement called like HINTS plus combined with ataxia assessment and vascular risk factor like ABCD2. Stroke assessment missing is almost nil. Then the various causes of acute vestibular syndrome, if you divide into spontaneous and trigger. Trigger is like you have some initiating or triggering factor leading to the vestibular symptoms, that is trauma, mild traumatic brain injury or barotrauma, and then toxins like carbon monoxide, illicit drugs, medications like aminoplastics, anti-epileptics, phenytoin, and then substance abuses. And even alcohol intoxication can cause, whereas the central causes, it's posterior circulation stroke, vernix encephalopathy, demyelinating disorders. In peripheral, it is vestibular neuritis, labyrinthitis, first episode of menials and first episode of vestibular migraine. Just a brief note on vestibular neuritis. The characteristic pattern is nystagmus is unilateral, like unidirectional nystagmus. spontaneous nystagmus, which worsens with visual fixation, with impaired VOR, with normal skips. Most commonly involved is the superior vestibular nerve. Most likely it is post-viral etiology. And steroids can be used, and vestibular rehabilitation improves the compensation, thereby reducing symptoms. Then there are the 4 dizziness central syndrome, that is stroke syndromes, like triggered episodic vascular syndrome or spontaneous episodic vascular syndrome, triggered acute vestibular syndrome or spontaneous acute vestibular syndrome. An important note on this transient ischemic attack, like isolated dizziness or vertigo presenting as stroke. It is very uncommon, but again should not be missed in a context if patient is having isolated vertigo without any triggers, negative neurological examination, negative positioning manuals, short lasting. We need to do the vascular imaging, then identify it as a TA of posterior circulation and start an antiplatelets. Then vestibular migraine, at least 5 episodes, the current or past history of migraine with or without RF. Vestibular symptoms of moderate or severe intensity lasting for 5 minutes to 72 hours. Then 50% of episodes are associated with migraine features. Then menias is episodes of vertigo lasting from 20 minutes to 12 hours with documentation of sensory neural hearing loss with fluctuating oral symptoms, hearing, tinnitus or fullness in the affected ear. So to summarize, we need to categorize the symptomatology into is it a vertigo, is it dizziness, unsteadiness or syncope. Then rule out all the non-vestibular causes in emergencies like hypoglycemia, hyperglycemia, hyponatremia, then cardiac causes, syncope, pre-syncope. Then interpret nystagmus in the form of spontaneous gaze evoke, and also do visual fixation suppression so that to enhance the spontaneous nystagmus. For all patients, we can apply HINTS plus and HINTS plus ataxia protocol in patients who are presenting to the emergency. Then note on TAA where episodic vertigo with vascular risk factors and normal examination, detailed examination, need to think of TAA, do vascular imaging and then start an antiplatelets. Do not forget about vestibular migraine and then Meniere's disease and BPP as the differentials. Thank you.
It was a very nice, brief and succinct approach. I now open it for questions. Can I just ask you one question? So what do you think about the antiplatelets? I think they come sometimes worse than
Antiplatelets. First dose effect.
Sometimes, so do you have any preference for some patients?
No.
So they don't take it right away?
No. Whether it is a causative or totally associated.
You said acute vestibular syndrome is when it's more than 24 hours.
Yes.
But thereby you are excluding most of these syndromes, menial disease.
Yes, sir, but patient comes even before 24 hours to the clinical emergency department. So we need to rule out even before that, the findings.
What is the purpose of having a definition?
No, that definition is purely for differentiating between stroke and then vestibular neuritis most of the times. But these are like not to be missed when patient comes to an emergency department. Like if patient has dizziness for 3 hours, then if he comes to an emergency department, then we need to think other causes. Even if the HINTS is negative, normal neurological examination is negative, we need to think whether it is vestibular migraine first episode or Meniere's first episode, because Meniere's can last for 12 hours. So it depends on patient presenting. But acute vestibular syndrome, by definition, it includes mostly those demyelinating disorders, central causes, demyelinating disorders, then strokes, and then Wernicke's encephalopathy, and the peripheral things are labyrinthitis and then vestibular neuritis.
some of these BPPV or venous disease, with inadequate compensation, they will continue to be there more than 24 hours or more than 1 week also.
Yes, sir. But again, in that history is more important. So there is something called trigger associated. If typical vertigo symptoms happen only during the position change, on turning on bed or getting up from sitting position, only during that position, that indicates more of the BPPV. The other vestibular neuritis or stroke, those also can worsen the symptoms when they change the position.
Yes, yes.
But it's not like only during that position.
Actually, I was coming to that. The positional change can be there in many other symptoms.
Yes. But it is whether it is only triggered with that, we need to it is BPPV definitely. If it is not triggered, if it is worsened with the posture, then we need to think of other problems. Because in typical BPPV, we don't get vertigo continuously. It is very short lasting and happens only during position change.
Most importantly, the patient who is able to walk better, going to the toilet and coming out and able to perform the activities of daily living. It's not a stroke.
Yes.
If somebody, if somebody is the peripheral vertigo,
yes,
definitely can, after getting up, if the acute episode is over,
yes,
in a few hours later, after 24 hours, within 24 hours, they can definitely go and perform their activities. But in stroke, they cannot walk. If it is really in the cerebellum, midline, or something, definitely there will be wobbling, unsteadiness, ataxia will be there. That's a simple differentiating point between the peripheral vertigo and the central vertigo.
No, sir. Even in small cerebral infarcts, they don't have the ataxia. Yes.
Small effect. No.
Yes.
It's the clinching point for you to go for a scan.
Yes. So we have patients who had lateral medullary syndrome, came only with vertigo, mild ataxia. MRI was negative, but still we thrombosed.
In that case, did you do HITS?
That I was not there, sir. It was in night.
That is where HITS is very, very important actually. In a suspected case of acute vertigo, if you are suspecting stroke,
yes,
do HITS. HITS will be positive, it is 100% sensitive,
yes,
MRI can be negative.
yes.
So we have seen patients like that. You should always do a HITS if you are suspecting a posterior circulation stroke, coming as a TIA or acute vertigo. And then I disagree actually with stroke patient not able to walk or not able to go to the washroom and all that. See, many times, they have very, very mild symptoms and then mild sense and clinical examination. And then they usually do their activities, and sometimes what we find in examination will be mild nystagmus and very, very minimal ataxia, and then do the MRI is normal. And then you reassure the patient, send him home, next day comes the massive infarct.
And second thing is hearing assessment bedside. That is also commonly missed in patients with acute vertigo.
Yeah, as a neurosurgeon, would like to know from you what's your philosophy in whiplash?
So whiplash, sir, again, because of concussion injuries, maybe.
What's the guidelines? How long to treat? What's the diagnostic criteria for that? Just history of trauma or any?
Since if you have a patient with whiplash coming with vertigo, there is a
cervical lesion. So you rule out dissection as well, sir. If they have other symptoms as well, it's not only vertigo. If they have the hearing loss, then a territorial infarct is possible.
My point was just to say that somebody who is not able to walk, just to don't brush it off and say it's better.
Yes, sir. That's the reason why they have put that ataxia scoring. If he is not able to stand. Yes. Yes.
Sometimes we do see patients sending back from India.
Yes.
that way, that is when actually these plus actually has made a market difference.
Yes.
It was really very difficult to differentiate between peripheral and central. This means definitely makes market difference in how people differentiate.
And it will take few minutes of examination.
And one more point as addition. In fact, one of the most common cause of so-called short-lasting acute vertigos, especially in elderly, is orthostatic hypotension.
Yes.
We should never miss that orthostatic hypotension. So in patients, especially elderly people, just see their medication and check the blood pressure carefully. And to the PGs here, what is the mechanism for vertigo and orthostatic hypotension? What is the mechanism? Why do they have giddiness when there is a fall in the blood pressure? it labyrinthine hypoperfusion? It is global cortical hypoperfusion. So that is the reason for orthostatic in orthostatic apnea. It's not a labyrinthine hypoperfusion. Thank you. It's an excellent presentation. So actually, in fact, the Vertigo actually is very close to my heart. So I try to learn, understand Vertigo so many times, but was never able to understand it completely. And what's your opinion about Ewald's laws? How helpful they are? Ewald's law 1, law 2, law 3.
Yes, sir. See, again, it again differentiates mostly the peripheral lesions. So, and based on that loss only, these Alexander nystagmus, and these are and nowadays these VNG and VOG, they are making a lot of impact because this this VOR, the head impulse, there can be corrective centers during the movement as well. So that will be missed by a normal clinical examination, and the gain and all those things can be appropriately monitored if you have a VNG machine. We started having VNG machines.
You have stimulation also?
No, not yet. We started recently that VNG machine. That we have to take in slow motion, or else we'll miss that catch-up cycle.
Thank you. Thank you again. It was a really wonderful presentation and good discussion.
Thank you.
And really on time. I mean, less than the 20 minutes that we're supposed to talk. Very
I'd like to request Dr. Rukmini ma'am to facilitate Dr. Vikram Kishore Reddy sir. So the momentum. The next topic for today's session is Parkinson's disease, unresponsive off stage. I request Dr. Y. Muralidhar Reddy sir, consultant neurologist, Care Hospital, to chair the session. Speaker is Dr. Rukmini Mridula.
At the outset, I would like to thank Radhakrishna sir and Dr. Vikram for making me part of this conference. So it is indeed an honor and also a privilege to introduce my teacher, Rukmini madam. She needs no introduction. Currently, she is the senior consultant neurologist and director at the Parkinson's Disease Movement Disorder Research Center, City Neuro Center. She has 110 publications and 20 book chapters, and she is the founding member and executive member of the Movement Disorder Society. Over to you, ma'am.
Thank you, Dr. Murli. And at the onset, I'd like to thank Radhakrishna sir, the Medicover Hospitals and the rest for giving me this opportunity. It is a very interesting topic that has been given, Parkinson's disease, unresponsive off state. So we know that, I mean, I won't go too much into detail about Parkinson's disease. We know that there are a lot of components of Parkinson's disease and all of them are not responsive to medication. So we actually preferably look at the motor aspects and that response to dopamine. The remaining non-motor symptoms have got a lot of other background problems like serotonergic, anticholinergic or noradrenergic dysfunction, and some of them respond to therapies and some of them do not. But I'm just going to focus only on the non-dopaminergic responsive off states in pertaining predominantly to the motor aspects. So the summary of the Movement Disorder Society is when you want to diagnose a patient with Parkinson's disease, you have to establish Parkinsonism with bradykinesia and rigidity, and then you have the clinical criteria, the exclusion criteria and the red flags. So if you look at the absolute exclusion criteria, you will see that there is absence of response to levodopa, which is actually an exclusion criteria. So if you don't have response to levodopa, you don't think that you have got Parkinson's disease. This is to start with. So what do you, so the levodopa responsiveness is very characteristic feature of Parkinson's disease, and it usually lasts for a long time. So this is a patient who I think might have seen for a long time. This is a patient in the off state is completely not able to move. So you can probably see the video. So he's not able to move and he's actually being moved by 3 people because he's got a lot of non-motor symptoms at this point. This is one of the oldest videos of Dr. Rupam, who has been showing these videos for assessment for TBA surgery. This patient had Parkinson's disease at that time of almost 10 years duration, was on levodopa, had undergone a telamotomy in 91 because he had a bad tremor on one side. This is the off state. This is a non-motor component where the patient has got severe restless leg syndrome or an akathisia-like feature where he cannot sit quite. A lot of the Parkinson's disease patient in the off state are like that. They complain of marked discomfort, they need to be moved, they need to go to the bathroom, they need to come back, they keep on getting shifted from one state to the other state, especially in advanced Parkinson's disease. So this is where the patient actually had appointed 3 people to take care of him. So you can see that they're actually trying to move him completely. So almost 17 to 18 hours of the day he was in this state. This was when the medications were not working. This is like an off state. So this is a patient with Parkinson's drug-induced off state. So if you look at the patient when they are kept down, you can see the tremors, which are quite severe. He's in a stoop posture if he's not held on to. And in a minute you will see that when the patient is given levodopa, he is completely normal. And this kind of response is seen irrespective of the duration of the disease. So this is after around 10 to 12 years after the disease onset. You can see the patient is walking quite well. So this is levodopa responsiveness. So when you have an unresponsive off state, so depending upon the unresponsive off state, I have actually divided into 4 groups. One is an acute non-responders, and you can also have chronic non-responders. So these are 2 different categories. If you have chronic non-responders, they can be primary non-responders, means that they are not responding to medication from the beginning, or you can have a secondary non-responder. This one, another patient who is a 71-year-old lady who presented with Parkinson's disease of 14 years. She came with the complaints of altered sensorium, stiffness of all 4 limbs, difficulty in swallowing, and there was a recent reduction in the dose of dopaminergic medication when she was being treated for UTI. I'm just putting this up because this is neurological emergency, and this is one of the most common emergencies that you see in Parkinson's disease. So you can see the patient is completely off rigid. She was drowsy. This was not the worst case time because when she came in, she was very severely, rigid and stiff. She was only opening eyes to painful stimuli, making incomprehensible sound. She had tachycardia. She had temperature of 100 degrees Fahrenheit. Otherwise, she was having a pupils were normal size, reacting to light. This was normal. And all eye movements were present. There was no facial asymmetry, but she was not talking at all. She was completely rigid and immobile. There was generalized rigidity. Tremor was present in the upper limb, and the PTRs were sluggish and neck rigidity was present. So anybody in the audience who say what is this syndrome? So I can't hear you. NMS. NMS or Parkinson's hyperpyrexia syndrome is what we consider. So if you look at the investigation, leukocytosis was there. There was an elevated CPK. The rest of the investigations were normal, and this is patient with Parkinson's disease with Parkinson's hyperpyrexia syndrome. Now the reason why I'm putting this is that these patients don't really respond to levodopa at that particular point. Once they develop this component, NMS or Parkinson's hyperpyrexia syndrome, it takes them a long time to come back to normalcy. So you really have to hike up the medication, or you have to give other medications to make sure that they come back to normal. So this patient was treated with a high dose of levodopa. It was actually, and then was added on amantadine, then was given antihypertensives, antibiotics, and she was started on bromocriptine, 5 mg 3 times a day. Sometimes you may have to give even dantrolene or put them on muscular relaxant if the patient has got severe abnormality. So during the hospital stay, patients started improving. At this period, they're completely rigid, confused, not speaking, cognition is impaired, they cannot swallow, they have marked dysphagia, sometimes they can have respiratory distress. So this is the patient who, so she was not on multiple drugs at the time, she was actually on levodopa, some 3 tablets a day, so they made it to almost 6 to 9, added amantadine, added bromocriptine. It took us 3-4 days for the patient to come back to at least this state when she started developing dyskinesia. So once that comes in, that we are a little more happier. So if you look at NMS and Parkinson's hyperpyrexia syndrome, they are actually the different ends of the spectrum. Neural management syndrome is considered when you are adding the neuroleptic. So that's why the name neural management syndrome. Whereas in Parkinson's hyperpyrexia syndrome, it is basically dopaminergic drug is withdrawn. So this can happen with, you can have the tetrad of mental state changes, hyperthermia, rigidity, and autonomic dysfunction. It can also happen when you add neuroleptics in patients with Parkinson's disease. Commonly, you can have patients who have got psychosis with PD, then the medication is reduced, add a neuroleptic, and then they come in with the Parkinson's hyperpyrexia syndrome. So if you want to look at NMS by itself, the incidence is around 0.01 to 0.02% in all patients exposed to neuroleptics. it is associated most often with typical neurologic agent, and the mortality is around 30%. This Parkinson's hyperparesis syndrome can also happen in post-DBS patients, and this has been well described, especially when you have a patient who's got on B-brain stimulation and suddenly you stop the battery goes off. So the patient becomes completely unresponsive to levodopa. They're just like, even if you increase a dose to markedly, to double or triple time 2000 milligrams of levodopa, they still become, they're completely off, and you have to do emergency battery replacement. We have had patients who have been on the bed, done with a bed sore, done an emergency battery replacement, and the patient has improved dramatically. So you need to, at that point, that's an emergency to do the surgery. So what are the criteria for Parkinson's hyperparesis syndrome? Unfortunately, you have a very specific criteria for NMS, where you have the DSM-4 criteria is given in 2000, and you know that there are various factors which has to be picked up. Parkinson's hyperparesis syndrome is not, it's not, because it is considered as a part of the spectrum of the NMS, they don't have an established criteria, but these are some suggested criteria. So you have to have a clear trigger before the onset of the event. So you should have either reduction or withdrawal of anti-Parkinsonian medication. You should have you can have a battery depletion, a heat wave. This is quite common in patients with Parkinson's disease, and you should be careful about it. Heat wave with high exposure to high temperatures can also precipitate Parkinson's hyperparesis syndrome. You have to have core clinical criteria, which include hyperthermia, worsening Parkinsonism, and elevated CPK. This is very similar to NMS. They also have these three core criteria. Which so instead of saying elevated worsening Parkinsonism, you actually have rigidity in the NMS criteria. At least two of the following clinical manifestations should be present. That is altered sensorium, autonomic dysfunction, diaphoresis, myoclonus, rhabdomyolysis, dystonia, and dehydration. So these are features which should, two of them should be present to consider this patient having Parkinson's hyperparesis syndrome. Alternate diagnosis should be ruled out. If you have a patient with infection, typically should be ruled out. Sometimes you can have serotonin syndrome, where so serotonin syndrome is very similar to NMS and PHS. You need to just keep 2-3 things in your mind. One, if they have GI disturbances, diarrhea as a manifestation, they can have hyperreflexia as a manifestation. So if these are features which are there, then you know that you have serotonin syndrome. The reason why I'm saying serotonin syndrome is a lot of patients are given multiple drugs of SSRIs, and sometimes that can trigger off a serotonin syndrome. And so, especially in a patient who's got on MAO-B inhibitors, the serotonin syndrome can actually get precipitated. Though the current MAO-B inhibitors don't have such a marked change in the serotonin syndrome. What are the complications? You can have dehydration, you can have acute renal failure, you can have all systemic complication, you can have DVT, and obviously sepsis, and the patient, the mortality rate is around 30%. How do you treat the patient? This is an algorithm for neural management syndrome. So you can actually divide it into 4 groups from stage 1 to stage 5. The same kind of picture is there for Parkinson's hyperparesis syndrome. The idea is that you again put the patient back on Parkinsonian medication, give them a very high dose of levodopa, put them on bromocriptine or amantadine. Dantrolene is actually preferred more for NMS than for PHS, but we have given dantrolene for patients with PHS also. And then you treat the other concurrent infection or other systemic abnormalities which the patient has. So prevention is definitely important. And if the patient is not able to take orally, or you think that the oral intake is going to be abnormal, because sometimes the GI uptake may be abnormal. Subcutaneous apomorphine is one of the drugs which can be given at this period to tide over the crisis with Parkinson's hyperparesis syndrome. This is a small study from NIMS in 2017 done by Dr. Pravalika, where we actually looked at both PHS versus NMS, and we saw whether there was any difference between them. There were 8 patients with PHS and 6 patients with NMS. It's a small group because it is a rare emergency. What we looked at was that only the age, the CPK, and the urea value was the major indicators of mortality in patients with either PHS or NMS. There was not much of a difference between the manifestations or the otherwise investigation between the PHS and NMS. Now, coming to the second acute event, where there's just a little bit of refractoriness, or maybe it's a pseudo-refractory Parkinson's disease. So this is something which is important. You should think about what are the other causes why the patient is not getting anyway. So the thing is that you can have drugs which can cause, so the patient may be saying that, okay, suddenly for the last 2-3 days the drug is not getting, I'm not getting on, or I'm just completely staying off. There may be a concurrent infection, the patient may be on antibiotics, which may be involving the absorption of the levodopa. Patient may be on prokinetic agents. Systemic illnesses like thyroid diseases, both hypothyroidism and hyperthyroidism can cause a pseudo-refractory Parkinson's disease. So just remember, if the patient with Parkinson's disease is doing well, suddenly comes with an acute worsening, make sure that you're looking at these systemic illnesses. Renal abnormalities, infections like HIV. If you have a hand, the patient may initially actually be responsive to levodopa, but on the longer term, they may not be responsive to levodopa. So because a lot of times Parkinson's disease is made on a clinical basis without an investigation or an MRI, sometimes you may miss HIV-associated neurodegenerative disorders and neurocognitive disorders. Now the next group is the subacute or the chronic resistance to levodopa. So you can have primary non-responders. As I said, if you have primary non-response to levodopa, you have to think about the diagnosis. Because the clinical criteria itself, exclusion criteria is that you have an absolute non-response to levodopa. But some of the genetic subsets, like say PLATO-G6 or say rapid onset dystonia Parkinson's, may have all the other features of Parkinson's, may have a bit of benefit initially, but they are actually primary non-responders. They may not respond to levodopa. So some of them may have abnormal oral absorption and reduced bioavailability. This is a study which was done recently published in Nature, which they said that some of them may have say an H. pylori infection or an SIBO, which may cause the non-response. Secondly, non-responders are the ones who were responding well and then suddenly they are not responding. Now there is a concept called as super-off syndrome. There is a lot of mystery about it because it is still not proven whether it is there or not. This super-off is when patients come and say, I take the medication, immediately after taking the medication I become off. And after a while it takes me around 45 minutes to 1 hour to become on. So a lot of times you may think that just the off is going on, but that may not be true because they have, this feature has been seen with pergolide or levodopa. When they have taken the medication, they have a worsening of the symptoms. So the reason why they think is that it's probably a presynaptic dopamine receptor which are becoming stimulated, and that reduces the amount of dopamine being released into the synapse. This is one of the pathophysiology which has been described, but we are still not sure about it. I mean, after the initial studies in 90s and 2000, the remaining studies have not really shown any difference in the drop in the markers after taking levodopa. So this can be both beginning of dose or the end dose effect. Motor fluctuations, we know that they have a problem, and then you have progressive unresponsiveness. So motor fluctuations are the ones which you have on off. The efficacy of the levodopa comes down. Now why does the efficacy of the levodopa come down? So one reason is that obviously the levodopa release in the brain is coming down, so obviously the release is progressing, so the efficacy is coming down. There is still a little bit of doubt on why exactly the secondary non-responsiveness occurs, but there are these features which you should think about when there is a secondary non-responsiveness, which seems a little bit more than usual. So one is that the patient may have a gut abnormality, or this is the aromatic acid decarboxylase enzyme, which is inhibited by what medication do we give? I can ask a resident, which medicine would actually inhibit the peripheral decarboxylase enzyme? Sorry, ma? Carbidopa. So the carbidopa, which actually is supposed to inhibit the aromatic acid decarboxylase level, there can be an increased amount of AADC being done in the blood as the disease progresses, and that might be the reason why there may be a non-response. So these are the two factors which are there. Now if you look at GI motility is an abnormality which happens in Parkinson's disease. Levodopa is absorbed in the duodenum and the proximal part of the jejunum. It's a very small area where it gets absorbed. So if you have a GI motility disorder, you can actually have a problem in the levodopa reaching there. You may actually get it may be broken down earlier itself. So you have a proteinaceous food in the stomach, so the absorption goes on. So entire the medication can just stay wherever it is and they may just not get absorbed. The other thing is that if you have H. pylori infection, this H. pylori infection itself can trigger off something called as the small intestinal bacterial overgrowth. This is a common phenomenon which is seen with patients with Parkinson's disease. Actually, it's a very poorly thought of pathophysiology, and we don't know when, it is actually very, very under-recognized. We can actually probably look at these patients, especially those who have got GI symptoms. You should look at whether they have a small intestinal bacterial overgrowth. H. pylori itself can predispose them to small intestinal bacterial overgrowth. Chronic use of PPIs, which is very common in our patients, can also predispose to small intestinal bacterial overgrowth. Reduced GI motility can predispose them to SIBO. So the SIBO increases what is called as the tyrosine decarboxylase production, and this breaks down the levodopa in the small intestine itself. So there is no absorption of the levodopa. This is treatable condition, so obviously you should look at these mechanisms. PPI, I think all of our patients, most of the patients would be on PPI, so I think it's a better idea to go back to them and see whether they really require it or not. So how do you manage the condition? You look for pseudoresistance in 3. H. pylori can be assessed with a breath urea test. You can do an endoscopy and biopsy. If you have H. pylori, treat the H. pylori. We actually did this was a study again done by Dr. Chandrasekhar Reddy, who looked at he took patients who were not responding, looked at them being H. pylori positive, gave them a treatment for 3 weeks. After that, there was improvement. Right now, there's a lot of studies which are going on H. pylori. It is not still very clear whether how much it really makes a difference or not. H. pylori is associated with the pathophysiology of Parkinson's disease itself. It's supposed to cause Parkinson's disease in one way, and also it is supposed to prevent the absorption of medication. So it may be a good option to look at it. SREO, you can use that test, look for various substrate, glucose hydrogen blood test, lactose hydrogen blood test, and you can check for the gut aspirate for culture. Treat it with antibiotics. Rifaximin is supposed to be the best drug of choice currently. Previously, vancomycin was tried, other medications have been tried. Give it for a period of 14 days. If it doesn't improve, then again give another course for another 14 days, and this may actually improve the absorption of the levodopa, so they may become more on in that case. Obviously, if you are going to manage this is another concept. No? So I said just that aromatic acid carboxylase levels are increased in the blood, and this is supposed to be secondary to the use of carbidopa and levodopa. It is supposed to cause an upregulation of the ADC enzymes, and so that's why there may be a secondary resistance. So in these patients, if you think that they're taking too many levodopa carbidopa, addition of a dopamine agonist has seemed to reduce the level of the ADC. So this can be done. So you can actually give a little bit more dopamine agonist and reduce the levodopa carbidopa. Obviously, if none of them is responding, you have to plan for the other therapies like apomorphine or deep brain stimulation surgeries. So these are, if you have advanced PD patients with predictable or unpredictable waning of response or motor fluctuation, we have the Delphi criteria, which is a consensus criteria, where the patient is on 5 tablets of levodopa still has 2 hours or 1 hour of troublesome dyskinesia, plan for a continuous dopamine stimulation. So infusion therapies, all of them are equally efficacious in reducing the motor symptoms. The non-motor symptoms are the ones which becomes a little different. If you have cognitive impairment, if you have a lot of suicidal ideation, it will be better to go for levodopa carbidopa intestinal gel, which costs around 20 lakhs per year. But that is I think it will come down because I think the rates are coming down. Apomorphine costs probably around 50,000 per month. That's around 6 lakhs per year, but people are willing to go for it. I think it will also come down. There are cheaper versions which are coming up. DBS costs around 15 lakhs per 5 years, that's around 3 lakhs per year. So that's how it goes. But the cognitive abnormality, if you have behavioral, age is older, you can plan for subcutaneous apomorphine pump. So if you look at apomorphine, it is one of the oldest dopaminergic drugs. So if you have a patient who is unresponsive to levodopa, you can try apomorphine. It acts on both B1 and B2. It is equally efficacious to levodopa. The rest of the drugs don't have such a big amount of efficacy. So if you have a levodopa which improves the off time by around 4 to 6 hours in a day, the other medication only reduces the off time by around 1 to 2 hours in a day. It's almost, except for the apomorphine. So oral bioavailability is poor, so subcutaneous apomorphine can be given. So intermittent injections are a viable rescue operation. So you can have continuous apomorphine infusion, which can be given for 3 hours. I think you've all seen these videos, but I'll just show you the videos where you can see the patient in a bad off state. And the on state. Now, I just want to give a clarity that this kind of response is seen with levodopa carbidopa also. So when we do a off, don't go mesmerized by all the videos which are coming up. It's exactly the same response as levodopa carbidopa. The only reason why these do work is, as I told you, in advanced PD, if the absorption of levodopa carbidopa comes down, the amount of levodopa carbidopa which goes into the blood is actually less. You may not see the response, but even then, we actually try and get such a response before we think of going for a continuous dopamine stimulation. Right? So only when you have patients, you know the reasons why you are getting unpredictable loss right now. So only in those patients, these may be better options. So this is a small group study which was done, which is a it was a registry which has been maintained. You can see that with apomorphine there was a marked improvement to the Honan stage from 3, 2, 2 and 2.5, and there was an improvement in UPDRS, NMSS, the quality of life, HADS, and a lot of non-motor symptoms of Parkinson's disease. The only problem is out of the 90 patients, there was 30% dropout rate by the end of 12 months. And the most common reason was the cost. The other reasons could be infection, they have nodule formation. Apomorphine is given as a pump for around 18 hours. So 12 to 18 hours. So you put the pump in the morning, remove the pump in the evening. It is not an implanted pump. It's a pump which is external. So you just put a needle, connect it to a pump, and the patient walks around. Because apomorphine is very unstable, you can't keep the molecule after it is, even in the liquid state after 24 hours or 48 hours. That's the reason why you have to keep changing the vial of the infusion. So that's a problem with apomorphine. The stability of the molecule is a problem. But otherwise, it is quite efficacious. DBS, as we know, is done in advanced PD patients. Usually after 5 years, you have a young onset PD patient who is going to have a long life and has got a very good on and off. It may be a good option to go for DBS. DBS is not really useful for genetic variants which are not responsive to levodopa. Say if you have rapid onset Parkinson's dystonia, or you have patients with Flat-Ujix, if you have a GBA mutation, these patients don't do well either with levodopa, either they do well with DBS or other drugs. So these are two patients who just this patient himself decided to do this. He was doing the same thing in the onset. Again, I will give a caveat. This is around 1.5 years after the surgery. He was able to do it even before the surgery. This is somebody which I would like you to have a notice, because this is around 20 years after the DBS surgery. So this is a very young onset patient who underwent surgery after 7 years of Parkinson's disease. So you don't see that kind of an improvement, or you don't see that kind of a response in patients who have a long-standing disease. So 25 years or 27 years after the Parkinson's disease, the patient is doing well. He went to Tirupati, went up, climbed up, was happy with the surgery. So what are the other potential newer therapies which are coming up? There is a levodopa carbidopa intersynogen, we already know, but there is a subcutaneous levodopa carbidopa preparation, which is called as a fast levodopa and fast carbidopa. The reason why they have gone to this subcutaneous preparation, they're looking at it, is that because sometimes when you have a GI abnormalities, as I said, if you got an SIBO or a reduced absorption, even the levodopa and carbidopa intersynogen may not work. But subcutaneous levodopa carbidopa gel might work. Sublingual apomorphine, which is already available in the US, can be given as an acute rescue medication. We have something called as Napotam in India, but unfortunately that's not the same as the sublingual apomorphine film. It does improve the, it does give a little bit of on in patients with Parkinson's disease. Some patients in the North India are using quite a bit of those Apotab. It comes in 2 milligram tablets. But the problem with it is that it can cause oral ulcer, and the amount of medicine that you need to give in Apotab is very high. So the efficacy lasts for a short period and then it's seeming to wane off, because the formulation is like that. So probably a sublingual gel, a sublingual film would be a better option. So probably somebody will come with sublingual film here also in India soon. So these are drugs which can be used for unpredictable ops. So to conclude, drug anti-ops can be due to various mechanisms. Treatment lies in understanding the underlying pathophysiology and is individualized. In cases of advanced disease with secondary refractoriness, non-oral therapies may be effective. Thank you for your patience. Patch is available. The roticotin patch was available for some time. Right now it is not available in India by itself, so they are actually getting it imported. There was a problem with the roticotin patch in Indian population because of excessive sweating. But the newer formulation of the roticotin patch is quite useful. So this is a dopa agonist which can again go through the subcutaneous tissue and can go. So it has a 24-hour patch. So it is available as 2 mg and 4 mg. It can definitely be given in patients who cannot take therapy. Yes, it is effective in off-state. It is as effective as other dopamine agonists. So the efficacy is a little moderate, but it is effective. A lot of people in UK actually go with apomorphine and roticotin patch. So they give a roticotin patch in the night so that it stays in the night and overnight, and then the apomorphine pump in the morning. So the combination is usually not common. Both of them are dopa agonists, but they have that also.
There is also a concept of dissolving the levodopa tablets in soda or lime
Yes.
and consuming it very frequently.
Yes.
What is your opinion?
We do that. So, if the patient has got very bad fluctuations, and especially if they have very severe dyskinesias. So what happens is that the tablets can get stuck in esophagus or stomach. They don't get, and then suddenly they have a release of the levodopa when it goes to the small intestine. So in such cases where they have very marked fluctuations, marked offs, severe offs and severe dyskinesias, what we tell is that you can give a levodopa in a acidic medium. So it can be, we tell them to take actually 1 tablet of vitamin C or 2 tablets of vitamin C in soda and mix it up with, it depends. So the way we make it, if the patient is taking 6 or 7 tablets, 6 tablets in 500 ml of soda, limca, or Sprite with 1 or 2 tablets of vitamin C and drink it whenever they want. It's 100 ml or 50 ml, they can modulate it and drink it. The immediate effect, I think, is immediate, more than not immediate means not as immediate as apomorphine or other injections, but it's definitely better than the people who have got very delayed onset.
What about a combination of entacapone and that's also
Yes, sir. Entacapone. The entacapone is very useful when we have a patient whose ONs are fairly well on time, but the effect of the drug lasts for a shorter period. But so that way, adding an entacapone definitely does improve the efficacy of the medication. If you have severe dyskinesias with peak dose dyskinesia also, entacapone actually reduces the dyskinesia because the amount of drug which is getting released comes down.
For me, regarding this, the patient who is advanced Parkinson's disease is already limited mobility in spite of taking several drugs. But this patient suddenly comes to you with off-like situation. But I have no much experience. I still feel that it's not off.
Yeah.
How to differentiate? Is there any point? Because sometimes, during this off also they are restless, as you said. In the opposite periods also they are restless, unable to open the eyes, and then cognitive is also restless. They keep moving limbs hazardously. Whether it's a dyskinesia related to the drug overdose or how to can you enlighten us on that?
Yeah, this is another point, that if you have a patient who is not responding to levodopa, better ask the patient attendants whether they are giving enough levodopa. If the patients develop dyskinesias, the attendants don't like to give them medication because they think that they will move too much. So they bring down the medicine quite a bit. And dyskinesia sometimes can be biphasic or a peak dose dyskinesia. In such patients, it would be better to see them actually in off, that is, see them 12 hours without medication if they are able to tolerate it. Otherwise, wait for the drug effect to come down and then give them 2 or 3 tablets of levodopa and carbidopa and see. If they're taking, ideally when you do a UPDRS challenge test, you have to give 1.5 times the medication that they're already taking. Suppose they're taking, say, levodopa, carbidopa, 275 milligrams, 250 milligrams with 25 milligrams of carbidopa, then they can go up to 375 milligrams to assess their responsiveness. So you can give them higher dose. Just because we keep telling the patient, most of the attendants are scared of dyskinesia. So the moment they have dyskinesia, they will reduce the medication. So that can be actually a pseudo-off. So you can actually give them a lot of medication, wait for the dyskinesias to occur, tell them don't worry, we will take care of the dyskinesias, put them in a bed or put them on the ground if you think that they're going to fall off the bed. Sometimes that also happens with the dyskinesias. So then
when in doubt, you better to give.
Better to give in.
I found that many patients are happy with dyskinesia rather than us.
The patients are very happy, attendants are very unhappy. So the advanced stage, they start giving the medication and so they don't give them.
There are nothing, no queries, close the session.
I'd like to request Dr. Murli sir to facilitate with me. The next topic for today is an important topic, surgery for stroke. I'd like to invite Dr. Subodh Raju, Director and Chief Neurosurgeon, AIG Hospital, to chair the session.
Good morning, everyone. Thank you, Srikanth, for organizing a beautiful meeting. Next topic is a very important thing, I think, relevant to both neurosurgeons and neurologists. And we have none other than Dr. Manas, Chief of Neurosurgery at KIMS. And he heads the Cerebrovascular Society, Skull-Based Society in India. Over to you, Dr. Manas.
Morning, Dr. Subodh, thank you, Dr. Radhakrishna and Dr. Srikanth for organizing such an event. Surgery for stroke, everybody will be expecting to speak on hematoma or decompressive craniotomy. But then there's something such a day-to-day event, and then every day there is a controversy to operate or not when there's a referral. So I'll not be talking much on the stroke, decompressive craniotomy or intracerebral hematoma. Actually, I'll speak on more of what is on ischemia. How many of you have neurosurgery residents? Yeah, at least it will be useful for few of you. But then I'm sure neurology residents also will have a take-home message. The surgery for stroke, like all of us know, is an ischemic stroke. One can do a carotid endarterectomy, or you have different types of bypasses. And then in emergency acute stage, you do a decompressive hemicraniotomy. And in hemorrhagic stroke, again, you do a decompressive craniotomy. And if you have an hematoma, then hematoma with intraventricular extension, you do a tooth-drill and do an external ventricular drain. If you have intracerebral hematoma, you can do a hematoma evacuation, either microscopic or macroscopic or endoscopic. And you have a subarachnoid hemorrhage in aneurysm, one can do a clipping or coiling depending on the anatomy of the aneurysm. Though subarachnoid hemorrhage or intracerebral, I'm not talking about aneurysm because again it will become purely surgical. So I thought I will confine myself to bypass because each topic is a lecture by itself. Now bypass is it's a very good procedure, but then it's like a lot of controversy exists. When it started long ago, a lot of people believe like cardiac bypass, that ECIC bypass will be very helpful and it will change the scenario for patient. But then it didn't do that. The bypass history was not very old. It's not even 100 years old. In 1942, they did the first indirect bypass, like ERAMS. And the first bypass with the saphenous graft was done in 1963. So it's like 80 years old. In 68, they did the NCMC bypass. In the 71, they did common carotid ICA bypass. And the ECIC bypass for Moyama was done in 73. And followed by different types of bypass, including bypass of posterior circulation. But then this study in 1985, where they did ECIC bypass, but let me tell you, nobody did a randomized study when we started cardiac bypass, whether medical management is better or CABG is better. But neurosurgeons, neurologists are very skeptical of doing anything new. So we did a study and then we told that it's not effective. But then that had a lot of criticism in the study because many of the patients were operated outside the trial and they did not have angiography criteria for determining what is the entry point, and they did not do any pre-op evaluation of the cerebrovascular reserve. Nor there was many patients did not have symptoms. So, and if they don't have symptoms, what will be the outcome? What will be seen later? So this study was not probably done properly, and then from 1985, everybody has preconceived idea that bypass doesn't help. But then in OP, all of us see patients who come with carotid artery occlusion. If you have less than 95% occlusion, you tend for stenting or carotid endarterectomy. But then what do you do for patients who have a total occlusion? Do we do a bypass for them, or we just leave it to them? So this study, carotid artery occlusion surgery study, was done in 2010, and then they had two arms, medical arm and a surgery arm. They had 97 patients in the surgery, and medical arm had 98 patients. Again, in this study, which was published, the result of study published in 2013, and the 13 again it was controversial. But one point I have to tell is the 97 bypass for patient surgery, and it was done by 30 different surgeons. So if it comes to like 3 bypass by one surgeon. So we will not have uniformity of result of whatever is published. And similar to what we think logically, there were 12 surgical patients who had stroke within 2 days of surgery. So obviously when they had 12 days surgery, which is a surgical complication, so the end, when you look at the 2-year study, so it will not be better than medical management. Because in medical management, in carotid artery occlusion, is 22% have a stroke, and if I include this 12%, it is similar. But then when they excluded these patients who had stroke within 2 days, there was a significant difference. There was a 9% in surgical group and 22% in the medical group. So this tells that if we have a consistent surgeon who is doing regularly bypass, probably it is helpful in carotid artery, total carotid artery occlusion. So in conclusion, as I told you, though overall if you take the perioperative risk, there is no difference, but if you exclude the perioperative risk in the first 48 hours, it has a significant benefit. So having told that bypass is useful in a selected group of patients, then what are the different types of bypass? There are 2 types of bypass. One is a flow replacement. Replacement is something which you do in ischemia or Moyamoya disease, where wherever there is a reduction of flow, so we have to do a bypass. The other is flow augmentation. Augmentation is when you have aneurysms or tumors, when you have to sacrifice the ICA, then you have to augment by doing a high flow bypass, like using venous graft and an radial artery graft. Just doing an STMC will not be enough. So I tell an example of a flow replacement and a flow augmentation. Now this is a case of atherosclerotic stenosis. Many of our patients have intracranial stenosis as seen in the scan, or they can have a complete ICA occlusion. They present with recurrent TIS, and these are the group of where you need a flow replacement. And another example of flow replacement is a Moyamoya disease, where there is, because of the ICA occlusion, you have multiple collaterals, they are not normal, and they develop multiple ischemia and hemorrhages, and they have again a good indication of bypass. In flow augmentation, like these aneurysms, these giant aneurysms ICA who present with stroke, they are partially thrombus. So here, if you look at flow diverter or stenting will not work because they have a thrombus and they present with ischemia, multiple emboli. So in this case, one has to do a trap the aneurysm and do a bypass. So doing an endovascular procedure will not be helpful in these cases, leaving aside the cost of the treatment. So once you decide to do a bypass, there are 2 stages. First is establish ischemia. Second is establish a cerebrovascular reserve. If the patient has an adequate cerebrovascular reserve in Moyamoya or in ischemia, we do not need to do bypass. But then if it does not have adequate reserve, then one has to do a bypass. Now, what is a cerebrovascular reserve? It is normally, whenever there is an ischemia, perfusion is maintained at rest. Patient is asymptomatic. But whenever there is an increased activity, like the patient is crying or eating spicy food or any exertion or does any strenuous work, when it needs an increase in blood flow, then they become symptomatic, they present the stroke. And so these are the group of patients who need bypass. So what are the tests to address this cerebrovascular reserve? Now there are different types of tests, like one can do a SPECT with and without diamonds, one can do an MR perfusion, one can do a CT perfusion, one can do an ASL with or without diamonds also. And this is a perfusion scan which shows that there's with and without diamonds there can be a reduction in the perfusion, or the perfusion does not increase because the patient does not have adequate reserve. Now this is a SPECT done, the right side shows baseline and the left side shows with diamonds. So whenever we give diamonds also, the perfusion does not increase. That means the patient does not have a reserve to to fight in terms of stress, and is a high risk of stroke. So these are the group of patients who need bypass surgery. Non-invasively, one can do ASL study with and without time loss, and then if there is no increase in perfusion, then they are a good indication for surgery. Once you make a decision that some patient does not have adequate reserves, he needs a surgery. There are different types of surgery. One can do a direct bypass, one can do an indirect bypass. Then one has to decide which vessel, whether I use a saphenous vein or a superior temporal artery or a radial artery, and decide whether I do a free graft or a pedicle graft, and then decide which is the recipient. I do MCA or ACA or posterior circulation, depending on the site of the disease and what technique of anastomosis. Now, usually direct is done whenever we do a carotid occlusion like aneurysms or tumors when you excise, so where direct is essential. And direct is also, because it gives an immediate result, direct is better, but the minimum prescription, the vessel should have at least 1.5 millimeter diameter to do the bypass. But if the recipient vessel MCs are smaller, then one can not do a direct, then one has to do an indirect, like doing just a muscle transposition or omental vessel transposition like this. There are different types of indirect. Suppose the recipient vessels are small, one can do encephalomyosynangiosis or encephaloduroarteriosynangiosis or encephaloduromyosynangiosis, where the muscle, artery, means the middle meningeal, everything is layered in the brain. Or if that is not enough, one people used to do earlier omental graft, or in children one can do just multiple burr holes, and then that also can increases the vascularity. But in indirect, it takes at least 3 to 6 months for the patient to get the benefit. So he still has the risk of 3 to 6 months that he can have an ischemic attack. Indirect, because it gives an immediate relief, so the relief is immediate. So direct one can do an STMCA, or if the STA is not adequate, then one has to do a radial artery from the common carotid to the MCA. So the different donor vessels, the commonest is ST, one can use middle meningeal, one can do external carotid, internal carotid, occipital artery or vertebral artery also. Now to graft, as I said, one can, in addition to artery, one can use a venous graft. Or one can use a free take arterial graft like CABG, one can take a radial artery and use that as a graft. Now when does one use a arterial graft or venous graft? If a child comes in, children, it is difficult to get an radial artery because the palmar arch is not developed. So one takes up the radial artery, patient can have ischemia. So if less than 12 years, one should not use a radial artery graft, should use a venous graft or direct STMCA if the ST and MCAs have an adequate diameter like 2 millimeter. So depending on the age, one has to decide what kind of graft has to be done. Now what is the present status of the literature? So though ECIC has shown no benefit in RCT, but in a selected group of patients, it is helpful as according to the cost study and other studies. In myeloma, it is class 3 evidence that it's beneficial to do a bypass. In complex aneurysm, it is again class 3 evidence that bypass is helpful, whether you do endovascular or surgery, it's class 3 evidence. And skull-based tumor where the ICA is involved, where the ICA has to be taken out, again, this is a class 3 evidence that bypass is helpful. So this is a case of a myeloma disease where the operative step is, once I have this patient, the first step is to harvest the superior temporal artery. So the superior temporal artery can be harvested by an outside-in technique or inside-out technique. This is for the surgeons. Then outside-in technique where we mark the superior temporal artery with a Doppler and then directly incise on that incision and harvest the, as you can see here, harvest the superior temporal artery and then do the bypass. The inside-out technique is we make a flap like we do for a decompressive craniotomy. So the flap is reflected and then the superior temporal artery is harvested from the flap. So you can see here the artery is harvested and then that is used for the bypass. I will not be wasting more time on the videos. So this is a small video on the harvesting from the outside-in technique where the STA is harvested, and the advantage of outside the technique is we can, because the craniotomy and everything can be done by your colleague, and then you can join just for the bypass. So your efficiency increases with outside in technique, but inside our technique you have to scrub from the beginning. And sorry. So this is the ICA harvested. Then there is a nick made on the middle cerebral artery. You can see here the middle cerebral artery, and anastomosis is done from the STA to the middle cerebral artery. And finally, confirmation is done by doing a intra-op angiography. Either you can do an ICG or yellow fluorescence. You can see here. The color will change. Yeah, you can see that the patency. So the end point is the patency should be there. If the bypass is not done properly, then there can be thrombus in the bypass. If there is thrombus, then we can open up and redo it so that the patency is seen with the intra-op angiogram. Now, of the anastomosis we have done, both direct and indirect, these are the numbers we have done. It doesn't go without complications. I'll tell one or two complications which I had. And so we had 95% patency, but then we also had complications like one flap necrosis. There is a problem with the indirect one, but then flap necrosis is described. But then, and then the risk of stroke. The risk of stroke also is almost 5% in children less than 18 years, because most of them are monomania. In the adult group, the risk of stroke was higher, like 13%. But then one is to understand that 87% have got the benefit. So this is a case of the moya. It came back with a hemorrhagic stroke again. So instead of STMC, because STA was already used, so we used a different artery. We used another donor. We harvested an occipital artery, and then did the augmentation of flow. The occipital artery was subcutaneous tunnel to the MC region, and again we have done an anesthesia to another region. So even if you have a complication, we have a solution that one can use other vessels if the patient comes back with recurrent strokes. So the patency rate, though different people have gone, the cost study has told 96%, Lavinum Sicker has told 100%, and we had a patency of 90%. Now what is bypass or flow augmentation? As I explained, aneurysms need a high flow bypass. Like this large aneurysm, the ICA, both MC and AC was coming out from the aneurysm, so flow divert was not possible, and so we did a high flow bypass. So here the common carotid is exposed, and then a saphenous vein was harvested, and then anastomosis is done, saphenous vein to the MCA, and then saphenous vein to the ICA. Anastomosis was done. And finally you can see the flow of the blood in the saphenous vein. It's a huge one. Whenever you sacrifice the vessel, one has to have augment the ICA with another large vessel. And this is again confirming with the ICG that the flow is good. So in conclusion, revascularization helps in reduction of ischemia with acceptable complication rate. Surgery is safer in younger patients, and complications are higher in adult patients in atherosclerotic, but then it is beneficial because it reduces the stroke rate from 22% to 9%. So in selected group of patients, bypass is helpful and is an option, has to be given to all patients. Thank you for your attention.
Thank you, Dr. Manas. I think whatever you told, it's a good awareness thing for everyone. One case scenario, a 60-year-old man with total occlusion, acute stroke, what would you suggest? Total occlusion.
Yeah, I say total occlusion acute phase, you don't do anything. And then is it the first attack or not? So after 1 month you call back, and then in the 1 month you doesn't have a second attack, so you have, then you're lucky. And then you do a perfusion, look for the cerebrovascular reserve, do a perfusion study with and diamox, and if the patient has adequate collateral, medical management. But if the reserve is compromised, then one has to do a yes.
But patient should be functionally good. In spite of a total occlusion, the patient should be functionally fine.
Functionally fine means if you take KT score, it should be more than 70. It should be independent. The bedridden patient will not do it. But you don't want patient to have another attack that hemiparesis becomes a hemiplegia.
So is there a role for an early intervention?
In total occlusion, unless it's an acute thrombus. The ultrasound shows it's an acute thrombus, and then one can do a thrombectomy. Or it's an ulcer or something. Otherwise, it's not. No, there is no acute role of bypassing those cases.
Thank you. Anyone?
Yeah, in the adult group, more than 18 years, we have done in 18, means ischemia was out of 18, 1/3 was ischemia and 2/3 were because of myomia. So we still get adult myomia in our group. No, we have not done that. We have only patients who had not. Huh?
PSS phase 3.
PSS stage 3 we can do. But it depends if the vessels are diseased, and like in SLE and rheumatoid arthritis, if you do bypass, it doesn't fold.
Yeah.
And there you can only do an indirect bypass. You cannot do a direct bypass.
Most of these cases, the vessels, you cannot, it's not.
Vessel is diseased.
Anastomosis is very difficult, so indirect what to do.
There are some conditions like carotid webs. Acute stroke, I think we need to find the carotid web. I think we have the role of emergency surgery in those cases.
Carotid web and acute thrombus. Now we had once at NIMS where they were doing stenting, and the stent did not open, and so we had to do an emergency endectomy and take out the stent. So because that would have precipitated an acute stroke.
The middle cerebral artery MC stenosis. So people are trying stents now. So will there be any role in future for the revascularization by surgery?
See, 1985 people did study. They told that that is our dichotomy of thoughts. 85 we did a study and we tell that bypass is not helpful. But now because stenting can be done without surgery, they do a stent that telling that it's helpful. So it's better you comment on that than I as a surgeon comment.
No, the thing is, sir, this is a teaching forum for the students, so we should not give confusing thoughts to them. In case of ICAD, the latest study, this CAD study says that medical management is still the best option. In spite of having 2 attacks or 3 attacks, medical management is still the best option. Stunting is again few case series, sir. Actually, we know that Sampras has failed, and then there are many interest radiologists. In fact, stunting has become a fad for interest radiologists because, unfortunately, here at least in Hyderabad, there are very few neurologists who are doing intervention. So they know which patient will do with medical management, which patient will do with stunting. So before embarking upon stunting or any kind of surgery, it is always better to put them on best medical management. In the latest study, this CAD study which is published in JAMA 2023, says that medical management still holds good. So that is a problem. That is the problem. These patients know we should not send them to the.
And you know that a small group needs surgery, a small group only needs stenting.
So there are a couple of patients who actually have this one-sided complete block and the other side they will have a small TIA or a stroke and they come with probably a 89% block. So that's where you don't have to go for any other. So do you think that bypass would be a good option?
Means he has a TIA on the which side, the close side? Normal side.
Normally that's what happens.
But then the normal side has 80-90% block, and if the stroke is on the same side, that has to be treated first. Unless he is having stroke on the opposite side because of low perfusion, then bypass becomes first. So here, then first do a therapy endarterectomy or a stenting, and then if still continues to have, then go for bypass on the opposite side.
It's always sometimes that time we always are a little worried that you open up or you do something and then suddenly things close at that point. So that is the worry with most of the...
There is a 3% risk of perioperative problems whether you do stenting or surgery. But the risk is less than medical management.
Yes, Susan.
This is, I think, overall stroke thing, but that in Moya, what is your take on the pediatric and adult? Do you do bypass for all pediatric Moya? Or you just do a EDAS or EDMS or Barbo or combination of everything?
When you operate, we always do both direct and indirect for children combination. But many times in children, direct we attempt, but if it's not possible, then that indirect helps. So we always combine in children. Do both, if possible, both.
Do you also use surrounding barcodes and
No, because we do direct, indirect, we don't do barcodes.
That is also an option which has come back again. So the older thing which is again come back in many cases, they are doing it. But for the general understanding, I want to point that pediatric stroke and vaso-occlusive disease is completely different than an adult these things. We don't measure it in the same set of guidelines. Anything else, anyone? Yes. Thank you very much, Sir.
Thank you so much.
I'd like to invite Dr. Subodh Raju sir to felicitate Dr. Manas Panigali sir. So hand over the moment. And I'd like to invite Dr. Suchandra ma'am, Head of Department Neurosurgery MIMS, to felicitate Subodh sir. The next session for today, the topic is large vessel occlusion and mechanical thrombectomy. I'd like to invite Dr. Sandhya Manoranj ma'am to chair the session.
Hello. So Dr. Renji is a consultant neurologist in Medicover Hospital. He has a fellowship in interventional stroke neurology. He has several publications to his credit, and we know that large vessel occlusion makes a major chunk of the etiopathogenesis of ischemic stroke, around 36 to 42%. Over to you, Dr. Renji.
Thanks for the introduction, ma'am. I am going to talk about large vessel occlusions and mechanical thrombectomies, and in which cases we have to take for mechanical thrombectomy and techniques of mechanical thrombectomy. This is the scheme of my presentation. So I will start with definitions. So large vessel occlusion is defined as occlusion of proximal vessels of intracranial circulation. In the anterior circulation, it includes intracranial ICA, middle cerebral artery M1 and the dominant M2. And in posterior circulation, it includes intracranial vertebral arteries, basilar arteries and the proximal posterior cerebral artery. So what are medium vessel occlusions? Medium vessel occlusions are occlusions which are slightly distal to the proximal occlusions. In the anterior circulation, they include M2 and the M3 segments. M2 if it is a non-dominant branch, M3 segment, A2 and the A3, and the P2 and P3 segments. So these are included under medium vessel occlusions. So how to identify, large vessel occlusions estimate for about 24 to 38% of all acute ischemic strokes. That is a huge number, with number increasing to about 46% if we include even medium vessel occlusions. So how to identify large vessel occlusions and how to identify clinically in which patients have large vessel occlusions. So NIHS score is the most standardized score in quantifying the neurological deficits in acute ischemic stroke. But given the importance of motor deficits in NIHS scoring, even the patients who have internal capsule infarctions may have high NIHS scores. So there are few scores which are developed for identifying particularly large vessel occlusions. There are many scores which have varied sensitivity and specificity in identifying large vessel occlusions. So I will be discussing two such scores. One is VAN. VAN includes patients who have motor deficits, and in those patients if they have visual disturbances like hemianopia, aphasia and hemineglect. So these patients are found to be having large vessel occlusions with a good specificity and sensitivity. And the other score which I would like to discuss is rapid arterial occlusion evaluation scoring, which is also a simple score, which includes facial palsy, arm motor function, leg motor function, head and gaze deviation, aphasia and agnosia. So to summarize, if a patient has symptoms of both proximal, cortical and subcortical infarction, then those patients are said to be suspected to be having large vessel occlusions. So usually the cortical symptoms are aphasia, hemineglect, forced gaze deviation, agnosia, and visual disturbances like hemianopia. These are the cortical symptoms. These patients are suspected to be having. We can suspect large vessel occlusions in these patients. So coming to imaging, can we identify large vessel occlusions in plain CT brain without doing a vessel imaging? Sometimes we can identify, like in cases of dense MCA sign. Sometimes we'll have find patient having dense MCA sign, which is very specific for middle cerebral artery occlusion. And sometimes even we can appreciate hyperdense basilar sign, which is also specific for basilar artery occlusion. And in plain MRIs, in flared images, we can sometimes identify the loss of flow voids in the middle cerebral artery, the suprasellar region. Like in this case, where we can find the middle cerebral artery flow is reduced and it is sluggish. And even in the Sylvian fissure, sometimes we will be able to find out the flow, sluggish flow in the middle cerebral artery. In these cases, we can suspect middle cerebral artery occlusions and the large vessel occlusions. And in flare images, we can identify right ICA segment thrombosis in the petrous and the horizontal segment here. And in SWI images, the equivalent of dense MCA sign is blooming artifact, which we can see in left MCA territory here, left middle cerebral artery here. So this blooming artifact and dense MCA sign are usually seen in red clots. So when there is a large vessel occlusion, it can be caused because of two types of clots. One is red clot. Red clot is usually mixed with fibrin and erythrocytes. So this will give this hyperdense MCA sign and blooming artifact in SWI images. And the other clot is white clot. White clot is usually a mixture of platelets and von Willebrand factors and collagen and calcium. So in white clots, usually we will not be able to see this blooming artifact or the hyperdense MCA signs. So coming to the arterial imaging, so when an acute ischemic stroke patient comes, there are two modalities of imaging: imaging the parenchyma and imaging the arteries of the brain. So in the reconstructed images, it is very easy to make out large vessel occlusions. For example, in this case, there is left M1 occlusion. In this case, there is right ICA occlusion. When taken for the procedure, this patient was found to be having right terminal ICA occlusion with collapse of the right ICA. And this patient was having basilar occlusion. When taken for mechanical thrombectomy, he was having proximal basilar occlusion. And we can appreciate left PCA occlusion here. So large vessel occlusions are comparatively easy to identify in reconstructed images, and we should be able to identify these large vessel occlusions even in the source images in the acute settings. So coming to the treatment part, how effective is intravenous thrombolysis for large vessel occlusions? About 10 to 20% of patients attain recanalization and good functional outcomes with intravenous thrombolysis itself. With ALT plus 0.9 mg per kg body weight, there is about 10% chances of recanalization, and with 10 plus 0.25 mg per kg body weight, there is about 22% chances of recanalization and good functional outcomes. 10 plus is slightly better in large vessel occlusions when we are taking the patient for intravenous thrombolysis. If the clot length is more than 8 mm, that is, the patient is having huge clot burden, then it is very difficult to recanalize with intravenous thrombolysis itself. About 80% of large vessel occlusions does not open with intravenous thrombolysis. So we should not wait for intravenous thrombolysis to work, and we have to take the patient immediately for mechanical thrombectomy after administering intravenous thrombolysis. So how to measure this clot length? Of course, it is not practical in all cases to measure clot length, but there is this theory. So in multiphasic CT scans, if we can see the point of occlusion in the peak arterial phase, and if we can make out the distalmost collateral in the peak venous phase, the distance between those two areas can be, we can suspect that this area is the clot length of the clot length inside the middle cerebral artery. It is very difficult to measure the clot length and then take a call. So large vessel occlusion, intravenous thrombolysis, followed by taking the patient for DSA and mechanical thrombectomy. So mechanical thrombectomy is synonymous to endovascular clot removal. So basic techniques are stent retriever technique and aspiration technique, or combination of both. So according to 2019 guidelines, MT can be considered in patients with MRS score of 0 to 1, that means patient should be functionally independent before stroke, and the causative occlusion should be proximal middle cerebral artery, basilar ICA middle cerebral artery, and basilar occlusions, and the NIHS score should be more than at least 6. And the aspect score should be high, that means the damaged tissue should be less. And the treatment should be initiated within 6 hours of onset of symptoms, and time window can be extended up to 24 hours based upon the tissue-based imaging. So imaging required is CT angiogram or MR angiogram. Multimodality imaging is required for patients who come after 6 hours of onset of symptoms. So this mechanical thrombectomy was, it has been in trial since 2001. Initially, endovascular treatment was started with intra-arterial thrombolysis. Later on, it has developed, later on with stent retrievers. Initially, the stent retrievers used to be, they used to use the stent retrievers for coiling cases. So for the support in wide neck aneurysm, they used to use the stent retrievers. When they were using the stent retrievers, they found out that it has capacity to pull back the clot. And in 2011, approximately in 2011, they have found that the stent retrievers are very useful. Stent retrievers are retinol stents which are attached to a stainless steel wire. So we can pull back the stent after deploying so that it can hold the clot and can pull out the clot from the arteries. So after these studies, after these hallmark studies like Mr. Clean, Escape, Revast, Swift Prime, and Extend 1A, after the data from these studies have come out in the Hermes collaboration, they have found that mechanical thrombectomy is very useful, and almost number needed to treat is 2.4, which is very, very good in when compared to many of the medical interventions. So after these trials have come out, the approval has come for mechanical thrombectomy up to 6 hours of onset of symptoms. And later on, this time frame has increased from 6 hours to 24 hours after this Dawn and Diffuse trials came out. So Dawn and Diffuse trials basically these trials are based upon the tissue-based imaging. In the diffuse trial, what they have done is they did a CT perfusion imaging and found CT perfusion imaging along with the CT angiogram or MR perfusion imaging along with MR angiogram in patients who have large vessel occlusions, and if the infarcted tissue is less than 70 ml, then those patients have significant benefit when taken for mechanical thrombectomy up to 16 hours of onset of symptoms. And in DAWN trial, they have checked the clinical deficits of the patient, that means NIHS score should be more than 10, with MR angiogram showing a large vessel occlusion, and the diffusion restriction is less than 30 ml of middle cerebral artery. In these patients, they have found that even mechanical thrombectomy will be useful when done up to 24 hours of onset of symptoms. After these two trials have come out, mechanical thrombectomy has this, the period of mechanical thrombectomy was extended from 6 hours to 24 hours. So coming to technical details of this mechanical thrombectomy, it can be done with two techniques. One stent retriever technique, two aspiration technique, and third is combination of both these, that is Solembra technique. So stent retrievers are self-expandable stents deployed by unsheathing the small open mesh stents attached to a micro wire. So these are just stents which are attached to a micro wire, and we can pull back the stent after deploying the stent inside the artery. So he is Professor Carlos. So he is the person who did this mechanical thrombectomies first in swine models, later on in patients and found out that this mechanical thrombectomies are very useful and they have capacity to pull back the clots when deployed inside the intracranial circulation safely without dissecting the vessels. So the technique is, first we have to take the microcatheter into the occluded artery. This the stent retriever is pushed into the microcatheter, that is into the thrombus, and the microcatheter is pulled back so that the stent gets opened inside the artery, that is inside the clot, and this stent retriever will hold the clot, and the device is left in place for 5 minutes. It is said that just after deployment of the stent itself, the brain will start breathing. That means all the times the brain will be deprived of the blood. When the stent retriever gets opened, there will be some flow into the vessels, and it is left there for 5 minutes so that the stent will open appropriately, and the clot will get trapped into the stent. And sometimes you can even use proximal balloon guided catheters to stop the flow into the artery so that the stent clot can be removed completely and distal fragmentation can be prevented. So solitaire stent retriever was the first approved stent retriever. So this is the solitaire stent retriever. This is how it looks, and these are the first generation Trevo stent retrievers. So I will show a case which was done with the stent retriever technique. With a 40-year-old male who presented with wake-up stroke. He was having high NIHS score of 24 with right hemiplegia and aphasia. We can see he is having the left M1 occlusion, very proximal M1 occlusion. ACI is good. And in this patient, we have taken the stent retriever into the middle cerebral artery. This stent retriever, microcatheter into the middle cerebral artery. This microcatheter has stent retriever in situ, and the microcatheter is slowly pulled back so that the stent is deployed. And when the stent is pulled out, you can see a stent here. This is the stent, and this is attached to a wire. So when the stent is pulled out, this huge clot came out, this huge red clot came out, and a TK3 recanalization was achieved. Patient had good functional recovery. So this is how a stent retriever works. And the second technique is aspiration or a suction thrombectomy technique. So it was first developed in 2007, and this suction technique or aspiration technique is done with the aspiration catheters. These aspiration catheters are forced into the occluded vessels, and the aspiration catheter, tip of the aspiration catheter is pushed into the face of the clot. And after this catheter is placed in the position and negative suction is applied either with 50 ml syringe, or if we have a luxury to have this aspiration pump, we can use even aspiration pump. But 50 ml syringe usually suffice. We have to give a good suction for 1 minute, and total aspiration catheter can be removed from the guiding catheter, which usually will hold the clots. So aspiration thrombectomy works very well for white clots, whereas stent retriever works well for red clots, because usually the white clots are very hard. They have calcium and collagen also. So in these cases, the stents will not open properly because the stents have limited radial force. Whereas the aspiration catheter, we can give good amount of negative suction, and they can pull out the white clots also very well. So few techniques like adapt and snake technique. Snake technique is nothing but take a very soft catheters like red catheter from penumbra and push the catheter through the guiding catheter. So this does not require wire. These catheters will go very smoothly up to the point of occlusion. That is called snake technique. Adapt technique means a technique where along with the aspiration catheter, wires are also used. So snake technique does not require wire. So this is the simple 50 ml syringe with a lever lock by which we can do a mechanical thrombectomy, and this is the aspiration pump. So usually I do with this 50 ml syringe. There are many aspiration catheters available in market. With the recent inclusion of React from Medtronic and Red from Penumbra, the navigability of these aspiration catheters has improved a lot, and basically problem happens with navigation through the ophthalmic curve. So most of these catheters does not take the ophthalmic curve. So as the catheters keep developing, as the recent catheters are coming, they are developing the catheters in such a way that they will take the cavernous loop and the ophthalmic curve very well and go into the middle cerebral artery. So these are the different types of catheters which are available. Even the smaller catheters like 5 max, 4 max are also available to do mechanical thrombectomies even in middle cerebral artery, M2 segments also. So this is one case where we did aspiration thrombectomy. You can appreciate right middle cerebral artery M1 occlusion here. This is a road map which gives the idea where the vessels are and how we have to go through these vessels. And an aspiration catheter is passed into this tortuous vessel. This is the A68 catheter which has taken all these loops and went into the ICA and went into the proximal MCA. And these hard red clots were pulled back. And this is the occluded artery, and this is after mechanical thrombectomy. There was good recannulation. Sometimes the results will be so quick and so gratifying that we can see improvement immediately after the procedure. This is a video. This is a video taken in cath lab. But always results will not be so quick. It may take 24 hours also. But sometimes results will be so quick. If the patient presents very early, results will be so quick. Even in the cath lab, immediately after reperfusion, they will start lifting the hand and leg. He had left hemiplegia, now he is able to move his hands and legs. A short note on tandem occlusions. So acute stroke due to tandem occlusions means acute stroke due to intracranial large vessel occlusions in combination with concomitant extracranial carotid pathology. So these are called as tandem occlusions. This is how the MR angiogram, intracranial MR angiogram looks like in tandem occlusions. There will be no ICA and there will be no MCA. So we don't know where is the point of occlusion, whether it is the proximal ICA or whether it is the terminal ICA. Especially in top imaging non-contrast MR angiograms, it is very difficult to identify the site of occlusion, whether it is in the proximal ICA or the distal ICA. About 15 to 30% of large vessel occlusions are tandem occlusions. These tandem occlusions are actually difficult to treat because we have to open internal ICA and also MCA in these patients. And usually these tandem occlusions happen with proximal ICA stenosis and distal MCA occlusions. It is very difficult to negotiate catheters into the ICA when they have a complete occlusion in the proximal ICA. But if there is no intracranial circulation, if the collaterals are bad, if we leave these patients, definitely a whole of MCA will get infected. So we have to attempt mechanical thrombectomy in these cases. So he is a 60-year-old male with sudden onset left-sided weakness 2 hours into the onset. Actually, this patient came to us 1 month back. He had right ICA watershed infarctions with minimal deficits. So carotid Doppler was showing right ICA thrombus, but the flow was very good. Even I did DSA, there was a large thrombus in the right ICA, but flow was excellent. So in these patients, usually we keep on either dual antiplatelet or antiplatelet plus anticoagulation. So we have kept this patient on antiplatelet plus anticoagulation, Epixman 5 mg and clopidogrel we have kept. But unfortunately, this patient had complete occlusion of right ICA and the right MCA. So we can see the right CCA shoots are showing only external carotid artery. There is no internal carotid artery. So in these patients, only micro wires will pass through the occluded segment. Our bigger catheters will not pass. So a micro wire was passed into the middle cerebral artery, and slowly a balloon was pushed into the ICA, and ballooning was done, and about 2 mm to 3 mm of vessel dilatation was achieved. And later on, an aspiration catheter was pushed into the ICA and taken the shoot. Here we can see even the MCA is occluded. So ICA is occluded, MCA is occluded. So aspiration mechanical thrombectomy was done, and middle cerebral artery total recanalization was achieved. And this is a long clot which was retrieved from MCA. It was almost about 10 centimeters. So later on in this patient, definitely we have to address the internal carotid artery also, or else he will have again stroke. So in this patient, we have taken for have taken the sometimes you can do on the same sitting stenting, but I have taken on the next day because ICA was open at the end of the procedure. Of course, it was stenosed, but ICA was open at the end of the procedure. So I have taken electively after loading with dual antiplatelets. So catheter stent was passed through the stenotic segment, and a stent was deployed into the ICA, and this is how the recanalization. This is the terminal final result of recanalization, and this is the post dilatation. And patient did very well. He came back after 1 week with very minimal deficits of only left upper limb weakness. So to summarize, large vessel occlusions constitute about 24 to 38% of all acute ischemic strokes, and only 10 to 20% are recanalized with intravenous thrombolysis. And recently there is shift from time period of onset of stroke to the salvageable tissue which is still present for taking the patients for any stroke interventions, primarily like mechanical thrombectomies. So tissue-based imaging is very important to find out the salvageable tissue. And patients with large vessel occlusion should be immediately taken for endovascular therapy. We should not wait for the intravenous thrombolysis to work. And with recent devices and techniques, EVT has very good functional outcomes and recanalization rates with very few complications like vessel dissections and ruptures. And number needed to treat for mechanical thrombectomy, if we attain good recanalization, is just 2.4. That is very good when compared to many of the medical interventions. Thank you.
Thank you, Dr. Venkat, for the wonderful talk. It was crisp and clear. Now we are running late of time. I think we can take 2 questions, 2 or 3 questions.
Are there any special situations actually where we can do thrombectomy after 24 hours?
Yes, sir. Even after 24 hours, we can definitely do thrombectomy, sir. Case reports are there up to even 7 days after occlusion of middle cerebral artery, mechanical thrombectomy can be done. If the perfusion imaging is showing significant perfusion deficit, and if the pile collaterals are the only thing which is holding the whole of MCA territory, definitely we can go for mechanical thrombectomy. But because the scenarios are, this scenario is very infrequent. I mean, of course, we do see cases where patients present after 24 hours. We don't have enough data to support that also.
Data is out. Data is out. Recently, the late trial has been published. It is hot off the press. I think 2-3 weeks back in Lancet Neurology. Mr. Clean late.
Mr. Clean late. Okay. I did not go through that trial.
Where they have taken patients after 24 hours.
Okay.
based on collaterals. Okay. Around 259 patients in thrombectomy group and 59 controls. And most of the patients who had good collaterals and then underwent thrombectomy after 24 hours had good outcome.
Yes.
So collaterals are the ones which decide the outcome.
Yes.
Every patient may come thrombectomy.
Yeah. And Select 2 trial also has came out, sir, in which they have found that even if they have taken the patients whose score is more than 70 ml also, they also have good functional outcomes when compared to patients who did not undergo mechanical thrombectomy. No other questions?
One question from myself. Whether you feel direct MT is good or is a combination is good? Direct mechanical.
Ma'am, as a neurologist, definitely I feel that intravenous thrombolysis should be given, and even the present data favors mechanical intravenous thrombolysis followed by mechanical thrombectomy. Of course, there are trials coming out like direct MT trial, where they have tried taking for direct mechanical thrombectomy, but I do feel that, and even the guidelines did not change. Actually, in 2019, the guidelines would say that we have to thrombolyze all the patients who present with within 4.5 hours and then take for mechanical thrombectomy. So intravenous thrombolysis, I do definitely advise.
Thank you. One thing I want to stress to the PG is that when the patient comes with acute ischemic stroke window period, we are doing CT scan. Then when there is hypertension MCSN or vascular artery, you think it is red clot as according to his class. So we need to give inactive phase instead of active phase. Thank you.
CT with CT angio, that is most important actually.
CT with CT angio is excellent.
What's your preferred modality of
my preferred modality is CT with CT angiogram, sir.
Many of them use.
Yes, sir. Basically, because we are going with MR angiogram in our institute because we had few communication problems with the ER team, and MRI definitely we can see the stroke. So.
And the problem is if it is a large defense restriction, no?
Yeah.
Then it puts you back actually.
Yes, sir. Yes, that is true.
Let's close the session now.
I'd like to invite Dr. Sandhya ma'am to felicitate Dr. Ranjit sir. The next topic is myasthenic crisis, the recent concepts. I'd like to invite Professor Srirangalakshmi ma'am, Head of Department of Neurology, Usmania Medical College, to chair the session. The speaker is Y. Muralidhar Reddy sir, Consultant Neurologist Care Hospital, with special interest in neuromuscular disorders, neurosonology and neuroimmunology. He is awarded as a Best Teacher in NY Chapter Telangana State 2022, and he has around 50 publications in index journals.
Again, I would like to thank Radhakrishna sir and Dr. Vikram for making me part of this conference. This will be actually a question and answer kind of thing. I would actually there are not many recent concepts in myasthenia gravis except some newer therapies which can be actually given as a treatment in myasthenic crisis. So this is all question and answer. That is how we actually learn the science too. So that at the end of the lecture, most of the questions and also doubts I must have cleared with the scientific knowledge. So what is myasthenic crisis? Actually, there is a lot of debate in the circles in the early 2000s about the diagnosis and also the definition of the myasthenic crisis. How many, especially this is in 2002. This is a landmark paper on the myasthenic crisis. It is actually the weakness from the acquired myasthenia gravis that is severe enough to necessitate intubation or delay the extubation in a patient who underwent surgery. Beyond 24 hours, if the patient we are delaying the extubation, then it could mean that we are dealing with a myasthenic crisis. So, however, how many, if the patient failed extubation after the surgery, when we remove it, again re-intubation, how many types of actually re-intubations needing surgery, and how long enough, all these things were confusion at that time. But latest 2016, that is guidelines of international guidelines, 2016 actually defined impending myasthenic crisis and myasthenic crisis also. But impending myasthenic crisis is actually left to the clinician. Even we do encounter like that when to intubate. So it is an impending myasthenic crisis is a patient of myasthenia who has very rapid clinical deterioration of the symptoms, and it is in the opinion of the clinician could lead to crisis in few hours to days too. So myasthenic crisis actually is an increased respiratory muscle or bulbar muscle weakness which is severe enough to necessitate intubation or mechanical ventilation. So this is the standard definition at this point of time. So how common is it? Actually, so we come across this myasthenic crisis. So a patient who is a myasthenic, at least 20%, it is something like 20% rule. 20% of the patients of myasthenics, they developed at least a single crisis in their lifetime, and 20% of the patients, it could be the initial presentation also. So it is more common in women than men, but there is a bimodal kind of distribution too. In earlier age groups, less than 55 years, the women are more common than men, whereas in more than 55 years of age group, women are more than men. But this is a literature, very long back literature, around a decade back literature. But now with various types of the myasthenia, various antibodies, each type of antibody may have different type of presentations, which I will run through the subsequent part of the lecture. So on an average, a myasthenia crisis patient will need at least 2 to 3 weeks of ventilation. So we may be able to successfully extubate them by the end of 2 weeks, maybe at the end of 3 weeks. If we are not able to extubate by end of 3 weeks, maybe the patient is not responding to the rapid therapy that we are giving. Sometimes the therapy to work too. So now how to identify? Actually, to identify myasthenic crisis, we should actually know what actually are the respiratory muscles which are getting involved in these myasthenic crisis. So patients, there are both the upper airway muscles and also lower airway muscles which are necessary for actually keeping the airway patent. The upper airway muscles, we have the tongue muscles. We have seen patients who have just tongue weakness, especially MUS patients. They just have tongue weakness, they present, and within few days one patient landed in crisis. The patients will have oropharyngeal muscle weakness, which will actually pull up the secretions, and it will actually increase the work of the breathing of already fatigued the lower respiratory muscles. And there are inspiratory muscles and also expiratory muscles. Actually, you all know this. Inspiratory, this is a standard stuff only. The inspiration is actually active, expiration is passive. Inspiration, we need actually the major muscles are the external intercostal muscles, and the accessory muscles are the sternocleidomastoid and scalene muscles and diaphragm. But what I would like to actually stress here is, in AChR receptor antibody associated myasthenic crisis, it is actually the external intercostal muscles which are actually become more weaker initially, followed by the scalene muscles. Diaphragm is usually late to get involved. Diaphragm is actually late to get involved. So if we actually see a patient who is actually exerting his sternocleidomastoid or the scalene muscles, the patients will definitely be in crisis. So how do we actually assess it? There are various spirometric tests, but however we don't use all these things bedside unless the patient comes from pulmonology with some neuromuscular weakness to us. So inspiratory, these are only two things, either inspiratory function is defective in them or expiratory function is defective in them. Inspiratory function, the parameters that we use are vital capacity or the negative inspiratory force. Inspiration is a negative thing, actually we inhale with force. So with what amount of the force we are actually inhaling is what is actually the inspiratory function. There are two parameters, actually vital capacity and NIF. Vital capacity less than 20 and negative inspiratory force less than 20. If it is there, then the patient is in crisis. But however, bedside or even in the clinic, we don't use all these things. So what a simple bedside clue is when the patient is actually recruiting the inspiratory muscles, that the accessory muscles of inspiration, that is scalene muscles, the sternocleidomastoid, the patient is in crisis. The expiratory function, we use expiration is actually a positive thing. We actually do positive expiratory force. the positive with the what amount of the force actually the patient is pushing the air from out of the lungs. The positive expiratory force, it is just double than the negative inspiratory force. It is very simple. That is 20, this is 40. If it is less than 40, then most likely the patient is in crisis. This test also we don't do routinely in our clinical practice. The simple test is do a single breath count. If the single breath count, the patient is not able to generate adequate amount of the force so that he is not able to count beyond 40 or beyond 15, then patient is in crisis. Or the patient has a very weak cuff, he is not able to, for actually cuffing we need lot of expiratory force also. The patient is not able to cuff and it is a very weak cuff, then it is an expiratory function. So simple things are when the sternocleidomastoid or the scalene muscles are more active, or the patient has a weak cuff, or a patient has a single breath count which is not enough to actually less than 20, then patient probably is in crisis. The next step when we make a diagnosis of crisis is what triggered the crisis. Most of the times we actually search for the cause, 50% of the times we find, many times we don't find what is the cause also. So most common triggers are usually infections. The infections you also must have encountered, usually lung infections are the most common cause. And aspiration pneumonitis is most common cause because the patient is not able to actually maintain the secretions in the throat. So the surgeries, peripartum period, pregnancies, these are all the causes. We had one patient in peripartum period who developed in myasthenia, came in myasthenic crisis. And drugs are very, very important because many of the myasthenic patients, they actually land up with GPs if there is any respiratory distress. They usually start on macrolides or they usually start on fluoroquinolones and they develop crisis. These are all the antibiotics which actually precipitate the myasthenic crisis, and we should caution them. And maybe in the OPD book we should caution them that these drugs, these things should be avoided also. So, and whenever we taper the drugs, immunomodulatory drugs, before the disease has become under control, even then the patient can land in crisis. And some temperature extremes, pains, all these things post-operatively, all these things can cause myasthenic crisis. And there are a lot of drugs. This is actually a clumsy slide. Simply, I would say actually the antibiotics which are commonly used, that are fluoroquinolones, macrolides, and these are all the drugs which can actually precipitate myasthenic crisis. Even aminoglycosides, amikacin and gentamicin. So gentamicin and amikacin, these are actually given intravenous. Oral drugs which are very commonly used. Azithromycin, if a person has a throat infection, they will start on azithromycin. A UTI, they start on ofloxacin or norfloxacin. And loose motions, they start, and patients can land up in crisis. It is as simple. And especially cardiac drugs. Some are drugs which are very old, chloroquine, we are not using these days. Beta blockers can cause statins, we use left and right statins, they can cause myasthenic crisis too. So, and now immune checkpoint inhibitors, we had a patient in another unit of our hospital, there was an immune checkpoint for another cancer they have given, and patient developed neuromuscular weakness. We had it out whether it was myopathy or myasthenia, later it turned out to be myasthenic crisis. So these are all the drugs. And penicillamine, especially in Wilson's disease, very high doses sometimes can cause, and this penicillamine and some things they are usually given along with the Ayurvedic medicines also. The patients are used to those drugs, and they come in some form of weakness, and we turn out to be myasthenia. So once we identify the triggers, we have to actually treat the triggers too. But many of the times we search for the triggers, like hepatic encephalopathy, we search for the trigger, we don't find it. Similarly, in myasthenic crisis, also 50% of the patients we may not be able to find the triggers. So, is it cholinergic crisis? Second, another thing is cholinergic crisis. This is actually very, very kind of exaggerated thing. We have actually never seen this. Cholinergic crisis, if a patient was given very high doses of pyridostigmine. Pyridostigmine acts both at the nicotinic and also muscarinic. It is almost like an opioid poisoning patient. They come with vesiculations, they come with profuse secretions all over the body, lacrimation, even salivation, bronchoria, and even loose motions, diarrhea, and all those things. But actually, as per the literature, a retrospective series was done. They have not found any patients of cholinergic crisis. Even in myasthenic and cholinergic crisis, whatever it may be, we stop the drugs. Pyridostigmine we stop. That is the standard of care. So now we know what is what, triggers and other things, when to ventilate. Actually, it is always better to ventilate the patient, that is elective ventilation, not an emergency ventilation. Whenever we see a patient who is breathing in that pattern who is not good, it is better always to intubate the patient. Rather than, it may become, more complicated course if we actually wait. It is always elective than emergency. And these are the standard things that I told just before, which we may not actually measure bedside routinely. And clinical signs of respiratory distress, inadequate secretion clearance, we intubate the patient immediately. And how to intubate the patient? Actually, we give a sedative and also a muscle relaxant, but the sedative dose should be very less. So, and we intubate the patient, and the neuromuscular blocking agents, out of the two groups of neuromuscular blocking agents, depolarizing and non-depolarizing, it is better preferable to use the non-depolarizing agents, because non-depolarizing agents, that is vecuronium or rocuronium, are competitive antagonists. So the dose that is required could be very, very minimal. Whereas succinylcholine, they may need a very large dose because it is a partial agonist. They may need a large dose to actually do and for its efficacy. So non-depolarizing agents are preferred drugs because they may be used at a very lesser doses, and it has to be very rapid sequence intubation, not wait for long and all those things. Three rules are actually very low dose of sedatives, prefer non-depolarizing agents, and it has to be very rapid. And it is we have to intubate it electively. And what mode of ventilation we use? We use actually assist mode of ventilation with low PEEP, and this is also a standard stuff only to generate a good tidal volume. You put at a good tidal volume of 8 to 10 cc with a good pressure support to prevent atelectasis, so that the muscles are not getting actually more fatigued, so to decrease the work of the breathing. So is there any role of NIV? Yes, this is actually a newer thing. Actually, NIV patients, some patients of myasthenic crisis do respond to NIV where there are no much upper airway muscles which are actually involved. So it is otherwise an individualized approach. Whenever who are actually expected to improve very quickly, who have very adequate cough, who are actually not so much of respiratory acidosis, such patients who can tolerate the mask also very well, NIV still has a role in patients with myasthenic crisis. And there is a study also. This is a study of 250 patients. This is the largest series of patients of myasthenic crisis. This is the largest study. Out of the 250 patients, 92 patients were managed with NIV, and out of the 50% did well with NIV, and 50% went on to develop invasive ventilation. And the risk factors for ventilation are very hypercapnia and other high baseline, very uncontrolled myasthenia gravis status before, and all those things. So now always we have confusions, what to give at the myasthenic crisis, what not to give. So should we give pyridostigmine during the crisis? The strict answer is yes, it has to be stopped temporarily, because pyridostigmine is actually anticholinesterase inhibitor, so it will cause lot of secretions. So the airway protection and airway management will be very difficult. That is one reason. And the second reason is it confounds the assessment of the therapies that we are also giving. Actually what we do is we give IVIG or plasma exchange. We are actually removing all the antibodies from the body. So whether the patient is responding to pyridostigmine or whether he is responding to the immunotherapy also, we don't know. So for weaning off, actually we want to know how effective was our immunotherapy that we give. So it confounds the assessment, but when to initiate? Once we actually were very clear in our assessment that yes, our immunotherapy has worked and we are able to come down on the tidal volumes and the supports, then maybe we can initiate before extubation. Just before the day of extubation, you initiate pyridostigmine and remove the tube. So that is the time of ideal time of stopping and also initiation of pyridostigmine. Now, should we administer the steroids during the crisis is the next question. Any immunotherapy, actually, because there are infective triggers also that I have told you. So the infection, we have to, it is again an individualized thing. The infection is very severe, then we have to think it and cover it with appropriate antibiotics and start steroids. And even the corticosteroids, they actually worsen myasthenia in some subset of patients. I will show you some literature about it. There are various mechanisms also. when actually crisis we start steroids in the same time, because the steroids once we start, they start acting at the end of 10 days to 2 weeks. So by that time actually our effect of the IVIG-RN will actually wear off. So by that time we are actually supplanting with the corticosteroids. That is the idea of giving steroids in the crisis under the cover of good antibiotics if there is an infection. So what are the mechanisms? Why actually some patients will worsen with steroids? Because steroids will cause lymphopenia, because they break the lymphocytes. Once the lymphocytes break, there is a lot of antibodies which are released, and these antibodies can actually worsen myasthenia. There is also increased activity of the cholinesterase at the neuromuscular junctions also. And overall there are a lot of immune reactions, but still there is are actually planning steroids in the OPD. We start 10 milligram and ask the patient to come again after 1 week, or call her how you are, and we start slowly. If the patient is admitted and already we are taking care of his initial part and the patient has crisis, then it is better to start off with a high dose. High dose steroids actually have high risk of going into myasthenic crisis, and rest of all the parameters suggest that it's a very badly controlled disease, can have worsening of the myasthenic crisis too. Next, how to rapidly control the disease. It is not just about the steroids and also the pyridostigmine. We have to actually reboot, actually we have to actually smoothen the immunological terrain which has gone actually berserk in patients with myasthenic crisis. So we have to remove the antibodies very fast. Whatever antibodies are there which are very fast. How to remove? These are all the standard stuff only. There are only two therapies, plasma exchange and also IVIG. Plasma exchange actually will directly remove the antibodies from the circulation, whereas IVIGs will neutralize the antibodies existing in the body. The advantage of plasma exchange is it works little bit slightly faster because we are removing the antibodies fast. So that maybe a plasma exchange you may see the effect by 3rd day, 4th day, whereas IVIG you may see effect by the end of 1st week. So both are actually equally efficacious. There is a lot of literature which is superior, which is not. But ultimately all the standard, there are 3-4 studies which show that actually both are equally efficacious. Either IVIG is too costly, otherwise both are equally efficacious. So these are all the various studies which I will rush through because of the time. This is a comparative analysis. IVIG showed similar clinical and perhaps superior economic outcomes in the myasthenia. This is a Cochrane Library meta-analysis. This systematic review comparing the trials of plasma exchange found no convincing difference in the beneficial effects of these therapies for treating exacerbation and myasthenia gravis. So this is a recommendation in 2016 which has come up. Although clinical trials suggest equivalence, expert consensus suggests that plasma exchange is more effective and works more quickly in treating the patients of impending or manifest crisis. Actually speaking, in our clinical practice in care, we stopped using plasma exchange. We are using only IVIG for most patients, and our patients are doing well only. I remember using plasma exchange only once in one patient, twice in patients with myasthenic crisis. And apart from these rapid therapies, I will actually go to newer rapid therapies also. Any other metabolic derangements also, the people in crisis, they will be in ICU, there will be a lot of metabolic derangements. Do these also have any effect on the outcome? Yes. The patients with hypokalemias, they will have effect on the muscle weakness. Hypomagnesemias will have effect on the muscle weakness, phosphate depletion. All these things have to be corrected so that we have a very good outcome. And if the patient's hematocrit or the HB is less than 7, it is better to transfuse so that we give less work to the muscles which are already fatigued, and also adequate nutrition and maintain the albumin and also rest of the things. What beyond IVIG? If the patient has failed IVIG, is not responding to the IVIG or plasma exchange, actually what can be done? There are actually newer drugs which actually see. Basically the issue is we have to, in the rapid therapy we have to remove the antibodies which are causing the problem very fast. which works very fast. Apart from IVIG and plasma exchange, whatever drugs we have, corticosteroids, maximum it will take 10-15 days. You cannot wait so long. So any drug which will actually deplete the antibodies fast will work in an acute phase. So this is eculizumab. Eculizumab is a complement inhibitor, as you can see on the left hand side, complement inhibitor. So it is a complement inhibitor. Ultimately what will happen, antibody will unite with the antigen and they will combine with the complement and they will cause complete damage to the body. So this is a REGAIN study, which is a standard study which came in 2016, which actually helped FDA to approve eculizumab in actually 2017, and from then on eculizumab is used in generalized myasthenia gravis who are AChR positive. However, this is a recent paper, but it was not actually recommended for myasthenic crisis, because eculizumab was actually shown in the study that it can deplete the antibodies within 2 days only in the body. So suitable indications, this is the latest paper. Actually, as you can see here on the left hand side, REGAIN criteria, those are all the standard stuff as per the trial. The left hand, as per the suitable indications, even myasthenic crisis also eculizumab can be used. However, it is very costly. So the other method of drug is neonatal FcRn inhibitors. Neonatal FcRn inhibitors are actually the drugs which prevent the lysis of the antibody, antibodies. Actually, the newer drug which has come into the market, Vyvgart is approved in the US in 2021. This is efgartigimod. This actually can deplete the antibodies very fast within 2 days. So this is actually approved it is not available in India. One company is trying to get it, but not yet. So this is also can be used, it can deplete in rapid therapy. However, we have our standard stuff, rituximab, how early we can actually deplete, but rituximab will help in patients of myasthenia very, very well. It can also deplete the antibodies, if not very fast, it can deplete antibodies, it can deplete the CD19-20 cells within 1 week. We can try this if those two drugs are not working. That's the presentation and the management. I am coming to last 2-3 minutes. Does presentation and the management change with the antibody type? Initially I just gave some statistics which are actually generalized statistics about myasthenia gravis. But actually MuSK antibody myasthenic gravis crisis has actually specific features. MuSK antibody myasthenia will have predominant complaints which are actually bulbar and also tongue muscles. Upper respiratory muscles are predominantly involved along with the lower respiratory muscles too. Upper respiratory muscles, when they are dysfunctional, they will have a lot of burden on already fatigued lower respiratory muscles too. So this is one study, actually it showed that MuSK antibody myasthenic crisis actually will not do well in long run. It will have longer ICU stay, days to mechanical ventilation are very high and days in hospital stay also very more. They did not do so well like ICHR antibody positive myasthenic crisis. And there is some entity called seronegative also. If both are negative, we call it as a double seronegative or seronegative myasthenic crisis. They actually fairly do well, behave similarly with responses similar to ACHR positive myasthenic crisis. And when to institute chronic therapy, if it permits and if there is no good infection focus, we can start concurrent same time immunotherapy, so that because anyway microfiltrate azathioprine we had, it will take almost 2 months, 6 weeks to work. So can we predict post-op crisis? This is a post-op crisis is another entity. So can we predict post-op crisis? Yes, we can predict post-op crisis based on some features. As you can see here, if there is already previous history of myasthenic crisis, they are more prone to develop a post-surgical myasthenic crisis. If the patient's general condition, generally the myasthenia itself is very higher grade, MGFA higher grade, they are more prone to myasthenic crisis. If they have bulbar symptoms or thymoma, they can actually more prone to myasthenic crisis. So if the disease is not under control, actually we give before only IVIG and stabilize the patient and then only take up for surgery if one of these risk factors are there. So this is another paper and it showed almost similar features only. So that's all about the things. The newer things are rapid therapies, maybe 2-3 drugs which may be useful if the IVIG or plasma exchange fails. So the take-home message I will summarize. So weakness, what is myasthenia? The patient 20% have the initial present only as myasthenic crisis and 20% will have life risk. The lung function parameters I told, vital capacity and the negative inspiratory force, and expiration is positive expiratory force. It is something like 10, 20, 40 rule. Less than 10 vital capacity, to less than NIF 20 and less than 40 PEF is equal to myasthenic crisis. However, bedside assessment, simple assessment of the accessory inspiratory muscles, single breath count and weak cough is equal to myasthenic crisis. We have dealt about triggers and also drugs. We should be cautious about the infections and also antibiotics. Actually, cholinergic crisis is very rare, but it is almost non-existent. We have not seen in our almost 8-9 years of practice. And regarding the ventilation, it has to be elective. We have to be very cautious about the neuromuscular blocking agents, and it should be rapid sequence intubation, assist ventilation with adequate tidal volume and PEEP, and BiPAP patients have also a role in intubations. And strictly stop anticholinergic stress drugs and start before extubation. Again, once you feel that your rapid therapy has worked well, start high-dose steroid. However, there is a caution on worsening. However, that will be taken care of by the rapid therapy that you are attempting. And rapid treatments are plasma exchange and IVIG, and newer and speculative drugs. Yes, eculizumab is now coming up. Vyvgart, that is efgartigimod, is coming up. Rituximab also can be tried. Chronic therapy should be initiated in the crisis only, because anyway the drugs will take time to act by the time the rapid therapy is wearing off. A muscle crisis, it will have upper muscles and longer stress. Seronegative crisis, they are very late to get come and outcomes almost similar. And we have some pre-operative, post-operative myasthenic crisis. If there are one of these risk factors, it is better to treat them with IVIG and then only take up for surgery. That's all. Thank you.
As usual, nice presentation, Murali. How do we define respiratory myasthenia? When we call respiratory myasthenia.
Refractive myasthenia is the one when they are not actually responding to two types of immunotherapies, then we call them as refractive, but after giving them for adequate time, at least for 3 to 6 months.
Like
Azathioprine, mycophenolate.
Then what is the next step?
Or if they are actually giving very steroid dose, we are not able to taper, then we call it as a refractory myasthenia. Actually, we can use now even for ACHR positive myasthenia gravis also. Rituximab is actually now recommended, madam. Actually, we can give rituximab, we can give the newer drugs, we can use cyclosporine. Methotrexate trial has failed, but some patients do respond to methotrexate.
Which antibiotics you suggest? Because most of the antibiotics trigger myasthenia. Infection is a trigger for crisis.
Cephalosporins are cephalosporins we can give.
Okay. Magnesium is not help. Magnesium is one of the cause for unmasking myasthenia, especially in women who are given mag cells for eclampsia. They may come with myasthenia.
Yes, ma'am. It just slipped from the table. It is
that is important drug.
Yes,
Next to all these other drugs.
Magnesium can respect crisis.
Any more questions?
Statins all cardiac patients and stroke patients are, so how do you said one of the precipitating factors is statins.
Yes, sir.
Without that the patient cannot survive with the cardiac.
We can temporarily stop, sir.
Myasthenia is lifelong, no, you don't want, lifelong you have to stop.
Actually, it is not that we have seen triggers, sir. It is not that all patients will have the same trigger kind of thing. Even some patients tolerate ofloxacin, norfloxacin also very well. We may have to explore the newer statins actually.
Off the record.
Yes.
No, it's not like that. Maybe the correct recommendation is that you can give statin at a lower dose. That's it. Even myasthenia patients. You can refer statin.
Yes, sir. We had one patient who took very long time to recover.
Myasthenia crisis.
Myasthenia.
You said in your commentary was not there. Plasma exchange. How did you give the patient?
We gave rituximab, sir. We gave IVIG followed by rituximab.
Myasthenia crisis actually must myasthenia and treatment of plasma exchange. So the respond with IVIG.
the crisis is over, why don't you start on the myasthenia patient? Because they don't respond quite.
Most of our myasthenia patients will be on rituximab cycles only, madam. Because it is an IgG for one of the IgG for disease, so they respond very well to rituximab. No, no.
This thing is actually most of the times in myasthenic crisis, mostly the plasma, in our center we do plasma exchange. We find plasma exchange to be more beneficial. Response is rapid actually, because you know that in one cycle you can remove 50% of antibodies in first cycle itself, and second cycle 6 days, third cycle 70%. By the time we wean off them from the ventilator, we give it exam. Yes, patients can decide them.
Yes, sir. Plasma exchange is well. I mean, it is definitely there. What means ultimately what we feel is anyway plasma exchange of 10 days of hospital stay, the cost will be almost same only. And we have seen IVIG was more safer without any infections. Already a patient came with infection to us with hypertension.
And more convenient to give.
More convenient also to give.
Sir, what is your take on pre-op management of thymoma, sir? If patient does not have any symptoms, and if patient has only ocular symptoms, and if patient has generalized myasthenia, so how to take up these patients for surgery? I mean, do you advise IVIG before surgery or stabilization on steroids?
No, stabilization on steroids should be fine. Actually, thymoma itself can be a risk factor for post-operative crisis too. But I mean, if that is the only thing, otherwise the disease is well controlled, his Osserman's or MGF grading is well down, 1, 2, you're told only ocular symptoms, so it is hardly one. Such patients actually we can take up directly for surgery.
Yes. What is trying to predict effect? Like they are very high, very medium, low.
Usually some centers what they do is they do 2 exchanges before taking the time. 2 time to assess the patient again. That is first thing for other 2 cycles after surgery.
The treatment especially is very individualized. There is no set of guidelines, anything like that. As far as the disease is well stable, we can take it.
Are there any false positive electrical receptor antibodies?
Yes, ma'am. The ACHR antibodies can be normally present in the human body. So with increasing age, they could be positive. 2% of the population will normally also have ACHR. We had one patient who had neuromuscular weakness only. ACHR was outside and it was positive. It was around 0.8 like that. We also went into the trap and felt that it was myasthenia, initially treated like that. But after the 15 days when he was not responding, then maybe we felt that later it turned out to be ALS. ACHR can be positive.
Same case we also had. He underwent antibody test for dysphagia. He was referred to our hospital because we give IVIG free. So he was referred for IVIG. And on examination we found it is motor neuron disease.
LRP for antibody, there is no literature, especially on the crisis in LRP for specific features. LRP for actually is an internet disease. The patients will have usually very mild symptoms and they do actually very well, respond well to the therapy.
My thesis was on myasthenia with pencil wick. 20 years back, where we did procedure doppler vaccine. I found around 2% of normal individuals in the population being positive for ACHR. And none of our patients who are on Wilson's on pencil wick.
Their antibody positivity is almost similar to that of general population. None of our patients have developed myasthenia. In fact, this was published in Green Journal in 2003. So the classical teaching is D-penicillin causes myasthenia. In fact, it causes myasthenia in patients who are prone to have autoimmune disorders. In our series of NIMADs, actually, there are so many patients on Wilson's, none of them had myasthenia, and all the reported literature prior to that, even after that also, the patients who developed myasthenia gravis were autoimmune, they are having underlying autoimmune disease like hydrotoxicosis, rheumatoid arthritis, and then Sjogren's and all that, for which insulin was given.
I request Sridhar Lakshmi ma'am to felicitate Dr. Muralidhar Reddy sir. It's already 1:30. We will have one last session before we break for lunch. The topic for the session is chronic SDH management. I request Dr. Manas sir, Chief Consultant Neurosurgeon, KIMS, to chair the session. The speaker is Dr. T.V.R.K. Murthy sir.
Good morning. The next topic is chronic subdural hematoma, which is a very common topic, usually diagnosed by neurophysicians and sent to neurosurgeons. Normally, it's diagnosed, they present with dementia, that's why they go to neurologists, and only maybe half of them come with a history of trauma. I request Dr. Ramakrishna, who is from Nizams and then worked as a faculty at Nizams for many years, and then has been working as a senior consultant at Care Hospital, Sanjana, Hyderabad City.
Respected chairpersons, seniors in the audience, and dear friends. At the outset, I would like to thank Dr. Radhakrishna and Dr. Srikanth for giving me this opportunity to talk about chronic subdural hematomas, even though the topic is a little off of the general discussion which has been going on since morning. I also request my chairperson, Dr. Manas, to please interrupt me at 20 minutes, because otherwise I will be eaten away by all of you. All of you look so hungry. So today's topic, I will be discussing about chronic subdural hematomas. As Dr. Manas has already told, this is one of the very commonest problems which we come across as neurosurgeon. See, this slide shows actually four different scenarios, four different cases. The first is hydrocephalus, second chronic subdural hematomas, an aneurysm, and a lesion in the region of the CPRP. So these are the common neurosurgical cases which we come across in our daily, day-to-day profession. These hydrocephalus and chronic subdural hematomas, actually, if somebody says that they constitute the bread and butter of neurosurgeons, especially cranial neurosurgeons, then it will not be wrong, because the number of cases which we come across is huge. And of late, in my practice I have seen, and probably in most of the other neurosurgical colleagues also, we are seeing less and less of hydrocephalus and more of chronic subdural hematomas. So why studying about chronic subdural hematomas is important? Because, as I told you, it is one of the most common neurosurgical emergency procedure, and the incidence is rising, and it is expected to double by around 2040. So this is one editorial which has been written by Dr. Sanjay Bihari, who was earlier the head of the department at the Sanjay Gandhi Institute, SGPGI, and now is the director of Sri Chitra Tirunal. As he was writing the editorial for one of the articles on chronic subdural hematomas, he has written that the evacuation of chronic subdural hematoma represents the second most neglected neurosurgical procedure, the first being ventricular peritoneal shunt surgery, the current neurosurgical practice. The procedure is often unsupervised, carried out under local anesthesia or regional blocks by the junior-most members of the neurosurgical team at unearthly hours, usually in elderly patients with significant life-threatening comorbidities who may also be on anticoagulants. I mean, he has actually hit the nail on the head. This is what happens with chronic subdural hematomas. And if you think that there is not much to discuss about chronic subdural hematomas, let me tell you that after a quarter of a century in neurosurgery, still chronic subdural hematomas give us sleepless nights. So just before going into the discussion, I thought just 2 or 3 cases I will highlight. This is one patient, a 62-year-old gentleman, who was actually underwent a mechanical mitral valve replacement about 3 or 4 years back, had a minor injury, and you can see that there is an isogenic subdural on the left side. And then once we operated that, a subdural has a hypodense or a layering type of subdural has appeared on the right side. And then continuously every day morning the neurologist and cardiologist are breathing down my neck that they have to restart anticoagulation because the patient has a mitral valve, mechanical mitral valve. And every day we see the cardiologist with their echo telling that the gradients are increasing and all those things. And then we thought that anyway, obviously we will not be able to restart anticoagulants with that subdural, and we thought we will operate on that. I don't have the slide of the scan of the immediate post-operative, but the subdural after surgery also remained the same size. Then because the patient had to be started on anticoagulants, we did a decompressive craniotomy to remove the subdural. This is the immediate post-operative scan. And probably 1 week down the line, again we see that there is a small correction. Now, can we start this patient on anticoagulants? And the cardiologist every day says that the gradients are increasing, you have to start, otherwise the mitral valve gets stuck. So, one of the few very difficult cases which we had come across. Similar case, these chronic subdural hematomas are sometimes very resistant to treatment. You operate, put a valve on it, it doesn't go, then you do a decompressive craniotomy and then only it goes. This is another patient where we have done a programmable ventricular peritoneal shunt for a normal pressure hydrocephalus. Patient perfectly recovered, ataxia recovered, his urinary incontinence recovered. He didn't have dementia pre-operative. And 2 months later, he comes with a left hemiparesis. And we see that there is a subdural which has formed in the right hemispheric region. Then what is to be done for this? Whether we change the pressure of the shunt. So what we did was, because obviously the reason for this is that the shunt is draining and that is why the subdural has formed. So what we did was increase the pressure in the programmable shunt. But the hemiparesis did recover even after a week. And then so even after a week, the hemiparesis didn't recover. Then we had to drain the subdural, put in a drain there, and still you can see that in the post-operative period also, you can see that there is some amount of correction still remain. Just to give an idea, actually when the idea of chronic subdural hematomas, I thought I will present as a neurosurgical emergency, then one of my colleagues remarked, what is there to be discussed in chronic subdural hematomas? But just to give an idea of the number of publications which we are coming across in the last maybe 70 or 80 years, you can see that there is a serial increase in the number of publications in chronic subdural hematomas which has come. And as is the general principle in medicine, if the number of publications increase in medicine, then that indicates that you are not sure about what is to be done and you don't know anything about the disease. Am I correct or not? So I mean, if there is a sure shot treatment, obviously there will be no publications on that. So the incidence, chronic subdural hematomas, there is a significant increase in incidence of chronic subdural hematomas in the last 2 decades, as I mentioned earlier. So initially it was 36 in 1 lakh population, has increased to 91 in 1 lakh population. And the reasons why this increase is probably because we have got imaging facilities in every nook and corner of the state and the country. More and more people are getting diagnosed because of the investigations. And also, as all of you know, chronic subdural hematoma is actually a disease of the elderly. It is mostly seen in patients who are more than 60 or 65 years of age. And the life expectancy, because of other medical developments, has increased significantly, and probably that is the reason we are having more and more. But they say that the incidence is likely to increase further, and I mean, probably it will be one of the most commonly done surgeries in probably in the next 10 years. So I think all the residents and the community should be aware of all these things. Pathophysiology, very briefly, I will tell you. I will not bore you much. So here. So this is the cross section of the meninges. This is the dura. The first three layers is the dura, then the arachnoid trabeculum, and the innermost layer is the pia. So what exactly happens? There have been different theories which have been put forward. Again, when different theories are put forward, it always means that we don't know what exactly is happening, and these are all hypotheses. But the hypothesis which is still holding on right now is that the dura has three layers: the periosteal dura, the meningeal dura, and there is a dural border cells. This is the third layer. So when there is a minor injury, which most of these patients complain of, there is a tear in the dural border cells, leads to inflammation. With inflammation comes in more and more number of macrophages and blood cells, angiogenesis, neoangiogenesis, and leaking blood vessels. And as a result of the leaking blood vessels, exudate is formed, more and more blood gets collected there. And as more and more blood gets collected there, the dural cell layer actually splits away from the meningeal dura, creating more of space and more angiogenesis, and that becomes a positive feedback cycle. That is probably the cause of chronic subdural necrosis. This is not moving. So this is that is what I was explaining. I don't know, this slide may not move back. Okay, right. So that is what I was trying to explain. This is the pathogenesis. We, even though people say that chronic subdural hematomas is precipitated by a fall, which the patient complains of between 3 weeks to 3 months before presentation, but the history of fall sometimes may be so trivial that the patient might have forgotten about the fall, and but in 70 to 80% of the patients, they might remember some sort of an injury. Now the most important thing is, any patient, actually not most, any patient, please excuse me for saying this, but any patient who goes to a cardiologist and neurologist is always on antiplatelets. And antiplatelets are the worst enemies of neurosurgeons. So you can see that 20 to 30% of the patients, antiplatelets, anticoagulants. One very important thing, especially for the neurology colleagues here, I would like to stress is that they have actually done a study in Frontiers of Neurology. It has come in Frontiers of Neurology in 2019. And when they take the clinical symptomatology of the patients who are less than 50 years and more than 50 years, there is actually a significant difference in the type of symptomatology which these patients present with. In patients who are less than 50 years of age, the more common symptoms are in favor of raised ICT in the form of headache, vomitings, headache and vomiting and limb weakness. Whereas in patients who present beyond 50 years of age, the more common type of presentation is actually gait disturbance or falls, where you can see 50% of the patients present with this, or they might have some limb weakness. So the presentation in elderly people may not be the typical presentation of a raised ICT. So that is what has to be kept in mind, and most of these patients have to be investigated thoroughly to rule out a chronic subdural hematoma. Reason being that it is a very, we can treat it so well that we can give actually a normal life to the patient. So now, actually, the next few slides I will try to run through, because we have more of neurology population here, may not be interesting for the neurology people. But what are the criteria for surgery? This I think everybody should concentrate on. Clinical, if a patient has the symptoms which we had discussed in the previous slide, yes, there is a definite yes. But if you see a chronic subdural on MRI or CT scan, is it an immediate indication for surgery? Is something which literature is not very clear about. But any chronic subdural hematoma greater than 1 centimeter thickness, we have to seriously consider surgery. But this is not a 100% yes. Clinically it is 100% yes, but here we always have a possibility of waiting and watching the patient. Age is never a contraindication. This should be built very firmly, especially in the young population, because we have operated on patients who are more than 90 years of age and with excellent results, and they come back with almost near normal. So, coming to the surgical management, E-surgery, I mean, these are the points which, as Dr. Murli was discussing, we can just discuss on the points, on the basis of points. E-surgery for chronic subdural hematomas and emergency. So once we decide that a patient, either clinically or radiologically, who is showing a significant mass effect, needs surgery, then even though the name suggests a chronicity, it is an emergency. So I would actually suggest to the younger population and also to the neurophysician crowds here that chronic subdural hematoma is an emergency. In my experience of more than 25 years of neurosurgery, I have seen 2 patients who have lost their lives. Reason being, 2 of my patients. Reason being that the patient has come at around 11 o'clock in the night. I thought we will operate in the morning, and the patient phones or something happens to the patient in the middle of the night around 2 or 3 o'clock, and by the time we go and do the surgery at that time, the patient, it is very difficult to retrieve the patient. So these are emergencies, and I would suggest that in case if any of us are busy, suppose the patient comes at 9 o'clock or 10 o'clock, it is always better that these patients are operated as an emergency, except in conditions where the patient is so clinically stable and the mass effect of the CT scan or MRI is not so severe that we can wait, or if the patient is on antiplatelets and needs correction of the antiplatelet medication before surgery. So anesthesia, I'll just run through anesthesia because there are different studies. There are multiple randomized controlled trials in subdural hematomas anesthesia, and probably the best anesthesia is to do it under local anesthesia with some sort of a mild sedation which we give to the patient when we are putting in the burr hole. Type of surgical procedure, there are different types of surgical procedure, putting a visceral, putting a burr hole, doing a craniotomy, and doing a decompressive craniotomy. But according to the literature, according to all these articles, it says that there is a class 3 evidence suggesting that there is no difference in mortality and morbidity or recurrence between burr hole and visceral. But they say that craniotomy has a little higher complication. And finally, actually, even according to this randomized trial, they say that burr hole is the best way to treat chronic subdural hematomas because the risk of any long-term effects or side effects with a burr hole is considerably lower compared to either a twisted or a craniotomy. Twisted for the neurology population here is something like a bedside procedure where you put in a small drill and make a small opening of maybe 2 or 3 millimeters across and try to drain the subdural. Single versus 2 burr hole, there is actually no clear-cut evidence of which should be followed. Earlier, when I was a resident, we are always using 2 burr holes. Now we are using single burr hole, and the results have not been different, even according to the literature. That whether to irrigate it or not, whether to drain out the subdural by after putting the burr hole, whether to drain out the subdural by infusing saline. Again, there is no clear-cut evidence to say that irrigation really helps. But for people who are comfortable with irrigation, which is most of us, most of the neurosurgeons do irrigate. Irrigating, I think this is a point which I have learned when I was going through the literature. Irrigating at body temperature has a significant it gives a significant benefit. There is a class 1 evidence to suggest superiority of body-warm irrigation versus room temperature irrigation with respect to chronic subdural hematoma recurrence. So probably from the next time onwards we will do that. Putting a drain or not, again there is the evidence is very clear cut that always we put in a drain. How long to put the drain? This is the article which I was, this is coming in Neurology India from India. And how long to use the drain? 24 hours, 48 hours really doesn't make any difference, and most of us take out the drains in 24 hours. The main reason for our taking out the drain out in 24 hours is so that the patient doesn't have any post-operative infective complications. Different types of drains are there. There is a subperiosteal drain, that is, it is placed outside the skull in the area, in the periosteal region. There is a subdural drain, and they say that subperiosteal drain is actually shows lesser number of complications compared to a subdural drain. But all of us, I think most of us, routinely use a subdural drain. when to mobilize. This is one very important thing. These patients should always be mobilized as early as possible because we are dealing with an elderly set of population, and to keep them long in bed, we are making them prone to multiple issues. This is one thing which probably I thought is very important for me when I was going through the literature, because I am a big fan of doing repeat CT scans. And the literature shows that there is actually a randomized controlled trial that subdural hematomas should never be followed up with CT scans in the immediate post-operative period, because definitely there will be some amount of collection, and we are not sure whether to take out that collection or leave it alone. But what this trial says is that follow them up clinically. Only if they deteriorate in the post-operative period, then do a CT scan, and then probably do a re-evacuation or something like that. So this is something which I have learned with this. Recurrence rate, as I told you, is very high, in 8 to 30%. Complications 0 to 25%. 0 is never possible. I think it's a watched-up study for a patient. For somebody who claims that he has a 0 complication rate, either the surgeon is not operating at all, or he must be a super surgeon next or equal to God himself. Now, the patients who are on antiplatelets, I think we will need the help of our neurology colleagues here. So what is to be done for the patients who are on antiplatelets, which we come across very often, and especially in our practice, we see a lot of patients who are on antiplatelets. So what is to be done for them? So it all depends on why the antiplatelets have been started. I'm just finishing up now. So why the antiplatelets have been started? If a patient who is on dual antiplatelets, probably better to give platelet transfusions before we take him up for surgery, and that too as soon as possible. If the patient is on a single antiplatelet, only aspirin, then probably we can go ahead with surgery directly. If the patient is on anticoagulants, it is always better to reverse the anticoagulation by vitamin K or other medicines before we take it for surgery. Now the question is when to restart the patients on antiplatelets. So the literature says that if the patient is on a prophylactic antiplatelets, then wait for a month. If the patient is something like a mechanical heart valve or something which needs early anticoagulants and antiplatelets, then probably 3 days to 3 weeks is the time frame which has been given, but there is no clear-cut again literature on that. Bridging therapy, I don't think I need to spend time on bridging therapy, especially with the neurologists here. What to do when bilateral subdural hematomas? Yes, it is again a problem, and whether to operate both sides or I think all this has to be more of an individualized. Now, what about usage of antiplatelets? We use antiplatelets regularly. I think most of the neurosurgeons might use it, but there is no literature to support it. The question which we come across is when can I drive? And according to US and Europe, you cannot drive for 6 months after subdural hematoma surgery. India, we don't have any fixed criteria. And what to do with the visceral membrane? When we operate on a subdural hematoma, there are actually two membranes, the parietal and visceral membrane. So there is no need to touch the visceral membrane, the membrane which is directly over the brain. And one more last thing I thought, see, this is one therapy which is coming up in the management of subdural hematomas, is the embolization of the middle meningeal artery. As I told you, see, the main pathology lies inside the dura, and you try to cut off the blood supply to the dura. Then what happens is the basic hypothesis is that we will be able to prevent the angiogenesis and all those things, all those cascades which is happening, and so we'll be able to control the subdural hematoma. So this is actually a very upcoming and promising thing. A lot of trials have been done on this, and they have reported good outcomes. Usage of steroids and statins also has been done, and probably multiple studies are there which show good results with the use of steroids and statins. So just this is a summary of what we do, what has been But I would like to stress again to the resident population here that in spite of so much of literature, I think we should always stick on to what your teachers have taught you and then probably try to refine in the light of this knowledge and the randomized control trials. So in our experience, why actually we thought we should really go into all these things is that in the last 3 years where we had operated around 168 patients, we found that around 36 out of the 168, that is about 20% of these patients were actually needing re-operations. And so then we thought we'll just go into the literature and also see whether we are on the correct track, and that is how this thing has actually come. Thank you. So I hope it take you for long, and I'm taking.
Thanks. Before lunch, there will be some questions. Thank you, Dr. Over you.
Sir, how do we minimize the cost of pneumocapillary surgery common?
See, actually, surgery on a chronic subdural is we are doing surgery on an atrophic brain. So we may not, we don't expect the brain to immediately expand up and clear and fill up the space. So what we normally do is that we put the bubble in the frontal region, in the region where it is the most on the topmost part. So and then while closing, what we do is we continuously irrigate into the chronic subdural and elevate the head end so that the bubble place where we have put becomes this topmost part. In spite of that, there will be some amount of pneumocephalus which may not be very dangerous also. Usually air gets absorbed also.
Yeah, but if you do continuous connect the irrigation to the drain tube, continuously irrigate till your last insuture is done, and most of the air is driven out.
Still, sometimes you see most of the
Sometimes still they have, but they are not symptomatic.
Yes, sir. Many cases where we had infarcts, many cases where we had infarcts, fatal cases, development of infarct.
Infarcts.
Because most of the cases they have CV or LV90 replacement now. One case recently I had a small case of CV.
So you meant to say that because you stopped antiplatelets, the patient developed a stroke. I think I was lucky that none of my patients had, but it's a very genuine question, and I think sir is here. I think you should give the answer.
No, in fact, means that is nothing related to surgery. No, it is an
We
event
stop
because
antiplatelets?
I think 1 month ago we had a patient who operated on the right subdural and the patient with a hypertension. And he got up with weakness on the ipsilateral and scanned so the opposite side vessel entire got out. So it's nothing to do with the disease. It's something related to the premorbid condition.
One case of recently we had a bilateral subdural, small case of CVA, we stopped antiplatelets. Post-operative 12th day he developed an infarct. So like that how to again.
Generally, we start the antiplatelet drugs after 1 week to 10 days at low dose, and then slowly it will continue, unless there is a strict contraindication. Otherwise, you can start. Anticoagulants, as Divya has rightly pointed out, only in valve replacements. Then you have to start on 5th day or 6th day, and then continue. But otherwise, for atrial fibrillation, it can be delayed. It can take up after 2 weeks or 3 weeks also in this trial. So there are clinical guidelines in it. But as Sir is saying, they are also be highly individualized in a person, what are the other comorbidities or this similar.
There are one point if I added in bilateral subdural, always look for cause of intracranial hypotension. Do a whole spine MR to look for any CSF defect or leak or something which is responsible for bilateral subdural, especially if the patient has no history of trauma, not an antiplatelets and comes with a bilateral subdural. So if those are the groups, if you don't treat the spinal lesion, they'll come back with repeat recurrences. And with all the anticoagulants, I think people have started doing prophylactic middle meningeal artery embolization, so that then they can start early anticoagulant and antiplatelets.
But I think actually one of your personally I do not have any experience of sending my patients for MMA occlusion, but I think you in KIMS have been doing it.
We did for one case, which was a recurrent cerebral hematoma, is an elderly. But then if you look at the literature, people have doing right and left middle meningeal column is overdone.
What happened to this patient?
This patient recovered. Okay. We didn't have to reorder.
You have done for one case, no? Medical embolization. What happened to him?
Yes, sir. We did for one case, sir. So patient had a recurrent subdural hemorrhage. So he was having bilateral subdural hemorrhage. The right side was thicker compared to the left side, and he was having a hemiparesis also. So craniotomy was done. Craniotomy was done for the patient, followed by middle meningeal artery hemorrhage. He is doing well, sir. He is having some CKD also. He is dealing with that issue now. But MMA embolization was done, and it takes 1 or 2 months for that result to show up in the scan, sir. I mean, whether resolution happens or not.
So you did it electively or it was a recurrence?
For the recurrence.
Because now if you look at it, started to doing prophylactic middle meningeal.
Can you just coagulate the middle arteries, sir? Like when we are doing the burr can you put one more burr down and like just coagulate it? Like will it have the same effect like embolization?
No, can you repeat that question? I didn't understand it.
So like like for my patient the middle artery embolization was done, but in retrospect what I was thinking that like I made it craniotomy. Like for the right this one like because even after 2 burr holes nothing was coming out, so I had to convert it to craniotomy. So instead of going for embolization, was it possible to just coagulate the middle artery and will have the same effect?
That's it. I mean, actually, when you're cutting the dura, you can actually cut off the middle meningeal artery. So
Yeah.
it's going to give the same effect, isn't it?
Actually,
No, it will not give the same effect.
Actually, concept of embolization is PVA particles going distally into the vascular bed, sir, into the dura and cutting the supply there. So PVA particles are so small it goes into the capillaries also, not just occluding the proximal vessel. It will go into the capillaries and occlude the vessels. So recurrence of the subdural hemorrhage will be very less.
He told the petrogenesis of because it's a vascular membrane. Just coagulating the middle meningeal will not have the same effect like embolization. Thanks, Dr. Raman Krishna. We've been eliciting a very good discussion. Question.
State TVRK would be, sir.
I have a small announcement to make. At the end of the last part of the program, we have a quiz contest for all the junior colleagues, preferably students, but junior consultants also can participate. Whoever is interested, please give their names at the desk and give the names. And we'll be forming teams, 4 or 5 teams who have number, depending on the number. And this will happen from 4:30 or 5 o'clock to start, but it will be for about half an hour.
Thank you, sir. We will now break for lunch. There will also be very attractive prizes for the winners in the quiz competition. So now we will break for lunch. Lunch is served downstairs. Since we are running short of time, it will be for half an hour. If we can gather back at the earliest, it will be for the best.
శాతంతో ఆయన కూడా కోరుకుంటాడు అలా అని చెప్పి రాష్ట్రపతి పెట్టే ఉత్తరం సెకండ్ సార్ I'm doing that.
Good afternoon, everyone. I welcome you all back to the afternoon session. The first topic today will be on approach to meningitis, and I request Dr. Srikanth Javalkar sir, Professor and Head of the Department of Urology, KM Hospital, Nampally, to chair the session. The speaker is Professor Srikanth Lakshmi ma'am, Head of the Department of Urology, Osmania Medical College.
Good afternoon. I thought my talk will be before lunch so that all will be hungry and no questions. But now all will be sleepy, no questions. Anyhow, I am happy. So I am going to talk about approach to meningitis. So this is a patient, a 48-year-old lady, presented to the emergency department with history of being unwell with fever, vomiting, diarrhea and agitation. On examination, she has 101 degrees of fever, rash over the legs and she was irritable. Examination showed meningeal signs. The second patient is brought with history of headache, bad headache, fever, vomiting, and she had similar episodes 1 year and 6 months ago. Even she was febrile and she also showed meningeal signs. So in both these cases, the diagnosis looks like a meningitis. So first the meningitis, the clinical features of inflammation of the brain with continual fever was given by Thomas Willis. Later, Pinky, he did CSF analysis post lumbar puncture and which helped us to diagnose meningitis, and not only meningitis, many other diseases as well as therapeutic interventions were possible because of this lumbar puncture. In 19th century, Kernick and Brudzinski, they gave bedside examination of meninges. They gave two signs which bear their name, like Kernick sign and Brudzinski sign, in addition to neck stiffness, which is classical feature for the meningitis. So earlier days, the treatment of meningitis was with meningococcal antiserum. Later, penicillins and sulfamides were described. Then later, after the World War II, the treatment of meningitis dramatically improved and the mortality has reduced after the invention of and introduction of penicillins. So in these two patients, the differential diagnosis can be meningitis acute, either it can be bacterial or viral or tuberculous. Tuberculosis, what we think is it is chronic meningitis, but it can present like a permanent meningitis also. So that has to be included. Drug-induced aseptic meningitis, carcinomatous meningitis or lymphomatous meningitis are all to be considered in these two patients. Not only this, they can have non-infective causes of meningitis like Sjogren syndrome, SLE, sarcoid, which can affect the meninges, and also Behçet syndrome. If the temperature is not very high, you have to consider subarachnoid hemorrhage with sudden severe acute onset of headache. When there is associated impaired consciousness or seizure or focal neurological deficit, the disease extend to CVT, viral encephalitis, brain abscess. So a patient coming with fever, altered sensorium, neck stiffness, not only meningitis, you have to consider all these differential diagnoses in the evaluation of the patient. So most of the viral and bacterial meningitis, they present acutely, that is within hours to 1 to 2 days they come to the presentation. Whereas fungal, tuberculosis, usually they present with subacutely or chronically. So the classic triad of meningitis is fever, stiff neck and decreased sensorium. This is seen in only up to 45% of the patients. And other patients, they have any two of these signs. So if all the three are absent, we can exclude meningitis. Neck stiffness is frequently absent in patients who are comatose. And also very small young neonates, there also neck stiffness may not be there. In addition, without meningitis, you can find neck stiffness in subarachnoid hemorrhage or tetanus. And in addition to that, the patients who are very old or who are on immunosuppressants or who are on steroids or taking NSAID, fever can be absent. So in those cases, to detect meningitis is very difficult. Like stroke or epilepsy, meningitis also requires emergency management. Here also the time is brain. So various etiological agents for bacterial meningitis include pneumococci, streptococcus pneumonia or pneumococcal meningitis, Neisseria meningitis, Haemophilus meningitis, Staphylococcus, Listeria. These are different organisms, and the organisms vary depending upon the age of the patient, depending upon the comorbid conditions, associated immunosuppression or immunomodulatory or immunosuppressive drugs. Then the causative organisms differ. In neonates and infants, it is E. coli, that is gram-negative bacilli, in addition to beta hemolytic streptococcus, staph aureus, and Listeria monocytogenes. These are the causes. In elderly and immunocompromised, it is the Listeria which tops the rank, in addition to gram-negative bacteria. discuss about, because it's a neurological emergency, I'm going to discuss about aseptic, acute and recurrent meningitis. Chronic meningitis will leave right now. So the term aseptic meningitis was first introduced by Valgren. It's a community-acquired infection. When you call the aseptic meningitis, the culture should be negative, gram strain should be negative, there should not be any parameningeal focus or systemic illness. Patient should show only signs of meningeal irritation. So this is commonly produced by viral meningitis. So various causes of viral meningitis include enterovirus, arbovirus, herpes virus. Usually herpes type 2 produces meningitis, herpes 1 causes encephalitis. Lymphocytic chorea meningitis, varicella zoster, EB virus and cytomegalo. In addition, mumps, adenovirus and retro. Of these immunocompromised patients, they have more of adenovirus, Epstein-Barr, cytomegalovirus and HIV. These are more commonly immunocompromised people. So how to distinguish whether a patient comes acutely with headache, fever, vomiting? That idea depends upon viral meningitis or pyogenic meningitis. Duration is few hours. It is common in both. Then there are few points which can distinguish viral from pyogenic meningitis. The patient with pyogenic meningitis will be more sick, whereas viral meningitis is less sick. And if you go for CSF, CSF shows the glucose is reduced, pressure is raised, cell neutrophilic leukocytosis will be there in pyogenic meningitis, and CSF lactate and CRP will be elevated. Whereas in viral meningitis, there will be normal pressure, lymphocytic pleocytosis, even though some conditions they produce neutrophilic pleocytosis. And then CRP and lactate will be normal. If you take blood, the procalcitonin levels are high in a case of bacterial meningitis, they are normal in the viral meningitis. The blood cultures can grow bacterium, whereas in virus the cultures will be negative. And CRP is elevated in the pyogenic meningitis, whereas in viral it is mild elevation. Now there are so many inflammatory markers that are involved in the pathophysiology of the meningitis. Of these, interleukin 1 and interleukin 8, they are increased in the pyogenic meningitis, whereas interferon gamma will be elevated in the viral meningitis. In addition, you can do PCR. The viral PCRs like RT-PCR, HSV1 and HS2 PCR you can detect in the CSF, whereas in bacteria it's a 6S ribosomal RNA PCR that shows positivity for 6 organs, which I will tell you. So this is about all viral meningitis. Now recurrent meningitis. A patient, the second patient came with a similar attack 6 months and 1 year ago. So that means it's a recurrent meningitis. So various causes for recurrent meningitis include bacterial meningitis, viral meningitis and non-infectious causes. So first, if you think of recurrent bacterial meningitis, then you must find a cause that maybe there is some CSF leak which is causing recurrent bacterial meningitis. Usually it is a CSF rhinorrhea or CSF autoria. In addition to that, the patient who has a complement deficiency or immunoglobulin deficiency, they are also prone for recurrent bacterial meningitis. The detection of beta-2 transferrin in the nasal discharge, it is very sensitive marker for the CSF leak. So this is a contrast CT scan which shows leakage of the contrast material into the ethmoid sinus. The white arrow points to the ethmoid sinus, the contrast leak. That indicates there is a CSF leak because of some deficiency in the bone. Either trauma or there are non-traumatic CSF rhinorrheas where the patient is very obese, has rise intracranial pressure. With the pressure there will be remodeling of the bone and thinning of the bone. And intermittent rise of intracranial pressure due to coughing, sneezing or vomiting can cause this further remodeling and making the bone thin and can produce recurrent CSF rhinorrhea even without trauma or surgery. So then other cause of recurrent meningitis is viral meningitis, otherwise called Mollaret's meningitis. It was first described by Mollaret. It is characterized by recurrent episodes of meningitis. At least 3 episodes must be there, and each episode lasts for 2 to 5 days. And in between the episodes, the patient is not having any sequelae and is normal neurologically. It was thought to be due to because of HSV2 virus. But PCR may show or may not show HSV. There are some studies where the PCR is normal, it doesn't show any virus, and some studies show it is because of the herpes simplex virus 2 infection. During the episodes, the CSF shows pleocytosis and signs of meningeal irritation will be there. So what's the pathophysiology? It is supposed to be 3 mechanisms were put forward. One is toll-like 3 receptor deficiency, which predisposes to recurrent lymphocytic meningitis. And sometimes there are intracranial cysts like epidermal cysts. they can rupture and release the squamous material which can produce recurrent meningitis, otherwise called chemical meningitis. Even epidermolysis and craniopharyngioma are known to produce chemical meningitis. And it may be because of NSAID-induced hypersensitivity reaction which affects the meninges. So that I'll tell you the drug-induced meningitis. So this is the depict stain of the CSF showing many large activated monocytes. Actually, in a Mollaret's meningitis, what he described is Mollaret cells. They are very enlarged monocytes. In addition to that, the monocytes contain bilobed or trilobed or kidney-shaped. This is the kidney-shaped nucleus of monocyte. This is the ghost cell, discomated monocyte. This is the bilobed nucleus and this is the trilobed nucleus. These are the normal monocytes. So this is these cells are seen if you examine the CSF. So now we go to non-infectious causes of recurrent meningitis. They include inflammatory disorders like IG4 related diseases, sarcoidosis, Behçet's. Most of these diseases they can present with systemic features in addition to meningitis. But IG4 related disease can only present with pachymeningitis. So high degree of suspicion is required in diagnosing these if they don't have systemic features. In Behçet's you can have all cranial abnormalities and midbrain involvement, oral ulcers, genital ulcers, all these other criteria. By them you can diagnose Behçet's meningitis. So chemical meningitis, as already told, it is a rupture of the epidermolysis or craniopharyngioma which can cause recurrent meningitis. So once it ruptures, it is difficult to find. So when the patient is asymptomatic, in between the attacks, if you do imaging, you can find these cysts. And in all these cases, before you label them as non-infectious causes, you must do CSF and rule out the infectious etiology before labeling them as non-infectious. And neoplasms like systemic malignancies can affect the brain, introducing carcinomatous meningitis. In a patient with malignancy, always this problem will be there, the suspicion will be there even though they are prone for bacterial infections or viral infections because of their chemotherapy or immunosuppression. Now coming to drug-induced meningitis. Drug-induced meningitis requires also high index of suspicion. You must know that the patients who are taking drugs for other purposes come with meningeal signs. You must look at the list of the drugs he is carrying because in the second patient was taking for arthralgia, always ibuprofen when she feels more pain. So all the episodes are treated by taking of ibuprofen. So ibuprofen can produce all features of meningitis. The way other drugs are antibiotics like sulfamethoxam, sulfamethoxazole and penicillins, they can precipitate meningitis. Here the problem comes whether to treat or to stop the patient. The patient is taking the drugs for some other infection. If you stop, the infection may worsen. If you don't stop, meningitis may not improve. So there is dilemma. And IVIG also can produce meningitis. In addition to that, OKT3 monoclonal antibodies. These are also cause for drug-induced meningitis. How to suspect? If these signs are there, we can suspect that it can be drug-induced. One is recurrent episodes and past history of drugs, and CSF, at least in the first episode, is aseptic. That means it is not showing any organisms in the smear or PCR. Then you can suspect this as a drug-induced meningitis, provided the patient is using one of these drugs. In addition to that, the patient can have as an allergic reaction to NSAID, he can have facial edema or conjunctivitis, and the symptoms occur with re-exposure of the drug. All these points towards the drug-induced meningitis. Patients with SLE are prone to take many of the NSAIDs for the joint pains. So, in them, the ibuprofen is known to cause more of drug-induced meningitis. Likewise, patients with chronic migraine who are taking IVIG for some other purpose, they are more prone for the IVIG-induced meningitis. So now we come to autoimmune encephalitis, which is triggered by some herpes simplex encephalitis. Many patients with herpes simplex encephalitis, after they recover, for a few days they will be okay, then they develop again some neurological deterioration. So this is when these patients were examined, their PCR turned out to be negative, and they examined, they turned to be positive for the NMDA receptor antibodies. So the incidence is 7 to 25%. In a group of 11 patients, even Epstein-Barr virus, mycoplasma or streptococcus are also known to produce, these are only few case reports, but confirmed is only herpes simplex. So why the herpes simplex infection triggers autoimmune encephalitis? The various mechanisms that are put forward are direct injury to the brain tissue. Then when there is injury to the brain tissue, the neuronal proteins, they come out and they induce antibody production. Not all patients develop, so there may be some genetic predisposition or like a GPS, it's a molecular mimicry. So these are the theories that were put forward to explain the herpes followed by autoimmune encephalitis. So here if you take a patient with the herpes simplex encephalitis, usually the autoimmune encephalitis comes after 1 month. And the clinical features will be, in the children it will be more of choreoacidosis, movement disorder and seizures. Whereas in adults it will be more of the psychiatric manifestations. And CSF again can show mild gliocytosis and protein concentration. And if you look for HSV PCR, it will be negative. But NMDA receptor antibodies will be positive in these patients. Actually, whether if the patient develops HIV infection and along with acyclovir, if you give glucocorticoids, whether it prevents the development of autoimmunity, it is not yet known. But the management includes the same lines of treatment like a autoimmune encephalitis, steroids, IVIG or plasma exchange. So the next more severe problem is partially treated pyogenic meningitis versus tuberculous meningitis. Many patients they develop pyogenic meningitis features and they were given antibiotics in inadequate doses. Then when the symptoms are not improved, they come to us. Then at that point of time we have a dilemma whether it is partially treated pyogenic meningitis or because of inadequate dose, or it is not responding because it is tuberculous meningitis. So the manifestations of tuberculosis are very varied and it gives very lot of confusion and presentation is non-specific. But usually the patients with tuberculous meningitis have a long history. They have a cranioparesis compared to pyogenic meningitis. Even the pneumococcal meningitis can produce cranioparesis. And pyogenic meningitis, they have a blood leukocytosis. Whereas in tuberculous meningitis, blood leukocytosis may not be there. And CSF is clear with lymphocytes and neutrophils with elevation of protein, low glucose, all features like a pyogenic meningitis. So there are various other techniques to see the tuberculous meningitis like gene instance stain, gene expert. In addition to rifampicin resistance, it can also see mycobacterial DNA identification, but the sensitivity is only up to 44 to 77%. And loop-mediated isothermal amplification test, which identifies the DNA of the mycobacterium. Here the sensitivity is 76%, but it cannot identify the rifampicin sensitivity. Other tests include like adenosine deaminase. EADI is found to be useful marker for the tuberculous meningitis. It is very much increased, that is up to 10 in a patient with tuberculous meningitis. Suppose still you have doubt, we have some scores like bacterial meningitis score. Here the positive gram stain carries 2 points and CSF protein more than 80, 1 point, and peripheral leukocyte neutrophil count more than 10,000 and CSF neutrophil count 1000. So all these get 1 point each and presentation of seizures at the time of onset of disease. So if the score is more than 2, it predicts bacterial meningitis. Then you have to continue the antibiotics rather than ATT. And there are other scoring systems that have been developed for the tuberculous meningitis like Lancet scoring system. In the Lancet scoring system, they give more importance to the duration of the disease. If the patient's duration of the disease before the presentation is more than 5 or 6 days, it is more in favor of tuberculous meningitis rather than pyogenic meningitis. And also other systemic features like loss of weight, presence of other focus like X-ray chest or CT chest showing tuberculous focus, and CSF culture, anyhow it is partially treated, it may not give much evidence. And this is under the Vietnam's rule to diagnose tuberculous meningitis on admission. If the score, they gave score depending upon the age, blood count and history of illness. Again it is important, duration of the fever, and then total count and neutrophils. So if the score is 4, you can think it is tuberculous meningitis. One study conducted by now 2 people, Kashyap et al., they found the 30 kD protein antigen in the CSF. It is very specific for tuberculous meningitis, which excludes all other causes of meningitis. And other conditions like hyponatremia, basal exudates, hydrocephalus, all these things will be present in the tuberculous meningitis. If even then you doubt exists. Give antibiotics full meningitic dose in 48 hours. If the patient improves, it is poisonic, or will switch to tuberculous meningitis treatment. So these I skip. So in immunocompromised and immunosuppressive patients also are at risk of developing meningitis. So immunosuppressive drugs, they have wider application in neoplastic and autoimmune disorders. They are like cyclophosphamide, azathioprine, mycophenolate, morphine, mitoxantrone, etc., tacrolimus. They produce wide variety of neurological manifestations including meningitis. Whereas immunomodulatory drugs, they affect only T cell population, they produce limited number of complications like PML. So immunosuppressive drugs like steroids, they can produce number of infectious pathogens like pyogenic listeria is common in patients who are on steroids, in addition to tuberculosis, herpes and fungal infections. The problem with these drugs and in immunosuppressive patients is they are prone for multiple infections, and even non-infectious causes will be there, and the symptoms are not so prominent, and CSF findings are also not prominent because there may not be leukocytosis, there may not be fever. So in all these conditions, it is very difficult to conclude that there is meningitis. So that's why we need to do CSF analysis and exclude meningitis. So this is a list of infections that are common in the immunocompromised host. In nature, these should be, because special focus should be given to these: listeria, nocardia, mycobacterium, and fungi, cryptococcus neoformis, virus, cytomegalovirus, varicella, and parasites like toxoplasma. A patient with SAH can mimic meningitis. So here, if you take CSF analysis, the first tube will be traumatic, then afterwards it clears, it indicates many traumatic drop or meningitis, and if it is uniformly blood stain, it can be a manifestation of subarachnoid hemorrhage, and sometimes D-dimer may help. In addition to these meningitis caused by different variety of agents, there are certain disorders that can mimic meningitis. This is called meningism, post-fossa tumors, patients having drug-induced dystonic reactions, or epileptic malignant syndrome, tetanus. All these can have neck rigidity and they may be mistaken for meningitis. Even Atlantic axis dislocation is one of the causes for DD for meningitis. So whenever a patient, you encounter a patient with meningitis, suspicion of meningitis, blood cultures must be drawn and all the routine tests including CBP, CRP, electrolytes and other tests should be done. And then you have to do lumbar puncture. If there is problem with there is risk of phoning in a patient with altered sensorium, or patient who is an immunocompromised, has focal deficits or seizure, then you have to go for imaging. Imaging most of the times may not show anything, or there may be cerebral edema. If you do contrast, better is flare contrast. Here it shows meningeal enhancement better than the T1 weighted images. So this is the T1 contrast which is not showing any meningeal enhancement, but this is the flare contrast which shows leptomeningeal enhancement. It is more sensitive in diagnosing the meningitis compared to T1 contrast. So in the lumbar puncture, you have to send all the parameters like normal compared to normal is clear, 5 cells, all of you know all these things, so I am not going into details. But while you are sending for culture, take the second sample, because if you introduce the needle and some of the skin pathogens may be mixed. So always send the second sample for staining and culture rather than the first sample. Usually in all the pyogenic meningitis, tuberculous meningitis, fungal, the CSF sugar will be low. But in addition to that, neoplastic process, chemical meningitis, mumps, lymphocytic chorea meningitis also have low sugar levels. So sugar cannot distinguish whether it is pyogenic or other viral infections. So when the treatment of meningitis starts the moment you see the patient. So you have to give antibiotics. When you give the antibiotics, the chances of positivity of gram stain and culture will be less. But in those cases, because the CSF gets sterilized if you start appropriate antibiotic. If it's an Neisseria meningitis, CSF becomes sterile within 1 hour. Whereas in pneumococcal meningitis, it becomes sterile within 4 hours. So in this time, if you can do CSF analysis and send them, you get some positivity. Otherwise, then you have to go for PCR or antibody test. So the PCR is multiplex PCR. It detects several common causes of meningitis like biofile film array, detects Streptococcus pneumoniae, Galactium, Neisseria meningitis, Listeria, H. influenza, and E. coli. The other things it cannot. Only these 6 bacteria are identified by PCR. Like that, 7 viruses are detected and 2 fungi like Cryptococcus is detected by PCR. But for the Cryptococcus, the antigen test is more sensitive and Indian strain is more sensitive. So there is an entity called culture negative meningitis. Like all viruses and partially treated bacteria, and sometimes it is very difficult to grow mycobacteria. So all these come as culture negative meningitis in addition to drug induced and autoimmune causes. When to repeat the lumbar puncture? If the patient is not improving within 48 hours of antibiotic therapy, then you have to go for repeat lumbar puncture and check your diagnosis. What are the various complications of meningitis? Hydrocephalus, cerebritis or brain abscess, venous thrombosis, infarct and empyema. These are the various complications that can follow in a pyogenic meningitis. So the treatment consists of, in community acquired bacterial meningitis, the adequate dose should be given. It is cefotaxime or ceftriaxone should be given in addition to vancomycin. Vancomycin, why? Because penicillin resistant streptococci or pneumococci will be there, so you have to give vancomycin and dexamethasone. Now steroids are supposed to be useful in the case of pyogenic meningitis when they are started early, before the first dose or along with the first dose, because they may reduce the complications of deafness and formation of basal exudates. If they are given late in the course, after 2 or 3 doses of antibiotics, they are not useful. So patients with who are suspected to have listeria meningitis, you have to give ampicillin also in addition to vancomycin and ceftriaxone. Patients with gram-negative bacilli or who have intracranial shunts or indwelling catheters, they should receive treatment with cefepime or ceftazidime, which covers Pseudomonas, in addition to vancomycin. For all viral infections, you have to give acyclovir 10 mg TID for 20 days. Even that is same for varicella zoster. In Epstein virus encephalitis, it is supposed to be caused by para-infectious cause, not direct infection. So it is the treatment is corticosteroids, intravenous immunoglobulins, but not acyclovir. Whereas cytomegalo, you have to do ganciclovir and foscarnet. If it is HF6, if it is a human herpes virus 6, it is commonly seen in the patients with hematopoietic stem cell transplants, where you have to do ganciclovir or foscarnet for 3 weeks. So the duration of treatment is, it is a Neisseria meningitis, 7 days course is enough. Even the same for Haemophilus influenza. For Streptococcus pneumonia, it is 14 days. Whereas Listeria and gram-negative bacilli, you have to give for 3 weeks. As we came to know that in refractory myasthenia or neuromyelitis, because the patients are nowadays given eculizumab, a complement inhibitor, but this can produce severe meningococcal meningitis, that is Neisseria meningitis. So all these patients must be given pneumococcal vaccine, the Neisseria meningitis pneumococcal vaccine 2 weeks before the starting of eculizumab. But it may not cover all the strains. So during the treatment also the patient should receive some cephalosporins. Chemoprophylaxis for bacterial meningitis includes Haemophilus influenza. The chemoprophylaxis is by rifampicin, whereas in Neisseria it is ceftriaxone or ciprofloxacin or rifampicin. The chemoprophylaxis should be given in case of Haemophilus for 4 days by rifampicin. In case of Neisseria meningitis, you have to give for 2 days. So, who published the data on the meningitis in India in 2020? The death rate was 2.52 per 1 lakh population in India, and India ranked 55 position in the meningitis deaths. And World Meningitis Day is celebrated on 5th October every year. Earlier it was celebrated on 24th April. Due to some reasons we don't know, it was changed to October 5th. So October 5th is the World Meningitis Day. Thank you.
Thank you, madam. Very comprehensive talk on meningitis. Any questions from the audience?
The patient with any interventions, usually it is the Staphylococcus that is responsible for the meningitis. Staph.
You must have seen such cases.
I didn't see. Nowadays, actually, the meningitis cases are coming down. We are seeing most of them as tuberculous meningitis. Recently, we saw 2 patients with herpes simplex encephalitis. Pyogenic? No, recently we didn't see.
Common phenomenon.
FDS meningitis, we don't know because we are working in a tertiary hospital or one, but the incidence is not tuberculosis, viral, or fungal, we are seeing.
Yes, we have 2 patients who presented with very acutely within 2 days. We thought of actually pyogenic meningitis, but it turned out to be tuberculous meningitis.
Older days we used to see cases of spinal arachnoiditis following tubercular meningitis. Are you still seeing or?
No, sir. Even while doing DM also, I saw one patient with arachnoiditis where we have given intrathecal hyaluronidase for those patients. Now it is only point of discussion and the theory classes are dealing for other conditions.
Recently, I also not seen any case of spinal meningitis. One question, is there any foolproof method to diagnose tuberculosis meningitis? Sometimes we do all the testing, we are having doubt.
So there is one study by Kashyap et al. From Nagpur. They said 30 kD protein. They found it is an antigen specific for tuberculosis. That can be done. I don't know. That is given in the literature. That is very specific for tuberculosis. Even nowadays there are many other tests to test the resistance of the drug. Now we have only gene expert test to test the sensitivity for rifampicin. Now there is a whole genome sequencing which is done on the culture of the CSF to test the resistance to all first line and second line drugs. Now there is one study published in Lancet where they are giving rifampicin labeled tracer in a PET scan to the rabbits so that they can identify any resistance. These are under process. And metagenomic sequencing is another method where you can detect even after giving antibiotics. So here it identifies all the non-host DNAs. So you can amplify them in the PCR and you can detect whether it is what is the organism. Many times giving antibiotics decreases the chance of getting the positivity of the stain or culture.
Actually, Dr. Vikram, I think he has presented one case where EVD, he has given highlights for arachnoiditis. Tubercular meningitis is still there, not completely gone.
Even they say intraventricular instillation of the antibiotics if the response is not adequate. Means you are giving hyaluronidase. Along with the decathlon you have to give. Yes, the equal amount of those things you have to instill.
Weekly once for 4 weeks.
Even as a DM resident I gave.
We used to give for spinal meningitis. Tubercular, any intracranial meningitis, I don't know.
No, it is for spinal arachnoiditis. Okay.
Thank you, madam.
There is another site for not spinal. This is for also parasitic arachnoiditis. Let's go into the
Request Srikanth Ravikar sir to present Sri Lakshmi madam with the bouquet and memento. The next topic for today's afternoon is recurrent TIAs. I request Harinara Krishna sir, Senior Consultant Neurologist, Medicover Hospital, to chair the session. Dr. Komal Kumar sir is the speaker.
After the first session, everybody is awake, they can see that. And this is another interesting topic. I asked Dr. Komal Kumar to present on recurrent TIA, particularly the more malignant varieties, crescendo TIA, recurrent TIA, how to manage. So I think he will clarify all our doubts and will be doubt free at the end of the session. Dr. Komal Kumar.
Good afternoon, sir. Actually, thank you for having me here. It's a wonderful session. Actually, I have learned so many things. And at the same time, it is difficult to being awake after the sumptuous lunch you have arranged, sir. I'll make it a session, make the session more interactive. In fact, if somebody comes to, I'll be the first neurologist to pray the God that I will not get a case of recurrent TIA, and particularly when I wake up from the bed. Because sometimes, if you are practicing in the periphery, one recurrent TIA can finish your career actually. If your local MLA or MP or some businessman comes and then he develops stroke in front of you, it can be finished. And this is one case which we have seen recently. This is for the neurology residents. What you see here, this patient, a 65-year-old man who came with one episode of weakness of left upper and lower limb 16 hours before. And then he came to my OPD with another episode of weakness of left upper and lower limb that day morning around 4 hours after the event. And 1 minute. This is what the Doppler shows. Any idea what this is? See, you have a plaque here with a thrombus there. It's a plaque, it's a ulcerated plaque with a thrombus. And what do you do for this patient? What do you do for this patient? You send him home, put him on antiplatelets and send him home, or what do you do? Admit this patient, put him on full-fledged anticoagulation. So because you have a thrombus here, and anytime it can embolize. And keep a close watch. If the patient continues to have symptoms instead of adequate anticoagulation, then what we do? Yeah, it's a plaque with thrombus. So what do? You send him for urgent endarterectomy. See, whenever you are dealing with a case of recurrent TIAs, this is something like, you have seen this movie Ghost and Darkness. It's based on a true event. Actually released in 1996. It's a true event based on the two man-eater lions in the savannas. You have to deal with two lions. One lion is the patient with the TIA. Second lion is the attendant. Okay, many times it is very difficult to deal with the second lion rather than the first lion. Let us start with the case. These are all true cases actually which we have encountered in our practice. Let us start with a simple case. 61-year-old male, hypertension of 10 years. He had history of weakness of left upper and lower limb lasting for around 10 minutes. He had two such episodes. One was 15 days ago and second episode 2 days ago. And he is a non-diabetic. So we all know that this is a TIA. This is what the Doppler show. So what do you see here? You see a plaque here. Okay, this is significant stenosis. You can see this. The concentric plaque with this is what we call aliasing. So this is significant stenosis. So this case is a straightforward case. What do you do for this patient? What do you do? What do you do? He comes to you, and what do you do next? You see this, and then MRI is normal, there are no infarcts. So he has got two clear-cut TIAs, not very malignant. So he is sitting in your OPD, you put the Doppler, and then you see this is what you have seen. He has MRI films in front of you. What do you do next? You load him with antiplatelets. You load him with clopidogrel and aspirin, 300 milligrams of clopidogrel and 300 milligrams of aspirin, and then admit him, send him for revascularization ASAP. probably the next day. Either you can do endarterectomy or you can do a stenting. So this is a TCD. You can see the left MCA is showing normal velocities, whereas the right MCA is actually the right hemisphere is crying for the blood. So there is a reduced systolic peak, blunted flow, and there is significant vasodilation on the right side. You can see the PI. So normal PI is 0.8 to 1.2 in TCD in cerebral vessels, whereas on the right, this side you see 0.7. That means there is significant vasodilatation. So these are the patients when you are revascularizing him, they can be a risk of, what is the risk? They can have hyperperfusion injury because the vessels are maximally dilated, and then whenever you suddenly open them up, especially clamping, they can have sudden hyperperfusion injury leading to stroke. So that is the reason you have to monitor even the intracranial vessels also while they are doing endarterectomy or stenting. So this is the MRI of this patient. This is normal. We know that this is a clear-cut, straightforward carotid disease. We know that anything which is more than 70% stenosis is significant, and it is proportional to the risk of stroke, and it is well established that these patients will benefit with revascularization. I think that's clear. As a clinician, we are not radiologists. Okay, if you send a patient to a Doppler, you will come with a big report saying that right side 20% diameter stenosis, left side 30% diameter stenosis, right ACA 20% diameter stenosis. But what they miss is they do not give us velocities. So what you should emphasize before sending your patient to a radiologist for Doppler is you ask them to give the velocities of ICS, CCS. And then as clinicians, we always go by velocities, not the diameter. It is very well known, actually there is a correlation. If somebody's ICA PSV is less than 125 centimeters per second, EDV is less than 40 centimeters per second. And another most important thing is you should always look at the ICA-CCA ratio. Anything less than 50% to us is non-significant. 50 to 69% is moderate carotid stenosis. The velocities are 125 to 230, ratio is 2 to 4, and EDV is 40 to 100. And there will be more than 50% dive detection. What we are more interested is in the numbers of velocities. Anything more than 230 centimeters per second PSV or EDV of more than 100, these numbers are very, very important. Just remember these numbers. Less than 125 normal, 125 to 230 moderate, anything more than 230 is abnormal. And ratio, ICA-CCA ratio, less than 2 normal, 2 to 4 moderate, more than 4 is significant. But sometimes if the patient has a near occlusion or complete occlusion, the velocities can drop out. So not only, now this patient, another patient with a TIA, what do you see here? You see a plaque, isn't it? So this is a hypoechoic plaque, this is what we call. And if you see the velocities, there is no aliasing, isn't it? The velocities appear deceptively normal. Is this plaque safe? Suppose a patient comes to you with normal velocities and in the Doppler you see this plaque. Is it a safe plaque? Or what you call a stable plaque? No. This is a significantly homogeneous, what called heterogeneous is evolucent plaque, hypoechoic plaque. These plaques are also unstable plaque. Sometimes not just the velocities, even the plaque morphology, plaque characters also is very, very important. A small plaque which is not causing any flow limitation can still be a dangerous plaque. If there is a plaque ulceration, and if it is a hypoechoic plaque, and if it is a intraplaque hemorrhage. So these are the three things again which you have to keep in mind. If you are seeing a hypoechoic plaque, and then if there is a irregular surface and with ulceration, and if there is intraplaque hemorrhage, these are the plaques you should be very, very wary of. Even in these plaques, even if the velocities are normal, these patients have high risk of having a recurrent TIA or a completed stroke. So this is the international plaque classification system. We usually follow this blue system, where we call them as heterogeneous plaques if it is more than 50% hypoechoic. Homogeneous plaques are more than 50% echogenic. If the calcification is present, it's in carotid system, the calcification has different connotation. Whereas in heart, they say the calcium score is high, the patient is at high risk of having MI. Whereas in carotids, if the calcification is present, it's supposed to be safe. But it is a marker for vascular disease elsewhere in the body. So what's a TIA? I think you all know this. It's a clinical syndrome characterized by sudden onset of focal neurological or monoocular functional loss present when vascular wasting. This everyone knows from their MD days also. So when we were doing MD back in late 90s, there was a approach called RIND. Sorry, what about of RIND? Reversible ischemic neurological deficit, where we say if the deficits improve within 7 days, it is called as RIND. And it was more than that. Previously, the definition of TIA has been limited to 24 hours. Anything which is less than 24 hours is called TIA. And it is mostly it was a time-based approach. But we know that diffusion restrictions can happen in MRIs, in TJs, as early as 50-45 minutes also. So the new approach should be anything. It is a tissue-based approach. Anything which is less than 1 hour only. So if somebody has more than 1 hour of a weakness or deficit, it is not a TIA. So old approach says it could be suggests a benign disease, delays intervention, and it could inaccurately produce ischemia. So the new approach is tissue-based. We know that time is brain and time is clot. And the new definition is it's a brief episode which is less than 1 hour. And it encourages neurodiagnostics, facilitates rapid intervention. And we know that TIA is very, very, very important. It's a neurological emergency. It should be treated on an urgent basis as we treat a case of status epilepticus or pyogenic meningitis, because it can be a disaster waiting to happen. So these are the 4 questions which you have to answer while you are dealing with the TIA. Why treat a patient with TIA? Whom to treat? When to treat? And what to treat? Why treat TIA? And we know that all TIAs are not good, and the prognosis after TIA can be very, very bad also. If you admit the patient, if you discharge the patient from the ER or the TIA without evaluating them properly, up to 12% of them can be readmitted within 30 days, and up to 12% can be readmitted with recurrent stroke or death. This can be 9% for TIA speech deficit, 12% for TIA motor deficit, 15% stroke rate for all types by 1 year, 22% stroke risk. That means anybody who comes to you with a TIA has a risk of having a composite risk of and of composite outcome of having a stroke or another TIA, or well matter even any cardiac problem can be very, very high. So we have a score called ABCD score. I think you all know this score. This is age, 1 point if you have more than 60 years, blood pressure 1 point if systolic is more than 140, diastolic more than 90. Clinical features 2 points for unilateral weakness, 1 point speech deficit without weakness. So 2 point if duration is more than 60 minutes, 1 point if duration is 10 to 15 minutes, diabetes 1 point. We know all this. And in fact, there is a validation of the ABCD score in triaging patients. So if somebody has a score of 0 to 3, its 2 days stroke risk is supposed to be 1%, 7 days stroke risk 3%, 9 days 4%, 4 to 5, 4, 9, 6 to 7, 8% or 24. So if somebody has 0 to 3, 2 days stroke risk is 1, 3 and 4. So it's not much, isn't it? So if somebody comes to you with a TIA, when do you treat? We know that most of the strokes happen in first 2 days. So TIA should be treated immediately. If the patient comes to you, load him with antiplatelets after imaging, and then you have to evaluate him like as you evaluate a patient of acute stroke. Let's come to another case. 50-year-old male, hypertensive and diabetic, history of weakness of left upper limb lasting for 15 minutes. He had an episode 3 hours ago. So what do you do? What do you do? Antiplatelets? So what is the risk of subsequent TIA stroke in this patient? What is his ABCD score? How much? He is 50 years. So non-diabetic, non-hypertensive, he had just weakness of one upper limb, 15 minutes. So what is his score? Maybe 1 or 2, isn't it? So what is the risk of subsequent stroke or TIA in this patient if you go with the Johnston's criteria? 1%, 2% and 4%, isn't it? Does it require hospitalization? Do you admit this patient? His score is very less, isn't it? So do you admit this patient? Does it require hospitalization or outpatient evaluation? Which antiplatelet drugs? Which drugs, which antithrombotics you give? No answer? How do you evaluate? So, this is what we did. You saw a huge floating thrombus. Okay, this is again a monster sitting there. And this patient actually was admitted immediately, he was anticoagulated. So we should not just go by the EBCD score. Actually, there is a call, in fact globally, to dump the EBCD score in trial TIA patients. Because the so-called low-risk TIAs, or low-risk TIAs in EBCD score can have significant disease burden. See this, there is a huge thrombus there. He was admitted, anticoagulated, and subsequently found to have hyperhomocystinemia and MTHFR gene mutation. The question is it safe to discharge TIA patients with EBCD score of less than 4 from OPD with antiplatelets? The answer is no. So in fact there was a Dutch cohort in which they found that 1/5 of patients with scores less than 3 had underlying conditions, like in this patient which I have shown earlier. They had conditions which required urgent treatment, like they had symptomatic ICS stenosis in 9.1%, and endocardial stenosis 5%, and 6% with atrial fibrillation. So therefore the take-home message from this case is all TIA patients should be optimally investigated ASAP and should be thoroughly investigated with vascular imaging and ECG. So coming to the atrial fibrillation, so these are the detection rates of atrial fibrillation with various modalities. We know that transmission ECG, the pickup rate is 2.7, Holter 24 hours, which we commonly advise is just the detection rate is 4.8%, and Holter for 48 hours 6.4, 7 days 12.5. So in fact my colleague from UK actually, she has returned, and she said there is a trend in UK actually in Oxford or Cambridge, where they hook on the patient, every patient of stroke with Holter right from day 1, and they monitor till the day of discharge, so that their pickup rates will increase. Because the regular practice in our country is to put them on Holter for 24 hours and 40 hours and send them home. That may not be ideal. Next case, 50-year-old male with recurrent attacks of right upper and lower limb weakness lasting for 5 to 10 minutes, subsiding spontaneously, 4 episodes in 1 day, non-hypertensive, non-diabetic, NHS score is 0. What do? Put them on antiplatelets straight away, isn't it? Look at his CT scan. What is it? There is an SDH. So, all TAs, you should have an urgent imaging before putting them antiplatelets, because mimics can always be there. So, what is the mechanism for weakness in SDH? Recurrent episodes of weakness in SDH? Any idea? It is because of compression of the blood vessels, or it could be sort of focal seizures, or it could be a cortical spreading depolarization. So we know that there are a lot of mimics for TIA, like seizures, Todd's palsy, migraine, hypoglycemia is one of the most common mimic we should never miss. Hyperglycemia, tumors, subdural, subsomatopron disorders. Coming to another case, 70-year-old male, hypertension and coronary artery disease, weakness of left upper and lower limbs, loud speech for 50 minutes, 1 episode 24 hours ago, NHS school skill is 0. So what is this? Clinically, TIA. So we'll do MRI. So MRI shows there is an infarction actually. Okay? So, again the point is, up to 30 to 50% of patients with clinical TIA can have diffusion restriction on the MRI. So these patients, though they can classify as TIA clinically, they are not TIAs, what we call them as TIAs, transient symptoms with infarction. So coming to the common drugs, these most important which we use in TIAs are ischemic strokes, the antiplatelet agents, we know the mechanism of action of aspirin, clopidogrel, and ticagrelor, and teroflunomide. So we know that the aspirin, it inhibits cyclooxygenase and then reduces the formation of thromboxane. And clopidogrel and ticlopidine, they act on they active metabolites. They are metabolized into active metabolites in the liver by CYP2C19 system, and then they act on the PE2Y12 receptors. Whereas ticagrelor does not need any hepatic conversion to active metabolite, it directly goes and inhibits the P2Y12 receptors. And ultimately the platelets get activated, and then there is the platelets and then neighboring platelets, they get aggregated through fibrin closets through glycoprotein 2B3A receptor. So our tyrosine, eptifibrate, diazoximide, they inhibit the glycoprotein 2B3A receptor. So this is a basic slide, I think, which everyone should understand. This slide actually is one of my favorite slides. So this is a very, very basic slide. I am not a very entertaining speaker, and then I don't read much, but I just go through the basics. So this is aspirin, we know, the time-tested drug, and it is one of the most astonishing inventions of the history. It has stood the test of time. It still continues to be the number one prescribed drug, antiplatelet worldwide. And you know how the aspirin cytotoxic has come into the picture? Way back in 1956, actually, it was seen by a dentist, observed by a dentist, where initially it has come as an analgesic. So these patients actually who were taking aspirin for dental pain had a lot of bleeding and reduced incidence of stroke and MI. That's what he has observed. And then subsequently, there was a lot of research which went on aspirin. And then it's supposed to be commercially most endurable, viable product of all time, aspirin. And you see the onset of action after loading dose of aspirin. This is just 20 minutes compared to clopidogrel, which takes 2 to 6 hours. And time to steady state platelet inhibition after maintenance dose is just 1 day for aspirin. Still, it is a number one drug. And whatever studies have done, none of the drugs have found to be absolutely superior and safer than aspirin. And clopidogrel, we know, is one of the favorite drugs of the newer generation. Ticagrelor, our favorite drug of our cardiologist colleagues. Most of the times our patients come back with a lot of intracranial bleeds with clopidogrel. And silastazole and dipyridinol, they have found to have some role, especially in fact, studies have found that they can have even the reversal of clot burden in the intracranial circulation. You know, the ESPS2 and ESPS3 studies. And to all the youngsters, I think I strongly recommend reading this book. Actually, this is a wonderful book actually. It can be your favorite tea time book. The Remarkable Story of Wonder Drug called Aspirin by Dermot Jeffries. It's a wonderful drug. If you have time, just read. There will be a lot of interesting stories and a lot of, in fact, true stories. And whenever we are, as a neurologist, whenever we are dealing with TIAs or strokes and then we are giving antiplatelets, we have to navigate between two things. Like the Odysseus in the Homer's Odyssey, we have to navigate between the bleed and the stroke. So which is sometimes very, very difficult. So we know that we have patient with TIA or stroke. So what do? We load them with antiplatelets, aspirin and clopidogrel, and there is a lot of meta-analysis. Actually, this is a meta-analysis which is published in 2021 Circulation. This has taken all the studies, right from 96, the Capillary study, up to the latest Socrates and Thales study. The what study this has concluded is, their dual antiplatelets are safe and effective in TIA or ischemic stroke if they are given for less than 30 days, followed by monotherapy. And this dual antiplatelet combination should not include ticagrelor. So still, the drug of choice, this combination should be aspirin and clopidogrel. So this is what it says. Compared with monotherapy, use of dual antiplatelets after stroke reduces the risk of recurrent stroke at TIA, and there is a risk of major hemorrhage if it is increased, if it is continued for more than 30 days. And except for the aspirin ticagrelor, the dual antiplatelets less than 30 days decreases the risk of recurrent stroke at TIA, but does not decrease the risk of major hemorrhage. But the take home again, the important message is do not give combination of aspirin plus ticagrelor. Use combination of aspirin and clopidogrel, or aspirin plus typhoid, whatever you are comfortable with. Let's come to the case vignette 5. There things get more and more complicated as the talk progresses. This is a case vignette 5. This was seen by a neurologist in a district. 16-year-old male, hypertension of 10 years, acute onset of left upper and lower limb weakness, 15 minutes resolved. Another episode 30 minutes. This happened when he was sitting in a temple. Another episode 30 minutes later, lasting for 20 minutes. He went to the hospital, consulted a neurologist, scan done, scan was normal, was put on dual antiplatelets. There was no mention about loading dose. 6 hours later, he had another episode. He was put on normal heparin, admitted, observed. 12 hours later, he had another attack which progressed to stroke. So, this was what the MRI says. So, what is this? Let's go to the another case. 64-year-old male, no comorbidities, acute onset of left upper and lower limb weakness, 30 minutes resolved. Another episode 120 minutes later, he was lysed with TNK TPA, improved. At another episode after 3 hours post-lysis, progressed to stroke. So, his MRI is just like a mirror image of the previous patient. This is, what is this? What is this? This is capsular warning syndrome, progress into stroke. See, both the patients, I think they were managed well. In fact, first patient was given dual antiplatelets, he was given heparin. Second patient was lysed, but still they continue to have stroke. So these are the cases which should not come to us. So this is capsular warning syndrome. Because the problem is, whatever you do up till here, 70% of these patients will progress to stroke. So whenever you are seeing a patient of capsular warning syndrome, if the given patient comes to you walking, you warn them, alert the patient, alert the attendant also, that in spite of your best possible efforts, there are chances that this patient will have completed stroke in the next 24 to 48 hours. So what is capsular warning syndrome? There are 3 or more transient episodes of focal sensory or motor neurological deficits affecting face, arm, leg in absence of cortical signs occurring within 24-hour period. Recent cases, anything up to 72 hours also can be called as capsular warning syndrome. The problem with CWS is there is high risk of subsequent complete infarction up to 70%. So what is the pathophysiology? It is not, and studies have shown that almost all the patients of CWS have hypertension as the major risk factor. And it is not lipohydrosis, it is microatherosclerosis at the origin of the deep penetrating branches, leading to stenosis or occlusion and subsequent distal hypoperfusion, not hyper, it's hypoperfusion. And patients with single dominant enterocyte also risk. So there was a study actually, which was a population-based study in which they have found that the 7-day risk of stroke after first TIA or recurrent drug called tirofiban, which is a glycoprotein 2B3 inhibitor. This is one of the largest series actually, published in Frontiers of Neurology in 2022, where they had treated 23 patients, this from the China, and non-tirofiban group, this is the Capsular warning, they have received TPA, heparin, aspirin in various combinations. The tirofiban group, one group patients have received TPA followed by tirofiban, because these patients instead of receiving TPA continued to progress. Other patients did not receive TPA, directly they were on tirofiban, aspirin, and these patients were followed. And in the patients who received tirofiban, the risk of completion, the percentage of complete stroke was around 22%, compared to the patients of non-tirofiban group, in which the risk of completion was around 62%. So the loading dose, this is very, very important. So this is 0.4 microgram per kg body weight per minute over 30 minutes, and then you maintain for next 24 hours. And sometimes the patients can still develop new TIAs instead of being on tirofiban. So what you do is give a second loading dose and increase the maintenance dose, and then infusion time can be prolonged up to 48 hours. But we have to be careful that these patients, they have received, some of them might have received anticoagulants or TPA, and then you're putting them an antiplatelet, powerful antiplatelet agent. So the risk of bleed is always there. Luckily in this series there was no patients who had any bleed. So another syndrome is it calls for recurrent TIA is Fontaine warning syndrome. We had seen 2 patients actually, because of lack of time. Actually, I have not kept those patients' profile here. Crescendo TIAs with recurrent stereotypical symptoms of episode motor weakness and dysfunction. Again, the proposed mechanism is penetrating basilar artery branch circulation at the origin. And another cause of recurrent TIA is callosal warning syndrome. Actually, this case was described by my senior at NIMANS, Dr. Nandagopal. So he had seen a patient with intermanual conflict, repeated episodes of intermanual conflict with alien limb phenomena, callosal apraxia and dysgraphia. The initial MRIs were normal. He was put on antiplatelets and sent home. And then 2 days later, he had continued episodes and then had infarct in the body of the corpus callosum. So what is the culprit vessel here? It is the pericallosal branch of the distal ACA. So summarizing the talk, TIA is a neurological emergency. It is as emergent as an acute stroke. So all these patients should be evaluated thoroughly, and it is the time to dump ABCD score. If somebody has a low ABCD score, that does not mean that his risk of TIA is low. A significant proportion of TIA patients can have established infarcts on MR imaging. This is what we call TSI, transient symptoms with infarction. And all patients of TIA, before becoming very enthusiastic about the antiplatelet agents, do a CT scan, because sometimes mimics can happen. And stroke warning syndromes are not uncommon and are the most common causes of recurrent TIAs and completion of the stroke. Proposed hypothesis for stroke warnings include microatherosclerosis and hemodynamic instability. So these patients should be given tirofiban and permissive hypertension and antiplatelet agents. Tirofiban is a promising drug in recurrent TIAs, and all patients with TIA or ischemic stroke should receive dual antiplatelet therapy for 2 weeks or maximum of 1 month, followed by monotherapy, and the dual antiplatelet therapy should not include aspirin and ticagrelor. So I would like to thank my mentors, Professor Vijay and Dr. Andy Alexandro, who has taught me the art of neurosonology and the basics of stroke care. That's all. Thank you.
I think it will generate a lot of discussion. Apart from the term RIN, there was another term called EA. Yeah, incomplete. Incomplete, yes. It's a completed stroke. It's a completed stroke. The patient comes in window period, thrombolysis. With NHS is more than 4.
If the score is 0, just give antiplatelets, that's it. Yes, sir. It's a completed stroke. It is no more a TIA. Yeah.
Excellent presentation, sir. I think we all should learn how much time you took for preparing the slides. They're looking like, you know, the newer jewelry shop ads and jewelry shop advertisements. Such a great slides and great slides. Yes. And coming to TSI and DIA. TSI has not any good prognosis if you see that.
No, TSI is a completed stroke, that's it.
Yeah. So means that pathology is over.
Yes. What we will call earlier FTA is not TSI.
Coming to that vascular warning syndrome, apart from this MRI, after MRI anyways we have that intuition of where the impact is. Apart, you have any other symptoms to suspect other than this lack of particle signs?
As I said, all TIAs, first modality is CT with CT angio. Like as you get any case of acute ischemic stroke, do a CT angio. And in capsular warnings, all vessels will be clean. And then patient have repeated episodes of weakness of the one side of the body, there are no cortical signs. We know that is capsular warning.
I also have about 3-4 patients like this.
Yes.
Young female, 45 years, I didn't thrombolyze because she had the stuttering course, coming and going, coming and going. Blood sugars were 400 in that lady. That was again the negating point. I thought maybe the vasculopathy is the main, also they may not benefit by giving the thrombolysis.
The problem here is again, thrombolysis also may not help these patients.
Yes.
So best thing is up the blood pressure, because sometimes, in fact, most of the cases it is because of the hemodynamic components. So already the results are narrowed, and the blood pressure is low, they have stuttering course. And the thrombosis there can be very, very dynamic. So that is the reason tyrosine has helped, because tyrosine is the one which breaks the final pathway of platelet aggregation.
The angiopathy is the main cause for this.
We generally would, if there is recurrent TIAs are coming, then admit the patient, give a bolus of fluids to improve the blood pressure and also avoid all the anti-hypertensive drugs, then evaluate further. Okay, thank you very much for the presentation.
On your antiplatelets and with optimally managed or risk factors, if they develop a stroke, would you like to add a third antiplatelet like Silazole, or do you want to check for the resistance?
Which drug you are adding?
Aspirin and clopidogrel. Patient is on aspirin and clopidogrel, and patient is having severe ICAT, not focusing on patient is having severe ICAT.
The problem is in these patients, before adding clopidogrel, again, if the patient has failed, that is, for C by P is reduced, loss of function of alleles. Clopidogrel resistance is a problem now. Okay. In studies have shown that 60% of Asians can have clopidogrel resistance. But many times we do not see that, isn't it? And if the patient is having repeated strokes instead of being on optimum management, we should always look for clopidogrel resistance. No, clopidogrel should not be used. No. Only in very, very high risk TIAs, they use for a very, very brief period. That's it. As such, clopidogrel should not be used.
Recent stroke congress also happened in Dallas. Many of our friends who have talked in favor of ticagrelor for that.
We think AC patients
also
coming with major
don't agree
possible
because
ticagrelor.
the brain is different from the heart. So bleeds are more common.
Rates of stroke when compared to Berlin and clopidogrel, but with the increased risk of bleeding.
You know the tail study, no? Yes. That's what tail says. Even the patients who had lot of means in tail study, the patients who had benefit with ticagrelor, in fact the benefit was nullified because the proportion of bleeds were very high.
patient has developed a stroke on particular antiplatelet, that does not mean the platelet has failed, isn't it? See, we know that treatment resistance is different, treatment failure is different. We know that aspirin is not going to save all 100 patients, isn't it? Suppose the patient has, and there is a role for diprodamol and cilostazol and all that, especially cilostazol. In TOS study, I think I've seen. And especially in intracranial atherosclerosis, they gave a combination of aspirin and cilostazol, and they found that most of these, especially in China and then these Asian countries, they found that even the plaques can regress with good statin and a combination of cilostazol and aspirin.
What is the take on schedule for PFO, sir?
PFO cryptogenic strokes, we look for PFOs, definitely.
How strong do you think is the data for closure of PFO?
That depends upon how much points you score on the rope score.
Vascular ultrasound. I think you are the one, I think all the radiologists should learn from. Because we sent to the periodic Doppler, there is no percentage written, no velocity is written. What to do? So probably all radiologists should be aware.
Emphasize those numbers.
Yeah, at least some percentage also should be. We see nowadays, not even percentage written, just it's a periodic disease, just a notion. No way.
I now request Harirama Krishna sir to felicitate Dr. Komal Kumar sir with a bouquet and a memento. The next topic for today is neurovascular surgery. I invite Dr. Vamshi Krishna sir, Additional Professor Neurosurgery, NIMS, to chair the session. Dr. Rajesh Reddy sir, Consultant Neurosurgeon, Apollo Hospitals, is the speaker.
How many neurosurgeons are there in the audience? Okay, very good number. Out of the 15 lectures which are there, 4 lectures are dedicated to the vascular part of neurology. So you should understand the importance of vascular neurology and the increasing incidence over the past few months or years, I would say. So I stand before you as a hybrid neurosurgeon. Because I do both microvascular surgeries and endovascular procedures. So when I was reading about what should I talk about in neurovascular surgery, I found 99 chapters on neurovascular surgery. So if I have to condense 99 chapters in 20 minutes, it's a very difficult task. And do you know how many slides I have? When I was at your age, when I had to, when we were delayed, running late, and then we used to post noon sessions, whenever a speaker comes up, I used to see the number of slides he's going to talk about. So based on that, I used to switch on my mind or switch off my mind. Okay, but then let's go with the flow. So, you plan something and something else happens, right? So it was expected anyway, but then let's go with the flow. And so I'm going to discuss neurovascular surgery in these 5 aspects. Let me put it very simple. Aneurysms, vascular malformations, carotid revascularization, vascular tumors, and miscellaneous tumors like bypass and microvascular decompression. Part of it has been made easy by some of the speakers earlier. So I will speak only about 3 topics: aneurysms, vascular malformations, and carotid revascularization. And this is the most important slide. For those of you who want to take a photo of this slide, because this will be useful for your career. It is very simple, because whenever you answer a particular, whenever you treat a particular patient, you have to ask, why am I treating it, either medically or surgically? More important, surgically. And what is the indication? What I mean is, when do I treat a patient surgically? The timing is sometimes very crucial. And finally, how do I treat? Nowadays you have options, not only surgical options, but you have endovascular options, sometimes radiosurgery, or a combination of all these. So if you have to answer these, if you can answer these 3 questions correctly, that means you will pass your Viva in the exam. At the same time, every day is a Viva for us in corporate life, right? Starting from morning to evening. So in the exam, your Viva starts probably for 15-20 minutes. Whereas in a corporate life, your Viva starts in the morning and then gets over in the evening. Sometimes at night also someone calls, sends some references, not only from India but also from abroad, to ask you
whether a particular patient needs a particular treatment or not. And even if you give an opinion, they'll come up with another opinion, quoting a different paper that it's a controversy. So a lot of controversies do exist in neurovascular surgery as well. So I'll start with intracranial aneurysms. So whenever we start a topic, there's a lot of epidemiology. This is picked up from another slide. So I wouldn't like to go into the topics, but I would say that studies have been performed quite long ago about epidemiology and other stuff, say 30, 40 years back. But then we are not interested in epidemiology. What epidemiology tells us is what is the risk of an aneurysm, bleeding, and so on. Let's say, for example, when a patient comes with an unruptured aneurysm, an incidental unruptured aneurysm, the aneurysm is around 4 to 5 millimeters. What would you tell the patient? What is the risk of rupture? You treat it or not treat it? So that is when we go back to literature, we know that more than 7 mm size aneurysms rupture. But in clinical practice, we do know that blisters do rupture, 3 mm aneurysms do rupture, even without risk factors. So what do you tell patients in such cases? And similarly, there are scoring systems like the FACES score or some of the other scoring systems which have taken all these factors into account, and they have put the risk of rupture in a particular aneurysm. But none of it holds true. Though these are guidelines, every patient is different, and when you counsel every patient, the scenario is totally different. So all these guidelines are nice to know, but every patient is different when you treat them for a given problem. So in my practice, the indications for treatment in aneurysms are definitely if there is a subordinate hemorrhage, if there are pressure symptoms in the form of cranial nerve deficits, seizures, brainstem signs, or hydrocephalus, or in giant aneurysms, sometimes the embolic can produce strokes, or it could be a combination of several factors like an incidental aneurysm in more than 60 years, located in the posterior circulation, with risk factors like hypertension, or if I am following up the patient with any growth of the aneurysm, or previous history of SH, or if I have treated the patient and it continues to regrow, then I treat these patients. So based on this, when we were training, we used to have a flowchart that when you have two options, clipping and coiling, there's a simple flowchart that wide neck aneurysms, posterior circulation, you have to treat it with, anterior circulation you treat with clipping, or a narrow neck aneurysm, which is there, the posterior circulation you treat with coiling. But as technology advances, these indications have become more and more complex. And currently with the available endovascular technology, there is no aneurysm which cannot be treated by endovascular means. But then there has to be a balance between surgery and endovascular, because sometimes we overdo things in endovascular and sometimes we take excess risk in microvascular surgery. So attaining the balance is pretty important. And similarly, papers quote about the safety and efficacy of clipping and coiling. These were probably published in an era when the endovascular was just evolving, so we cannot rely on these data. However, one thing is very consistent, that endovascular treatment, the recurrences are slightly more, so follow-up is very important. So how do I treat them? I look at the clinical condition of the patient. We know that the patient who is sick, whose general condition is very sick, is not fit for a prolonged microvascular surgery. And for example, if the aneurysm is located in the anterior circulation, the narrow neck aneurysm, not much of hematoma, spasm is not good, not so much, and hydrocephalus is not there, probably I would like to take the patient up for coiling. And at the same time, there are other factors like the expertise, which matters, and the cost of treatment, and follow-up, as I said, in endovascular procedures, follow-up is equally important for the recurrence, because the recurrences are slightly high. So for aneurysms, I consider these factors when I treat them. And since I said every case is different, I have to analyze each of these factors for a given case to actually tell which is a better option for a given patient. The surgical options are clipping. Sometimes in a wide neck aneurysm, you have to do a clip reconstruction. Parent vessel occlusion is a simpler option in some of the patients with a good cross flow, but I would not like to perform it on a younger patient because he has a lot of life to lead, and if you occlude one of the vessels, it's possible that he can, because of high pressure, he can develop aneurysms on the side which is not occluded. Bypass and clapping and other procedures like wrapping and aneurysmography are also examples. Simple video about an aneurysm, an anterior communicating artery aneurysm, which has been clipped here, and which is also confirmed on indocyanine angiography that the perforators are not clipped along with the aneurysm. Similarly, a middle cerebral artery aneurysm, for lack of time I am skipping this video, and I will go to the endovascular options which are available. Earlier, when you think about endovascular options, it used to be only coiling. So, but now, wide neck aneurysms also can be coiled with assistance like balloon assistance, stent assistance. There are devices called the PCONS, common etching, other devices which help you retain the coil mass into the aneurysm without any major issues. Similarly, current artery occlusion also can be performed on endovascular options. Other treatments like the flow diverter and the flow diverters are actually revolutionized treatments for giant aneurysms in the cavernous ICA or the basilar top and stuff like that, where people would do a lot of complicated bypasses and then used to treat those aneurysms. These are revolutionized the treatment in these aneurysms. Similarly, in patients who have got mycotic aneurysms which have not responded to antibiotic therapy or which are repeatedly rupturing, we have liquid embolic agents as well. So this is a fairly straightforward case of a posterior communicating artery aneurysm, a narrow neck, and this was treated with coiling, balloon assisted, because we have to preserve this posterior communicating artery, and by inflating a balloon to this level, you could manage the coil mass stops short of the parent vessel. This is an aneurysm, a basilar top aneurysm, a symptomatic aneurysm. If you look at on the previous images, it looks as though there are no vessels arising from it. Here you see the vessels arising from the aneurysm sac itself. Do we have to treat this in the first place? Again, the question. So most of us agree that it has to be treated. Secondly, how do we treat it? Is surgery an option? Probably I would not consider surgery an option because there are better endovascular techniques. But as you know that, as you see that the neck is pretty wide neck, and the second thing is you need to preserve the parent vessels as well. So this is a technology available wherein it's inspired from nature actually. The flower, this device opens like a flower into the aneurysm. It holds the coil mass, and wherever you need to keep this device so that the parent vessels are preserved, you can keep this device and then finish the coiling. So this was what was performed here. There are some markers of this device here, and we know that the small neck is revenant, but then that can be followed up as the patient comes later on. This, if it comes as an incidental aneurysm, would you treat it? Probably I would not treat it if it comes as an incidental aneurysm, but this is a ruptured aneurysm. And if you see that there is no definite neck, we don't know which part is ruptured. And you can see two main, the posterior cerebral arteries as well as the superior cerebral arteries coming from the actual dome of the aneurysm. So probably if it was 10 years back, you wouldn't have probably done anything about it. But today, we can put two braided stents as a white, and then you can see that the follow-up, the shape, the morphology of the aneurysm has adapted to the stent, and the risk of rupture is reduced. Giant aneurysm, cavernous IC aneurysm, if it is incidental, probably you can follow up, but this patient has had a third nerve palsy, so we have to treat it, and surgical option probably is a little bit more complicated. So the other option is the flow diverter and coils, and you see that 6 months follow-up, the aneurysm is totally excluded from the circulation. Another patient, 55-year-old patient, again symptomatic aneurysm. There are challenges here. One is the tortuosity. You can see that it's not a straight thing, there's a U-turn, and there's a narrowing as well proximal to the aneurysm. So negotiating this curve, probably 10 years back, the catheters were not so good. You had to perform direct carotid puncture or something. But now, with the available catheters, even this U-turn, you can negotiate and go ahead, do the angioplasty and finish the procedure with good results. Now this is a patient with another giant aneurysm. Giant aneurysm, the classical teaching is you do a cross-flow study. If you have a good cross-flow, you have to do the parent vessel, provided the patient is above 50 years of CCS, because young patients you don't like to put vessels. So this patient again had a balloon occlusion test in the presence of electrophysiological monitoring. You can see this electrodes, electrophysiological monitoring electrodes placed on the skull. We waited for 30 minutes, did a hypotensive challenge. The crossflow was still maintained. There was no drop in the electrophysiological potentials, and she underwent a parent vessel occlusion with coils here. The same parent vessel occlusion can be done surgically, but then if you have to do this parent vessel occlusion, you have to occlude both in the neck, as well as do a craniotomy and then occlude it in the, even because there can be a retrograde flow and then filling of the aneurysm. But this was done simply with the help of coils. So this is a patient again with a, it looked like a mass, he had a gait disturbance, a mass compressing on the brainstem, calcified wall, a fusiform aneurysm of the basilar artery. A telescopic stents were placed, and the aneurysm is excluded from the circulation. So sometimes you do a very good job with surgery or endovascular treatment, but still you find that the patient doesn't do well. Because all of us know that in ruptured aneurysm there is a scenario called vasospasm, which can kill the patient and which can bring down your morale literally down, because you might have done a good job, but then patient deteriorates. So this is a patient who underwent coiling. She had vasospasm. We gave intraarterial nimodipine. The vessels though not normal, but on transcranial Doppler, the velocities were coming down and clinically she had improvement. So this is another aspect of endovascular treatment where you can treat vasospasm as well. This patient, anterior communicating artery aneurysm, also was in spasm, but we went ahead with coiling. We also gave an option of clipping, but the patient preferred coiling, because ideally in ACOM aneurysms we try to clip if there is a hematoma and stuff like that. But after pneumodipin therapy, the vasospasm resolved and she improved clinically, and she was discharged in 15 days time. 10 days later, she had presented to another hospital with headache, and the scan shows that there is a rebleed with hydrocephalus. And we see that in 20 days time, there is a recanalization of the aneurysm. So aneurysms are not always because of the pathology in the vessel, but it's also the aneurysm sac. This is a type of pseudoaneurysm, I would put it, because it had grown so fast in spite of coiling. And then this patient was again offered surgery as an option, but they chose endovascular option, so coiling was done. But then by the time there was diffuse cerebral edema and she did not make it. So the take-home message for treatment of aneurysms is, there are some patient characteristics you have to look at, there are some aneurysm characteristics you have to look at, there are some operator or the surgeon or endovascular the technical team's characteristics you have to look at, and there are also the institutional practices you have to look at, in addition to the actual what is described in the guidelines. Similarly, volume counts, because the center which is going to do, even in literature it is described that when you do aneurysms of more than 35 to 40 cases per year, the results are going to be definitely better than doing a less number of cases. And most importantly, teamwork enhances. Always partner with your other departments instead of competing with other departments to say that you are better than the other department. That's where hybrid neurosurgery comes into existence. The bias is totally eliminated. This is another important thing which is not discussed in many forums, carotid revascularization. And the literature states that anything more than 75%, the risk of stroke is high, and with ulceration it is going to be higher. And the carotid stenosis with TIA definitely needs to be treated. So the literature states that if you have a stenosis 70 to 99%, the chances of developing a stroke is around 16%. And if you treat these patients, the reduction in stroke when you treat these patients is 16%. And more so in patients more than 75 years and perform within 14 days after the last ischemic event. This timing is very important, 14 days. Some papers say up to 30 days that after the last ischemic event you can perform. Thereafterwards, you don't have a great advantage of performing operation or stenting in these patients. So in carotid revascularization, there are 4 questions to address again. What is the imaging modality of choice, which has been described extensively by Dr. Komal? When do you intervene, which I've answered earlier, about how early do you intervene in such patients? And what is the ideal treatment of choice? We have a gold standard called endarterectomy. We have another procedure called carotid angioplasty and stenting, which is non-inferior to endarterectomy when selected appropriately. And the technical aspects like anesthesia, use of a shunt or a filter, and choice of stent is also important. When you look at a report, you have to see that what is the type of, when you see the percentage of stenosis, we should see how have they estimated the percentage of stenosis, because it is only not the number which is important, as Dr. Komal told, it is also the flow velocities which are important. The plaque morphology is equally important when you decide about stenting or endarterectomy. It has been shown that this is a paper which says that up to 1 month you can perform these procedures. So the numbers don't matter. What is the conclusion is you have to intervene anywhere between 14 to 30 days from the time of last event if it is a major stroke. If it is a minor TIA, I do intervene within 48 hours as well. So the flow charts are extensive, but these are very confusing, and like I said, I'm not going to go into the flow charts because every patient is different, and you have to look at so many factors when you treat these patients. So when you compare endarterectomy and stenting, cumulative analysis has shown that carotid stenting is non-inferior to endarterectomy, although endarterectomy is the gold standard. Let me look at some of the case examples. A 52-year-old diabetic, hypertensive, chronic smoker with left-sided weakness, MRI showing this embolic episodes, and then you see an ulceration like this. Ideally, I would try to do an endarterectomy in this patient, but this patient was, they were dictating terms rather with me, so I had to go ahead with the choice of the patient. But then I know that this is, when I'm passing the wire itself, this can embolize. So I had to use a filter, though I don't use filter in every case of endarterectomy, but here I had to use a filter. The second thing is it is an extensive long segment stenosis. I know that placing 2 stents has got a higher risk of thromboembolic episodes or restenosis, but since patient was very keen that he didn't want a neck open, I had to take all these precautions, went ahead with the procedure, and you can see the amount of bad ulceration of the plaque which gets caught in the filter. So that is the importance of using filter in selected cases. When you do an endarterectomy, you clamp the vessels, you are more secure. Whereas here, unless you plan your procedure properly, it can have devastating complications. Another case of 68-year-old diabetic hypertensive with right upper limb transient weakness. Again, you can see the strokes in the MR. This is a bad stenosis. And luckily, I could convince the patient that I would do endarterectomy only in him. And so this is the procedure of endarterectomy. I've pictured it in the presentation. You clamp the carotids, and then you can see the amount of plaque you are removing from the carotids, and then you close the vessel back. The advantage of endarterectomy is you can probably give a single antiplatelet for a shorter duration and then look at the risk factors and following up later on. Another illustration of a 28-year-old male where Dr. Komal has already shown some floating thrombus examples. So this patient again had an embolic shower. From if you see the MRI, it will look as though it is looking fine, but if you look closely over here, it is not completely smooth. There is some kind of a grayish thing over there. So you don't rely only on ultrasound or CT angio images for carotid disease. You have to rely on Doppler, and the Doppler should be preferably performed by the person who is going to do the treatment. But then we have a good radiology team. We rely on them for the reports. If you see the report, you see the carotid Doppler. I mean, this is the MR angio report, the axial sections. You can see that there's an eccentric plaque over there. And on the Doppler, it was a floating thrombus. So floating thrombus, like Dr. Komal said, you have to stabilize initially for the first few hours, but then this patient was flowing embolic shower, so we had to take him up for a procedure. I did this procedure under awake anesthesia. We had a superficial cervical block given by the anesthesiologist. With the patient awake, we can perform these procedures if he is cooperative. And this is the clamping, and this is the floating thrombus we could get out. And if you see, it is not actually a red thrombus. It is more of a fibrotic material, which is probably a dissection which has healed and then left, something like that. Cases like this, where there are bilateral stenosis, I would not dare to do an endarterectomy because clamping can cause so many hemodynamic changes. So I went ahead with the staged stenting in these patients with 3 weeks interval, and he is doing pretty well. This is something which no one would like to touch as a surgeon because the post-radiation stenosis. You can see the amount of stenosis and the extensive surgery and dissection which has been performed post-radiotherapy, and then stent has been deployed. What is interesting to note is that the stent is not fully expanded to its capacity, because if you try to do that, the vessel is going to tear. So whatever is optimal for that particular disease, you have to choose, and then this is a suboptimal angioplasty and stenting, but that is more than enough to take care of the vascularity for the brain. So this is a patient with a, I would say, a petrocavernous junction symptomatic stenosis, a straight segment, relatively best medical management tried, but still he had recurrent episodes of stroke and stented. And this is another intracranial stenosis. He was also on best medical treatment, young patient, 35-year-old, and he was, in spite of treatment for the procedure, he was showing multiple TIAs. The 3D reconstruction was helpful here. The whole purpose of this is to show on the imaging, on the MRI, it looked as the stenosis was over here. But the actual stenosis is beyond the bifurcation at this level. So if you stent only this segment, you are not going to treat the stroke at all. So such patients, this patient probably was suspecting vasculitis as the underlying pathology, and though none of the reports came out positive, when you do a bypass in such procedures, they're not going to last longer. So we went ahead with angioplasty and stenting, and he continues to do well during the 1 year follow-up. Finally, the vascular malformations. Again, the natural history. After the Aruba trial, the number of cases of AVMs being treated, when they are asymptomatic, have drastically reduced. The annual risk of rupture is somewhere between 2 to 4%, and if they rupture, the first year risk is around 6%. Thereafterwards, it continues to be in the natural history range around 2 to 4%. The morbidity around 30% and mortality of around 10%. And the risk factors, it's very important to see who is at high risk of rupture. So presence of intranadal aneurysms on the angiogram, if there's a deep venous drainage, or if there's a stenosis on the venous outflow side, these are signs that it's going to rupture. Again, on AVMs, if the patient is having only seizures or headache, you can always manage them conservatively, provided you don't have any of those angioactive features which are at risk of rupture. If the patient has bled, you can manage it surgically. Embolization is an option where the bleeding is not too high and medical treatment is not giving him significant relief of his symptoms. Radiosurgery is an equally good modality, and sometimes you can use multimodality therapies, as I will show now. This is a patient with a posterior fossa AVM. He has gait disturbances. Because it is superficially located, straightforward case. You can see that the nidus is being dissected out. The most important step being controlling the feeders. The draining vein should be clipped or removed at the last. That's the draining vein being coagulated and the nidus being removed completely. This is a patient who had a symptomatic, he was symptomatic both for headache and seizures, but his headache was not resolved in his medical treatment. He was convinced that he needed some alternative form of therapy. Because there is a single main feeder, probably another minor feeder, it is a straightforward case for embolization. And post-embolization, you can see the difference. This is a patient in an elephant area AVM. He was also symptomatic, and then he underwent a stereotactic radial surgery. And post-SRS, 2 years post-SRS, you can see the difference in the nidus. Not all cases look so attractive as what is presented here. There will be some complications here and there, 5 to 10% risk, but overall complication risk should be less than the natural history of the disease. That should be aim of treatment. So the other 2 cases I will be showing in the form of spotters. Post-traumatic, if this patient comes, what do you suspect? Yes, a keratoconus fistula. When we do the carotid arterial injection, you see that there is no intracranial flow on this side. It's all going to the venous sac. So where is the right hemisphere filling from in this patient? You can see that there is a good collateral, but there is also filling of the fistula. Generally, you would think of doing a parenteral occlusion in such cases, but if you observe the parenteral, there is a more likelihood that it can fill retrograde and the fistula can still persist. So this is a diagrammatic representation of what we did. We know there's a big tear. It's a direct type of fistula. We just put a covered stent across the defect, or we can go inside and coil. This patient, it was a straight segment vessel. We put in a covered stent. I will not go into the technical details. Let me show the pre-op and post-op images. Yeah. So this is the pre-op image and this is the post-op image. You don't see any ophthalmic artery over here, but towards the end you see the ophthalmic blush. So here visual symptoms, visual deterioration. But following treatment, there was restoration of vision in him. Similarly, there was no flow on this side before treatment, and you can see that the flow has been established following treatment. And there is no other way of treating the CCFs. Earlier they used to, age old days, they used to open the neck and put in some silk particles. With flow, it used to go and occlude the fistula spontaneously, but now we have better options. So this is the pre-treatment, post-treatment images. And this is another spotter. What is this? It's a vein of Galen malformation. Endovascular option is probably the ideal option in these patients, provided the child has got adequate development, the child should tolerate anesthesia. There are so many challenges when you take up these children for endovascular because the amount of contrast, the hemodynamics which changes drastically after occluding such a high flow fistula. So you need a good anesthesiologist who can support you during these procedures. So this child underwent endovascular embolization. Just 1 ml of liquid embolic agent can occlude this fistula. You don't have to go and coil the whole sac. Just stay proximal to the sac, use a balloon guided control, and then 1 ml of glue can cure this fistula. So that is the beauty of endovascular procedures when selected appropriately. I have not covered this spinal vascular malformations. Bypass procedures have already been discussed. So the summary is, neurovascular surgery is like walking a tightrope. It has a long learning curve, and we need to collaborate with other departments to have good results. The decision making is not purely based on guidelines as described in literature. It is individual based and institutional based, and also the choice of the patient and family. And thanks for your kind attention.
Thank you for an excellent talk, Rajesh, and a lot of illustrative cases as well that you have done. And as the way ahead is like, as you said, it's the hybrid neurosurgeons and as well as the hybrid neurologists, right? Because no one should be pushing the envelope, neither the interventionist nor the surgeon. But at the same time, the surgery is getting more and more complicated because the hybrid neurosurgeon has to be very thorough and will be at ease with doing bypasses. That's the only way forward. So having said that, I'll open it for the discussion. Any questions? Yeah. So I have one of the cases that you have shown, like, the carotid occlusion. So the carotid occlusions, I mean, whether 60 years, 30 years, like, I mean, still like there is a chance of 14 to 25% chances of stroke, like, I mean, various series. So still, I mean, would you consider a bypass and then do an occlusion? It's like this. That's an unpredictable thing. Patient may come up with an immediate stroke. He may come after 4 days, and balloon occlusion test is being very unreliable, like, in those cases. So how do you ensure that you have a surety of reliability of your balloon occlusion?
So when we consult the patient, we tell them that the balloon occlusion test, even if it passes, there is a 20% risk of stroke procedure period anytime. And when we do the balloon occlusion test, we monitor the electrophysiological, we do the electrophysiological monitoring, and we do hypotensive challenge as well. We drop the blood pressure by around 20% from the baseline to see if the collateral is still maintained, and the electrophysiological monitoring doesn't show any drop in the cases. So that way we are gaining another 10% additional advantage. But still, like you said, destructive procedures preferably better to avoid. But this patient understood the risks, and they agreed for the procedure.
Most of the strokes are a little after 48 to 72 hours. It's nothing on the day. And other thing is the vasospasm, which is a very big challenge, like, I mean, heating. So, what is the literature? Because most of the, we have, and probably a lot of centers have tried this nimodipine. It opens up beautiful radiological images to absolutely fantastic. But the patient comes back and he has rebound vasospasm. So, and severe vasospasm, I mean, everything has uniformly failed. Because when I saw it, like, even in best of the centers, when I did my fellowship in Canada, I did a couple of months of rotation in neuro intervention. So even everything that has been from oxygen brain oxygen monitoring to saturation monitoring, everything. So uniformly, a severe vasospasm, everything will end up like having a very in a vegetative state after that. So how has been your experience in that?
Yeah. So when we say vasospasm, we say there's a clinical vasospasm. You may not have anything, you may not pick up something on the transcranial Doppler because it could be at the level of the microcirculation, which is different from the vasospasm in the larger vessels. So larger vessel mass vasospasm, the earliest way to pick up is to do a transcranial Doppler monitoring in the ICU. And if you find that the velocities are increasing, if you can intervene within the first, and if it's going to be focal in one territory of the brain, it definitely responds to intraarterial nimodipine injections if you intervene as early as within 2 to 4 hours from the time of picking up the vasospasm. On the other hand, if you delay it by 24 hours also, we have found that injecting nimodipine is of no use. Similarly to the focal vasospasm in one territory which is not responding to nimodipine, then angioplasty does help. But like you said, global vasospasm is another entity which doesn't respond, which is quite refractory, and then probably doesn't respond to any of the treatments. So it depends on what variety you're looking at.
The moderate one, I mean, ultimately whether you treat or don't treat or just maintain the hypertension therapy, they'll come back to normal. So we haven't found, I mean, we got a lot of enthusiasm when I came back and we started doing a lot of nimodipine infusions, and none of them we haven't seen really benefit. And even the literature as well is very skeptical about these injection nimodipine infusions. Intraarterial. Yes, exactly. Not
I have probably given for around 14 cases, out of which around 70%, because the timing was appropriate, they did pretty well. So that's my experience with intraarterial. I found that the timing is very crucial. How early you go in and give the nimodipine.
And what other measures you had?
Apart from nimodipine, we have used milrinone infusion. Sometimes we even a microcatheter we give milrinone infusion, or sometimes milrinone is given intravenous as well. And then usual tutelage therapy, but again there's a controversy whether
I mean, no, it's not tutelage. It's only hypertension or hypervolemia.
And in acute SHs, we find that even with spasm, you give nimodipine infusion for say 15-20 minutes, you wait. The vessel opens up. If you treat on the first or second day of SH, or when the third day SH patient comes, on table we find there's a lot of improvement in the vessel diameter. But how much it translates clinically, it varies from person to person.
Because I have seen like catheter being kept in mineral infusion being continuously given antibiotics and everything. So still, I mean, it has not been so much helpful in a way. So I've seen centers where completely shifted to just hypertension, that we without much injections and all.
Yeah.
So I'm kind of very skeptical about that pneumotherapy.
Yeah, I'm not in favor of continuous infusion because managing that is very, very difficult.
Yeah, it's difficult, but I mean, there are centers who are able to taking that pain to May. Still, I mean, there's not much. It's still a very formidable challenge treating vasospasm. So anything else?
My experience had 4 cases. One patient had a proper hemiplegia with diffusion restriction was picked up within 2 to 3 hours. Only 4 patients with one patient he has witnessed also.
That happens even spontaneously without pneumotherapy infusion by being the hypertension. So the pneumotherapy therapy is something, I mean, which is useful. Is a very big question. Like, I mean, that's the literature. I mean, on these things even have not been. A lot of centers have done away with it. So there are centers who just shifted. Like, I mean, there's varying opinion across.
What I meant to say, my experience only 4 cases.
No.
All these 4 cases were done without delaying for one. Delaying was saying that once you do it, early the results are better. What we routinely do is we use the triple therapy for 6 hours, 12 hours, 24 hours. When that fails, we try to go into pneumotherapy.
No, that's right.
But
the
my
early
experience
pickup is the one. As you said, Doppler is one of the methods, and the other one is doing a CT angio and immediately trying to constant those things. So that's the one. So you are more. Are you kind of like pushing your things? I mean, Doppler is not very inconvenient. Sometimes having complicated, someone may be picking it up, someone may not be picking it up. So what is the next modality? You go for orbital angio, or you are going for CT angio, or CT Parkinson's things?
I don't go for the perfusion. I take for the benefit of doubt, I take to the cath lab and give the infusion. And it is given on a daily basis for 5 days.
Yeah, that's right. So that's
There are 2 things. One is the triple H therapy is gone. Okay, there is nothing like triple H now, it's abandoned. If you say triple H therapy in 2023, I think people might laugh at us. Number 1. Number 2, see, many patients they respond with intravenous intraarterial nimodipine milrinone. The patients who have not responded, see, studies have shown that it is not just vasospasm. The vasospasm could be because of the vessels being dipped along with the blood and all. But studies have shown that these vessels, they can be endothelial proliferation. They can have a very rapid endothelial proliferation. There will be an internal thickening. So those are the patients. In fact, that proliferation can happen within 3 to 4 days. Studies have shown in postmortem studies also. So those are the patients who do not respond with whatever measures you do. The vasospasm, nimodipine, milrinone, and all that. So that is the thing. So not all patients SAH are not happy patients. So they do not respond with nimodipine or milrinone because there are a lot of dynamics which are happening there.
Targeting that, like silastazole, everything has been tried.
Yes.
Uniformly, like everything has been a failure. So vasospasm is still the biggest challenge. If oil, clip or anything, like I'm still, you are very varied to the last
Sometimes some patients can have what is called malignant endothelial proliferation starting from day 2, day 3.
The patient suddenly becomes, I mean, from talking patient suddenly becomes the kind of brain gets state. Anyway, I mean, as I said, like, I mean, the hybrid neurosurgeon is the order of the day. And in the best interest of the patient, I think the neurologist and neurosurgeon should be led by the neuroradiologist rather than taking it. Because at the end of the day, who does it? It doesn't matter for anyone. The patient is, no one is pushing the envelope, they have to be checks and balances on both sides. So that's the only way to do it. The same thing happens probably with stroke. And we have to see more and more neurologists like being in the lab. And that's probably the future way of like evolving any kind of stroke teams or any vascular teams.
In fact, it is quite encouraging. Today actually we have seen one neurologist talking about intervention, neurosurgeon talking about intervention. It's quite heartening to see. Because many times we are in the hands of radiologists and then we take decisions, sometimes it should be irrational actually. They do just angios just for the sake of it. And then they stunt the patients with 30%, 40%, I don't know, for benefit they have in mind.
A lot of things happen. Once, I mean, you are only one-sided like
So as a clinician, I think we are the ones who see the patient from the day 1 and then see the patient till follow and until the patient gets discharged. So radiologists, they don't have any hold on the patient, isn't it? They don't know what's happening. It's quite convincing and quite encouraging to see a neurologist and neurosurgeon talking about intervention and then quite satisfying actually.
No one is respiratory is what. So it's ultimately like, I mean, it's finally the patient is served better than what they usually do. That's it. And thank you, and we congratulate you on the work,
Thank you, sir. I now request Dr. Vamshi Krishna, sir, to felicitate Dr. Rakesh Reddy, sir, with bouquet and a momentum. I would also like to request Dr. Srikanth Reddy, sir, to felicitate Dr. Vamshi Krishna, sir, with the bouquet and a momentum. The next topic for today's evening is highly active or malignant multiple sclerosis. I request Dr. Srikanth Javalkar, sir, consultant neurologist, Care Hospital, to chair the session. The speaker is Dr. Hari Radhakrishna, sir. Due to shortage of time, instead of a tea break, we have a working tea coffee arranged. So please be free to pick your coffee and join the sessions right away.
షూట్లో ఇక్కడ బంజారాహిల్స్ షూట్లో లేదు ఆ షూట్లో ఉన్నాను నైట్ అవుతుంది అదే కాక మరి ఎల్లుండి నాకు సర్జరీ ఉంది ఇప్పుడు లేదు ఆరోగ్యశ్రీ కార్డు అవి తీసుకోవాలి పెట్టుకున్నాను ఆరోగ్యశ్రీ కార్డు అవి తెచ్చుకోవాలి నేను అక్కడ రేషన్ కార్డు ఎల్లుండే కదా అసలు టీవీ కొన్నందుక అక్కుందా నేను ఫోన్ చేస్తాను
For the delegates, we are almost coming to the last part of the program. I think this is probably the last lecture from a neurologist perspective. And so I'll be talking on multiple sclerosis. This topic is not covered in the past few lectures. As you have heard in the earlier lectures, the concepts have been changing, and in the olden days we used to think there was no multiple sclerosis at all in India. Nowadays we are seeing more number of cases and more complicated cases, and this is one of the complications that I was actually not seeing. I've seen first time only 2-3 years back only this kind of highly active multiple sclerosis. So I got interested in that topic, and I thought I would share my views and my thought process with you. Nearly 80% of the multiple sclerosis patients have relapsing remitting course. Progressive course occurs in nearly 50 to 20% of the onset. And these progression can be primary or secondary. So 10 to 15% belong to primary progressive multiple sclerosis category. And there's disability and disease, both are different. Disease can progress without disability being progressive. Plaques may increase in size in the MRI, but still there may not be any clinical signs. And disability can progress without there being relapse, and maybe due to poor recovery from the whatever already happened, or complicated by falls and spasticity and other complications and dystonia. And this is a course pattern. Was earlier, this is an older classification, I think 1996, relapsing remitting MS, primary progressive MS, what you have seen, secondary progressive, and progressive relapsing. These are the 4 types that were described earlier in 1996. Now there is concepts of changing. As we go further, we'll see the newer classification. Progression and relapse. Progression is the objective evidence of neurological deterioration on 2 visits, at least 6 months apart, in the absence of a relapse. There being no relapse, still it is progressing. Indicates neurodegeneration predominantly, with inflammation along the margins sometimes, not always, and resistant immunosuppression. Any amount of immunosuppressives or immunomodulators you give is not going to be effective. And relapse is a new or worsening neurological symptom of CNS dysfunction, showing at least 2-grade increase in the EDSS score. In 1 or 2 functional scales lasting for 24 hours or more in the absence of fever, indicates predominant inflammation, and it may respond to one kind of treatment or other kind. It's not mandatory that it should respond to only one variety. So it may be different varieties of treatment we need to say. This is the new framework for classification of ECTRIMS, European Committee of Treatment and Research in Multiple Sclerosis. Relapsing limiting MS, RRMS, active and inactive. Similarly, PPM MS, again active and inactive. And what is activity, what is inactivity? Inactivity, of course, you all know what is activity, that we'll know in the next few slides. And SPM, secondary progressive MS. And then clinically isolated syndrome is now being conferred the status into multiple sclerosis. And radiologically isolated syndrome, I think all of you know this, only radiologically you say, clinically there is no correlation. So activity can be clinical or radiological. Clinically there could be relapse, or only radiologically there can be progression. And radiologically active lesion means a new lesion compared to earlier scan. So you compare 6 months apart. And increase in size of a pre-existing lesion and contrast enhancing lesion. So these are the different, there are many definitions coming out. And this is one new term which is actually quite old, 2010. Blue Book of Neurology has described this. This is not being used nowadays. Catastrophic multiple sclerosis. And where there's market worsening, rescue therapies were used. There are type 1 and type 2. Type 1 is from 0 to 3 weeks to 3 months. And type 2 is 3 months and to 6 months. So in type 1 there is acute attack developing over days to weeks with major disability and not responding to steroids. And here you have to exclude other conditions like NMO or acute disseminated encephalomyelitis or Marburg variant, so other varieties of multiple sclerosis or other demyelinating disorders. The treatment of first choice would be therapeutic plasma exchange and followed by mitoxantrone or mitoxantrone combination. And type 2 where therapeutic plasma exchange is not the first choice. And there, the rapidly worsening disability with superadded relapse over 3 to 6 month period. Here, the mitoxantrone and mitoxantrone is the first choice, followed by cyclophosphamide. So, malignant multiple sclerosis is another term, fulminant multiple sclerosis is another term. There are so many terms which are being used vaguely, so we are still not sure where we are, what kind of terms we use. The current terms now, what we are using is highly active multiple sclerosis. Malignant multiple sclerosis, most extreme variant of multiple sclerosis is rapid progression and significant disability. But the definition is very vague. How rapid does it progress and how much disability does it produce? Mostly decided retrospectively, hence the term is to be used very sparingly, in fact better avoided. So generally presents as monophasic illness, just like acute disseminated encephalomyelitis, and with very little recovery and there result in death, and also described as Marburg variant or Schindler disease. These two diseases, Marburg disease, actually we don't see in India. This most severe variant can be called malignant or fulminant or pseudotumor form of multiple sclerosis with high morbidity and mortality within weeks or months. And first discovered named after Marburg and not seen in the only case reports are included mitoxantrone, however most of the cases end in death. Yeah, this is the Marburg disease. Like a tumor, you can all see the mass effect. Generally, demyelinated lesions do not produce mass effect. You can see the mass effect and you see the midline shift also. And this patient ended in death. And the Schindler's disease is another variant, which is again, similarly younger patients will have multiple pseudotumor like radiological picture, clinically it can be seizures or hemiparesis or other disabilities all put together. They are also not survived. They are all very severe variants of demyelinated disorders. So this highly active multiple sclerosis is now what we are trying to address. But here again there is a competition for this term by a term called aggressive multiple sclerosis. So what is aggressive, what is highly active? This also we try to see in the next few slides. Other times for malignant multiple sclerosis, Parkinson's, MS are used in the past. So the definition used are 2 or more disabling relapses in the past 1 year in spite of disease modifying therapy and progressive disease reaching EDSS score of 6 within 5 years.
I think those who have worked with me might have seen that patient who have been following, and he is having 2 or 3 episodes in the same year. Now resistant treatment going on and coming back from Vizag. So here there are some factors which can identify, predict at least, though it may not always be true. The epidemiological factors: females, slightly good prognosis; male, bad prognosis; and similarly age less than 40 years, good prognosis; at onset, more than 40 years onset is bad prognosis. The first relapse is monofocal, only either optic neuritis or hemiparesis or ataxia or INO. Then it is good prognosis. See, multifocal, multiple areas the neuritis is getting affected, severe. And sensory and optic neuritis have got good prognosis. There is motor weakness, cerebral involvement, and cognition. Affecting cognition also is a bad prognosis. And full recovery is good prognosis with a favorable feature, residual deficit left behind, and ultimately building up to become the relapsing remitting multiple sclerosis course is a bad sign. And time to second relapse, longer time, good prognosis; shorter time, and patient is a bad prognosis factor. And relapse rate, higher relapse rate is again bad prognosis factor. So these are all pointers. The other side, what you are finding here, the other side, what you are finding are they are the bad prognosis factors. Sometimes there will be mix up of both the things. And time to EDS is 4 or 5. It takes long time in good prognosis disease, whereas shorter time to progress is the bad prognosis. And MRI, high MRI lesion load, and here we have the low MRI lesion load, number of lesions the counts. And similarly, contrast enhanced lesions, if they are present, more dangerous is the disease. So one must remember that MS is a lifelong disease with unpredictable course. At the same time, we have also seen patients who have started progressing further, no further relapses, and we have seemed to have completely stopped the progression. And even I also have stopped 1 or 2 patients of the disease-modifying therapies. So even according to literature also, 5 years if there are no relapses and more than 40 or 50 years of age, you can also, if there are no relapses, you can also stop the treatment. There is no generally accepted definition of highly active multiple sclerosis. And these are the other terms: aggressive multiple and multiple sclerosis, catastrophic multiple sclerosis. So before going further, I think we must also understand some of the points in this expanded disability status score. This is only expanded one. Earlier one we had only one, level 1, 2, 3, 4, 5 like that. Now it is 1.5, 2.5, this also added, that is the expanded version. Level 1 has no disability, only signs, some hyperreflex may be there or maybe there will be RAPD. And level 5.5 can walk up to 50 to 100 meters, and beyond that he requires assistance. Level 6 patient requires a stick or a crutch or a walker, and level 7 patient requires a wheelchair for most of the time. 8.5 is restricted to bed, and 10 is death secondary to MS. So 8 functional subscales are there, any of which most of the time we have measured the cerebral or cerebellar one. The bowel, other things also may have to be counted. And in every visit, we assess the TDSS score.